लॅटिन शब्द त्याचं नाव आहे बॉडी, इट्स अ सॉईल. आणि म्हणून ज्यावेळेस एखाद्याच्या अंत्ययात्रेला आपण जातो त्यावेळेस महाराष्ट्रामध्ये मराठीत म्हटलं तर कुठे गेला होतात, मातीला गेला होतात. म्हणजे त्या बॉडीचं तुम्ही मातीच म्हटलं जातं. ती बॉडी एलिमेंट्स आणि विटॅमिन्स मिनरल्सनी बनलेले वगैरे 5 एलिमेंट्स. आणि बीइंग म्हटलं की ते येतं सोल. इट्स आपण काही आत्मा म्हणतो, कोणी प्राण म्हणतो, कोणी शक्ती म्हणतो, कोण जीव म्हणतो, कोण श्वास म्हणतो. तर अशा प्रकारे ते केलं जातं. म्हणून माइंड बॉडी मेडिसिनमध्ये आपण पहिले बघूया बॉडी, जी मगाशी म्हटलं मी 5 एलिमेंट्स. अँड आयुर्वेदाप्रमाणे पण आपण शरीरातले 3 दोष सांगतो, वात पित्त आणि कफ. होमिओपॅथीमध्ये सोरा सिफिलिस सायकोसिस असं म्हटलं जातं. हे झालं बॉडीचं. आणि माइंडबद्दल काय तर माइंड इज अ टीम वर्क. जस्ट एज अ टी फॉर थॉट्स, ई फॉर इमोशन्स, ए फॉर ॲटिट्यूड अँड एम फॉर मेमरीज. ह्या चारीचं हे करून ज्यावेळेस आपण जगतो त्यावेळेस वी आर ॲज अ ह्युमन बिईंग विथ सात्विक, राजसिक आणि तामसिक स्टेजेसमध्ये जातो. इन आवर क्लिनिक ज्यावेळेस तो पेशंट येतो आणि आपण ट्रीट करतो त्यावेळेस तो ईजमध्ये गेलेला असतो. डिसीजमध्ये येतो आणि तो होतो ईजमध्ये. आणि ज्यावेळेस तो ईजमध्ये न होता डिसीजमध्येच राहून काही कारणाने आपण डिक्लेअर करतो की ही इज नो मोर. मग त्यावेळेस राहते काय, आपण काय सांगतो, काय घेऊन जा तुम्ही, डेड बॉडी. येताना त्याला आपण पेशंट म्हणून सांगतो आणि जाताना तो बॉडीमध्ये असतो, म्हणजे परत बॉडीच आली. ॲज सेज माइंड कंट्रोल्स बॉडी, है ना. माइंड जर तुमचं जसं असेल तसं बॉडीला कंट्रोल केलं. तर कालच्या लेक्चरमध्ये पण तुम्ही ऐकलेत, बऱ्याच जणांनी ते सांगितलं की तुम्ही काल शेवटच्या ओरेशनमध्ये पण होतं की तुम्ही काय खाताय त्याचा इफेक्ट तुमच्या मनावरती, तुमच्या बुद्धीवरती होत आहे. मग माइंडच्या हिशोबात तुमच्या बॉडीवरती त्याचा परिणाम होतो. अँड वी हॅज टू ट्रीट पर्सन होल, नॉट द बॉडी. फक्त बॉडी ट्रीट नाही आपण करायची आहे, तर आपण माइंड अँड बॉडी. इन माइंड वी हॅव 7 व्हॅल्यूज अँड दे प्ले अ रोल टू कंट्रोल द बॉडी. जसं की पहिले व्हॅल्यूज आहे लव. आणि ज्यावेळेस आपण एखाद्याला सांगतो की आय लव्ह यू त्यावेळेस मध्ये सिम्बॉल काय टाकतो आपण, हार्टचा टाकतो. त्यामुळे लव कनेक्टेड टू सर्क्युलेटरी सिस्टीम आणि त्यावेळेस हार्टवरती परिणाम होतं. आणि त्याला आपण इंग्लिशमध्ये बऱ्याचदा आय इल म्हणतो, ILL, आय लाईक लव. दिल के तुकडे 1000 हुए, कहा यहाँ गिरे वहाँ गिरे वगैरे. तर हे लव मध्ये तिथे येतं. दुसरं आहे व्हॅल्यू पीस, शांती, है ना. ज्यावेळेस आणि शांती ही जी आहे ती रिस्पिरेटरी सिस्टीम कंट्रोल करते. अस्थमाचा पेशंट ज्यावेळेस आपल्याकडे असतो त्यावेळेस काय असतो, तो बेचैन असतो, रेस्टलेस असतो. त्याला आपण सांगितलं झोपून जा, मी तपासतो, तर तो म्हणतो मला झोपता येत नाही आहे, श्वास घ्यायला त्रास होतो, है ना. आणि दुसरे एक महत्त्वाचे की व्हेन एनीबडी डेट्स और डिक्लेअर्स डेथ त्यावेळेस आपण लिहिताना श्रद्धांजलीला काय लिहितो इंग्लिशमध्ये, RIP, रिप इन पीस. म्हणजे त्याच्या आत्म्याला शांती मिळावी ह्या करताच म्हटलं जातं. मग पीस आणि त्याचं काय गेलेलं आहे, ज्यावेळेस डेथ झाले त्यावेळेस काय संपला आहे, श्वास, है ना. म्हणून कनेक्टेड पीस टू रिस्पिरेटरी सिस्टीम. तिसरा आहे हॅपीनेस. 2026 रायकॉन कॉन्फरन्समध्ये सर्वजण त्या आनंद घेत आहेत. आणि काल सर्वांनी त्याचा अगदी फ्री हँड म्हणतात किंवा मुखाने सुद्धा त्याचा बराच काय आनंद घेता. इट्स अ हॅपीनेस, है ना. आणि हॅपीनेस घेतला नसेल त्याचं काय ते आपण नंतरच्या स्लाईडमध्ये बघणार आहोत मेडिसिन पार्टमध्ये. तर आणखी एक हॅपीनेसबद्दल होतं की एखाद्याला बोलायचं नाही आहे पण ॲक्शननी सांगायचं की मी सुखी आहे. हॅपीनेस इज अ सुख. मग तो कसा ॲक्शन करेल, येस सर, असं थंब, ओके. अजून हे जर पण सुंदरला पण असं म्हणतात ना, स्माईल करून. अजून पोटाकडे हात, खाऊन पिऊन सुखी. आणि म्हणून कालचं फंक्शन रात्रीचं होतं खाऊन पिऊन सुखी, हॅपीनेस. चौथा आहे ब्लिस, आनंद, परमानंद, आनंद. जे जे महान ऋषी मुनी संत होऊन गेले त्यांच्या मागे आनंद शब्द आलाय बघा. स्वामी विवेकानंद, नित्यानंद, परमानंद. त्यानंतरचं इथं आणि तो इंडोक्राईन सिस्टीमशी कनेक्टेड आहे. आणि इंडोक्राईन सिस्टीम जी आहे ती बऱ्याचदा डायबिटीस कंट्रोल करते. आणि त्यामुळे ज्याचा आनंद गेलेला आहे त्याला बऱ्याचदा डायबिटीज होण्याची शक्यता जास्त असते. त्यामुळे आनंद ठेवणं महत्त्वाचं आहे. नंतरचा व्हॅल्यू आहे, गुण आहे नॉलेज. नॉलेज करता कुठलं ॲक्शन करणार? येस, राईट, नर्वस सिस्टीम, ब्रेन. आपण म्हणतो ना, असं म्हटलं की लक्षात येतं, म्हणजे ती नर्वस सिस्टीम नॉलेजनी कंट्रोल करते. नंतरचं गुण आहे पॉवर, शक्ती. येस, हातपाय. आणि म्हणून अस्थिरोग तज्ज्ञांकरता पण ही व्हॅल्यू खूप महत्त्वाची आहे की पॉवर मसल अँड स्केलेटनला मजबूत करते. एक गुण आहे प्युरिटी. काल जे काही तुम्ही फंक्शन आपण बघितलं आहे ना, काय विश्वसुंदरी जसं असतं तसं रायकॉन सुंदरी, तर त्याचं पण आहे ते स्किन आणि आईजवरनंच तुम्ही त्यांनी डायग्नोज केलं आणि कसं करतायत ते. त्यामुळे प्युरिटी इज द मेन व्हॅल्यू फॉर धिस. आणि ह्या सर्व व्हॅल्यूजमध्ये विरोधी व्हॅल्यू आहेत, फक्त एकच व्हॅल्यू अशी आहे की तिला विरोधी नाही आहे. वेळ मिळाला तर आपण त्यावरती टॉक करूया. सो लॅक ऑफ धिस ऑर शॉर्टेज ऑफ धिस व्हॅल्यूज गिव्ह अ कंप्लेंट. ह्या व्हॅल्यूज, हे जे गुण जर कमी असतील तर तुम्हाला आजार नक्की होणार आणि होताच आहे. जिंदगी की मिठास कम होने के बाद शुगर होती है ना. मिठास ही नहीं है जिंदगी में तो शरीर में शुगर होती है. आणि त्याकरता बघितलं तर ब्लिस लिहिलेलं आहे, व्हॅल्यू आहे ब्लिस. मन चंगा तो कटौती में गंगा, और अगर मन में पंगा तो शरीर में दंगा, है ना. म्हणून मन करारे प्रसन्न, सर्व सुखाचे साधन वगैरे जे काय आहे ते म्हटलं जातं. कोणीतरी म्हटले जिंदगी एक सफर है, आराम से चलते रहो, उतार चढ़ाव तो आते रहेंगे, बस गियर बदलते रहो. सफ़र का मज़ा लेना हो तो साथ में सामान कम रखिए, है ना. और अगर ज़िंदगी का मज़ा लेना है तो दिल में अरमान कम रखिए. नाउ द थर्ड वन इज द मेडिसिन. आपण बॉडी बघितलं, बॉडी तर तुम्हाला सर्वांना माहिती आहे. नस ना नस आपण म्हणतो ना, तुझी नस ना नस मला माहिती आहे. त्यानंतर आपण माइंड पण बघितलं, जे व्हॅल्यूज आहेत ते. मनाला कंट्रोल केलं तर सगळ्या काही शरीरावरती कंट्रोल करतं. आणि मन ह्या शरीराला कंट्रोल करताना प्रत्येक सेल ही इंटेलिजंट आहे माइंडच्या हिशोबात. जे काल एका लेक्चरांनी सांगितलं ना, सेल्स जी आहेत तिला तुम्ही जर बटन स्विच ऑफ केला तर ती डायग्नोज करू शकत नाही की समोरचं कुठली इन्फेक्टेड सेल आहे म्हणून. आणि त्याने हेल्मेट दाखवलं होतं एका स्लाईडमध्ये, आणि हेल्मेट दाखवलं तर मग ती डिटेक्ट करू शकते. तसं मेडिसिनमध्ये आपण बघूया. तर पहिली मेडिसिन आपण आज बघणार आहोत नक्स ओमिका. ही होमिओपॅथिक मेडिसिन आहे आणि त्याचा शॉर्ट फॉर्म जर केला, म्हणजे शॉर्ट फॉर्म आहे NV, N फॉर नो अँड V फॉर वॉमिटिंग. जर आपण कालच्या फंक्शनमध्ये हॅपीनेस घेतला असेल, चित्र तुम्ही बघत असाल, आणि ज्याला वॉमिटिंग किंवा काही झालं नाही तो हॅपी आहे, त्याला नक्स ओमिका घ्यायची काही गरज नाही आहे. पण ज्याला कोणाला काही त्रास झाला असेल तर त्याला नक्स ओमिका नक्कीच घ्यावी लागणार, कारण त्याशिवाय त्याचं वॉमिटिंग आणि ॲब्डोमिनल प्रॉब्लेम कसं सांगणार. आणि नक्स ओमिका मेडिसिनचं आणखी एक हे आहे की तो डायरेक्टली ओपनली बोलत असतो, सीधी बात नो बकवास. तिथे एक सिम्बॉल दाखवलेला आहे, जे मगाशी तुम्ही थंब दाखवला तर ते पण आहे ना, हे थंब आहे. काल पहिल्या लेक्चरमध्ये आपण काय काय बघितलं, पहिले एक ॲक्शन बघितली, त्यांनी थंब दाखवला, आणि नंतर ही मुद्रा बघितली आहे ना, आणि रात्री आपण ही मुद्रा बघितली. ते ह्या वेगवेगळ्या मुद्रा आपण बघतो. तर सीधी बात नो बकवास. आणि नक्स ओमिका ही मेजॉरिटी डायजेस्टिव्ह सिस्टीम करता काम करते, ॲब्डोमिनल सिस्टीम करता, आणि त्याची व्हॅल्यू आहे हॅपीनेस. जर जास्तच झाली आणि पडलो तर काय होतं, फ्रॅक्चर. आणि फ्रॅक्चर झाल्यानंतर बऱ्याचदा 2 मेडिसिन आफ्टर प्लॅस्टर. असं नाही किंवा फ्रॅक्चर झालं आणि होमिओपॅथिक मेडिसिन घेतली आणि आम्ही घरी बसलो, असं नाही आहे. यू हॅव टू डू द प्लॅस्टर और ऑर्थोपेडिक ओपिनियन घ्या. आणि बोन युनियन करता जसं तुम्ही कॅल्शियम आणि हे वापरता तसं कल्केरिया फॉस होमिओपॅथीमध्ये आहे, आणि सेम्फायटम म्हणून पण चालतं. हे दोन्ही अल्टरनेट दिलं तर तो बऱ्याचदा होतं. आणि मग तिथे ॲड्रेस दिला आहे, तो ॲज कशा करता ते वापरलं जातं. आणि म्हणून ह्या दोन्ही मेडिसिन करता येणारी व्हॅल्यू आहे पॉवर. ओबेसिटी हे फ्युकस जे मेडिसिन आहे, फ्युकस वेसिक्युलस, हे ओबेसिटी करता वापरलं जातं. आणि ते खाली जे लिहिलेलं तुम्हाला दिसत असेल, स्लिम ट्रिम क्लिनिक, म्हणजे बारीक होण्याकरता बऱ्याचदा हे मेडिसिन यूज होतं. त्यानंतर आहे बेलाडोना, सर्वसाधारण वापरलं जाणारं लहान मुलांपासून सगळ्यांकरता, आणि नॅचरल रेमेडी फॉर फिवर अँड इन्फ्लॅमेशन असतं. जसं आपण ब्रुफेन वापरतो अँटी इन्फ्लामेटरी तसं हे वापरतं. हा बेलाडोनचा पेशंट कसा येईल माहिती आहे तुमच्या दवाखान्यात? तो आजारी असेल ना तरी नीटनेटका येईल, लिपस्टिक लावलेली, व्यवस्थित ड्रेस केलेला आणि स्ट्रेट फॉरवर्डसारखा असं येईल. बऱ्याचदा असं पण येऊ शकतो, आता मी भांडतो की काय अशा प्रकारचं. आणि त्याला बरीच काय माहिती असते आणि तो बऱ्याचशा माहिती तुम्हाला विचारत असतो. मी एक्सरे काढू का? मग काढलं तर चालेल का, हरकत नाही, ब्लड टेस्ट करू का, ते ह्या प्रकारचं असतो. आणि त्यानंतर त्याला अटेन्शन पण वॉन्ट असतं, म्हणजे माझ्याकरता अटेन्शन द्या, मला कोणीतरी बघा, माझ्याकडे बघता की नाही असतं. आणि शेवटचा प्रश्न तो जाता आता विचारेल, तुम्हाला बेलाडोना कधी हे होईल की तो जाता आता विचारेल, मी नक्की बरा होईल ना डॉक्टर? म्हणून मगाशी मी एक वाक्य टाकलं होतं, व्हॉट पेशंट वॉन्ट. त्याला नक्की बरं व्हायचं तुमच्याकडनं आणि बरं होऊ शकतो की नाही, आणि त्याकरता व्हॅल्यू इथे दिले आजाराकरता इम्युन सिस्टीम, प्रतिकारशक्ती कमी असणं. स्ट्रॅमोनियम एक पेशंट आहे, बाहर से शिखानी अंदर से परेशानी. तुम्ही म्हणाल म्हणजे काय? तर त्याला फिअर ऑफ इंजरी असते, फिअर ऑफ ऑपरेशन असतं. बऱ्याचदा पेशंट येतं ना, डॉक्टर मला ना हे आहे, गाठ आहे, ट्युमर आहे, व्हॉट्सएव्हर आहे, पण मला ऑपरेशन नाही करायचं. काल त्यांनी कुठले मेडिसिन्स वेगवेगळे सांगितली कॅन्सर ह्याच्यामध्ये फर्स्ट स्टेजला वगैरे. तसंच हा पण पेशंट असतो की मला ऑपरेशन नाही करायचं. आणि तो दाखवताना शेखानी का म्हटलं मी की तो मी विचारलं इंजेक्शन घेणार का, तर तो असा म्हणे, हो लहान मुलगा असेल तरी काका बिंदास द्या इंजेक्शन, आणि तुम्ही इंजेक्शन हातात जर घेतलं तर तो बाहेर पळून जाईल. म्हणून ते बाहेर से शिखानी अंदर से परेशानी आहे. आणि डेल्युजन शी इज अ ब्युटिफुल अँड वॉन्ट्स टू बी ब्युटिफुल. काल कोणीतरी तिथे अनाऊन्समेंट पण करत होतं की सुंदर दिसावं असं मला वाटतं का, आणि का वाटतं म्हणून त्यांनी प्रश्न विचारला होता. तर त्यातलं पण एक प्रकार आहे की ह्या पेशंटला, ह्या स्ट्रॅमोनियम मेडिसिनला असं वाटतं की मी खूप सुंदर दिसावं आणि मी सुंदर आहे म्हणून. रस्टॉक्स इज अ मेडिसिन, इंटेन्स खाज असते त्याला, इचिंग असतं, स्क्रॅचेस ओढतो. आपण म्हणतो ना ओरखडे ओढल्यात, ते ओरखड्याकरता ही वापरली जाते. खुजली पाडा म्हणून त्याला म्हटलं जातं की खाजवतच येतो आणि काहीच नाही आहे, डॉक्टर साहेब काही आहे, काहीही घेतलं तरी बरं वाटत नाही आहे, बरेच काय काय केलं. आणि बेस्ट मेडिसिन फॉर जॉईंट करता ही वापरले जाते की सुरुवातीला चालताना खूप त्रास होतो आणि एकदा चालायला लागलं ना की मला काही सांधे दुखत नाही, परत बसलं की दुखतो, त्याकरता रस्टॉक्स वापरलं जातं. चिकनगुनिया ज्यावेळेस होता त्यावेळेस या मेडिसिननी खूप फायदा केला आणि त्या हिशोबात सांधेदुखी जी आहे ती बऱ्याच पेशंटची कमी झाली. नंतरची मेडिसिन आहे ब्रायोनिया अल्बा. ब्रायोनिया अल्बाचा पेशंट नेहमी म्हणता, इन माय टाइम्स आय एम PT उषा यूज टू फॉलो मी, म्हणजे तो इतका धावपळ करत असणार आहे. आत्ता काय कंडिशन झाली त्याची की त्याला सर्वच ठिकाणी स्टिफनेस जॉईंट्स आला आहे, शूटिंग पेन्स आहेत त्याच्या, आणि बटक्स आणि अँकल आणि सायटिका प्रॉब्लेम येतं. हा पेशंट नेहमी बार्गेनिंग करेल, बिझनेससारखा करेल. डॉक्टर साहेब मला ना त्या मुंबईच्या डॉक्टरांचं खूप आराम मिळतं, पण मला तिथे जाता येत नाही, तुम्ही कसे जवळचे आहात ना म्हणून मी तुमच्याकडे येतोय. म्हणजे तो बिझनेस करतोय, तो बार्गेनिंग करतोय. डॉक्टर पैसे कमी नाही का होणार थोडे? डॉक्टर जरा 10 रुपये कमी घेतले तर इट्स अ ब्रायोनिया. आणि मॅकफॉस आणि कोलोसॉन्थ ही क्राईम करतायत. इन्शुरन्स अगेन्स्ट ऑल टाईप ऑफ क्राईम्स, मस्क्युलर यूज, ॲब्डोमिनल कॉलिक ह्याच्याकरता ब्रायोनिया आहे. हेअर लॉसमध्ये जब्रॉन्डी आहे. बॅडिएगा पण हा टक्कल, डॅन्ड्राफ आणि ह्याच्याकरता आहे. स्प्रेन करता बेलिस आहे. स्प्रेनिंग जे होतं ना, जसं आपण स्प्रेनिंग करता वेगवेगळे मस्क्युलरचे हे वापरतो तसं हे बेलिस आहे. पॅलॅडियम एक्सक्लुसिव्ह ब्युटी क्लिनिक, खूप मी सुंदर दिसावी किंवा इगो आणि अशा असणारे जे काय फक्त ते लेडीज असं नाही, जेंट्स पण आहे यात तिथं. मॅडम प्लॅटिना, खुद को क्या समजती है, इतना क्यों अखडती है. आणि प्लॅटिनाचे पेशंट हे बऱ्याचदा अशा प्रकारचे जातात. कॉस्मेटिक ब्युटीमध्ये, ब्युटी पार्लरमध्ये हे लोक खूप पैसे खर्च करतात. बर्बेरीज ऐकवा, एक स्किन ब्युटी करता वापरलं जातं, लोशन, क्रीम आणि ह्या करता हे वापरलं जात आहे. बर्बेरीजवर किडनी आणि युरेट्रल जे कॅल्क्युला आहे त्याकरता वापरलं जात आहे. हार्ट डिसीज करता स्पॉन्जिया, कॅक्टस, क्रेटेनाइन्स वगैरे वापरले जात आहे. आणि परत इथे व्हॅल्यू येते लव. एलिमेंट्स फ्रॉम डिप्रेसिव्ह एक्साइटमेंट. नागपूरमध्ये मागच्या काही दिवसापूर्वी एका कलिगचं डेथ झाली. आपण बघितलं आहे की 31st त्यांनी खूप सुंदर फंक्शन अटेंड केलं आणि काही प्रॉब्लेम नव्हतं वगैरे. आणि बाकी डिटेल मला माहीत नाही, पण त्याचे जे हे झालं की 1 तारखेला तो सडनली बिचारा गेला, एक्सपायर झाला. आणि त्याच्याकरता जेल्सिमियम आणि नॅट्रोमोर आहे की एक्साइटमेंट येतं पण डिप्रेसिव्ह एलिमेंट्समध्ये येतं, की त्याला तो एलिमेंट्समध्ये. आणि म्हणून आपण बऱ्याचदा बघतो ना, इंडिया मॅच जिंकली तरी हार्ट अटॅक येतं, हारली तरी हार्ट अटॅक येतं. नॅट्रोमोरचा एक पेशंट आहे, तो कधी आरशामध्ये स्वतःला बघायला तयार होत नाही. एखादा पेशंट किंवा एखादी व्यक्ती आहे तुमच्यासमोर तर ती आरशामध्ये बघायला तयार येत नाही. आणि म्हणून तिथे एक शॉर्टमध्ये दिला आहे की मी आरशात का पाहू म्हणून, सायलेंट ग्रीपमध्ये असतं. एक आहे की पल्सेटिला म्हणून मेडिसिन आहे, जुनी सिरियल होती, आपको रुलाने आ रही है एक नई सिरियल म्हणून. आणि अटेन्शन वाटणारी ही एक मेडिसिन आहे. हार्मोनल इम्बॅलन्स करता गायनेकोलॉजिस्टला ही मेडिसिन खूप उपयोगी येते. हा पेशंट मुसमुस करून रडत असतो, कधी बघावा रडका चेहरा, कुसुम क्यूर होती आहे अशी ती सिरियल होती पहिले. ह्याच्यामध्ये एक लिहिलं मी कन्सोलेशन ॲम्ब्युलेशन. कन्सोलेशन ॲम्ब्युलेशनमध्ये आपल्याकडे एखादा लहान मुलगा टेबल लागला आणि रडायला लागला तर आपण काय करतो, त्या टेबलला असं मारतो आणि टेबलला मारलं की तो म्हणतो की हा बरं झालं बरं झालं, त्याची चुकी होती ना, बरं झालं. दॅट इज द पल्सेटिला मेडिसिन, कन्सोलेशन ॲम्ब्युलेशन. आणि हम है राही प्यार के हमसे कुछ ना बोलिये जे आहे ते पल्सेटिलाला लागू होतं. नेक्स्ट गायनिक मेडिसिन आहे सेपिया. काही क्यू नाही आहे, याने ती नेहमीच ही पण रडत असते. आणि ही सेपिया पेशंट कशी असते, घरात सगळं काही करत असे आणि ज्यावेळेस ती आजारी पडते त्यावेळेस जर कोणी तिच्याकडे बघितलं नाही तर ती अंथरूण धरून ठेवते, म्हणून खटाई पे पडी राहती आहे. मग तिला सगळं समजतं पण ती हे करते, कॉटवरती झोपून पडून राहते असं करते. त्यानंतर टॅलेंटुला हा जो पेशंट आहे हा मल्टी कलर चप्पल, मल्टी कलर ड्रेस वापरेल, केसांचा वेगवेगळे कलर वापरतात, ते लाल हिरवा पिवळा जे काय आहे ते असं. त्यानंतर आर्सेनिक अल्बम जे तुम्ही सर्वांनी मागच्या 4 वर्षापूर्वी कोविडमध्ये वापरलं. फ्लू कोल्ड अँड कफ करता आहे. आर्सेनिक हा खूप कंजूस असतो, तो घाबरतो एकट्याला आणि म्हणून कोविडमध्ये एकटे ठेवले आणि म्हणून बऱ्याच जणांची डेथ झालेली आहे. म्हणून कोविड मेडिसिन फेमस झाली ती. आणि हा पैसा क्यू पैसा करताय असंच करत राहतो आणि म्हणून त्याच्याकरता व्हॅल्यू दिले पीस. नंतरची एक मेडिसिन आहे इग्निशिया. तुम इतना जो मुस्कुरा रहे हो क्या गम आहे, सायलेंट ग्रीफमध्ये ही मस्क्युलर इग्निशिया पेशंट असते. ओपीएम पेशंटचं एक थोडक्यात म्हणजे असं की हा पेशंट तुम्हाला विचारेल किती दिवस मी औषध घेऊ, तुम्ही म्हणालात इतक्या पिरियडमध्ये घ्या, तो तुमच्याकडे बरा नाही झाला तरी येतच राहील आणि तो पिरियड संपला की तो विचारेल डॉक्टर तुम्ही सांगितलं होतं 6 महिने अजून बरा नाही झाला, आता काय करू. इट इज द ओपीएम. ओपीएम ही मेडिसिनचं नाव आहे. आणि त्यात इंडिग्नेशन डिस्कम्फर्ट ड्युरिंग. हा पेशंट दुसऱ्या पॅथीची औषधं घ्यायला बऱ्याचदा तयार होत नाही, पॅथी कुठलीही असू द्या, पण तो म्हणेल अच्छा ते मी नाही घेणार, मी येणारच नाही आहे. कलकेरिया काब आहे, सबसे बडा रोग क्या कहेंगे लोग. हा पेशंट कधी बाहेर यायला तयार नाही, लोक काय म्हणतील म्हणून तो असं झाकत असेल, स्किनमध्ये असं करत असेल, चेहऱ्याला काय असेल तर तो झाकून येतो. इट्स अ कलकेरिया काब आहे. आणि लहान मुलं जे तोंडात बऱ्याचदा येतात ना पेशंट, की कुठलीही वस्तू मिळेल ती टाकतात तोंडात तीच. चॅमोमिला हा डेंटिस्ट करता पण उपयोगी आहे. टिथिंग पेन्स जे आहे त्याकरता येत आहे. ॲल्युमिना आहे, कॉन्स्टिपेशन करता आहे. स्माइलिंग नेवर. कॉन्स्टिपेशन असणारा पेशंट कसा असेल, आतमध्ये हसत असेल का, इज नॉट स्माइलिंग नेवर, म्हणून स्माइलिंग नेवर. आणि ॲल्युमिना एक अशाकरता वापरलं जातं की ज्यावेळेस एखादा ब्लड बघतो, रस्त्यामध्ये ॲक्सिडेंट झाला आहे किंवा कोणाचं ब्लड वाहत आहे तर त्यावरती ॲल्युमिना उपयोगी येतं. कॅन्थर इज बर्निंग मिक्सुरेशन, अर्निका तुम्हाला सर्वांना माहिती आहे. आणि डेंटल करता आणखी 2 मेडिसिन आहेत, क्रिओझोट अँड स्टेपिसायग्रिया. ओके, थँक्यू. पीछे मुडके ना देख प्यारे आगे चल. एक फक्त मी 2 मिनटं घेतो सर, चालेल ना. मगाशी मी तुम्हाला 7 व्हॅल्यूज सांगितले, बरोबर आहे. नॉलेज, रिस्पिरेटरी करता पीस शांती, हार्ट करता प्रेम, सुख, शक्ती आणि पवित्रता, आणि शेवटचं एक सांगितलं आनंद. तर तुम्ही मला ह्या सगळ्यांचे विरोधी गुण सांगाल काय एक एक. फॉर एक्झाम्पल नॉलेज ज्ञान, अज्ञान, शांती अशांती, प्रेम तिरस्कार द्वेष मत्सर, सुख दुःख, शक्ती अशक्तपणा, आणि प्युरिटी इम्प्युरिटी, आणि आनंदला ब्लिसला, सुखाला दोघांना एकच कसं का असेल. त्यामुळे आनंद हा इंडोक्राईनमध्ये त्याकरताच गेलेला आहे की त्याला कुठेही विरोधी गुण नाही आहे, म्हणून महान संत लोकांच्या नावाच्या मागे आनंद येतो. थँक्यू व्हेरी मच. वन्स अगेन थँक्स टू RMA कर्जत मेडिकल असोसिएशन टू गिविंग मी दिस टाइप ऑफ चान्स. ओके, थँक्यू.
थँक यू व्हेरी मच सर फॉर सच अ नॉलेजेबल इन्फॉर्मेटिव्ह लेक्चर. मला असं वाटतं की आपला दरवर्षी KMAमध्ये सरांचा एक लेक्चर ठेवला पाहिजे होमिओपॅथीचा. नाव इट्स टाईम टू अनाऊन्स आवर लकी ड्रॉ. फर्स्ट ऑफ ऑल आय रिक्वेस्ट आवर चेअरपर्सन टू प्लीज फेलिसिटेट आवर गेस्ट स्पीकर डॉक्टर नितीन भोपतराव सर. Thank you, sir. Now I request our guest speaker to please felicitate our chairpersons, Dr. Nilesh Mhatre and Dr. Manish Jain. Thank you. Now it's time for lucky draw. I request Dr. Nitin Bopatrao sir to do the honors. तीन काढा. तीन. This lucky draw is sponsored by MOC Hospital. चालेल ना. And the winner is Dr. Rahul Sukare. No, he is not there. डॉक्टर गीता हजारे. तिचा झाला होता ना काल झाला होता तिचा, परत त्याच्यातच टाकली का चिठ्ठी? नो, यात येतात मॅडम, अजून येत आहेत लोक. एक दोन काढा, अजून पाहिजे तर एक दोन काढा. हा ते काढून टाका, एक दोन काढा. चला ठीक आहे, कोई लास्ट डॉक्टर दिगंबर पवार is not there. Okay, we'll finish here. Now I request my colleague Dr. Sharwani Kulkarni to continue with the scientific session.
Thank you. आपण आपल्या दुसऱ्या दिवसाच्या दुसऱ्या लेक्चरकडे प्रस्थान करूया. वर्षानुवर्ष मुलींना, स्त्रियांना मासिक पाळीचा त्रास होत असतो. यातली गंभीरता शोधणं आणि वेदनामुक्त करण्यासाठी यामागची कारणं शोधणं, असं आपलं आजचं लेक्चर आहे डिस्मेनोरियावरती. आणि आपले स्पीकर आहेत डॉक्टर देवदत्त दाभोळकर सर. मी आजचे चेअरपर्सन सिनियर प्रॅक्टिशनर कर्जतचे डॉक्टर फडके सर आणि डॉक्टर मनोरिता गायकवाड यांना आपल्या लेक्चरला स्पीकरना व्यासपीठाकडे घेऊन येण्याची विनंती करते. मी चेअरपर्सन्सना विनंती करते की त्यांनी दाभोळकर सरांचं फूल देऊन स्वागत करावं. आणि कालपासून एक वैशिष्ट्य सांगायचं राहतं आहे की हे जे बुके आपण यावेळेला वैशिष्ट्यपूर्ण बनवलेत, दरवेळेचा अनुभव असतो की हे बुके ठेवून दिले जातात, पायदळीत उडवले जातात. पण म्हणून आपण यावर्षी स्पेसिफिकली लोकरींचे विणलेले बुके जे आपल्या कर्जत मेडिकल असोसिएशनच्या मेंबरच्या एका पत्नीने केलेले आहेत, तर तिच्यासाठी आपण एकदा जोरदार टाळ्या देऊया. तिचं नाव आहे ममता ओसवाल, डॉक्टर अमित ओसवाल यांची पत्नी. यानंतर आपण MOCचा लकी ड्रॉ काढूया. आपले आजचे स्पीकर दाभोळकर सर यांच्या हस्ते. वन 174. थँक्यू सर. एवढे लकी ड्रॉ पेंडिंग आहेत. मी आपले आजचे स्पीकर यांचा परिचय करून देते. डॉक्टर देवदत्त दाभोळकर, MBBS DGO DNB, सिनियर ऑब्स्टेट्रिशियन अँड गायनेकोलॉजिस्ट, लॅप्रोस्कोपिक सर्जन, इंटरनॅशनल ट्रेनिंग इन गायनेकोलॉजी, gynecologic endoscopy in Germany and laparoscopy and infertility, Ahmedabad, certified in menopause care, gestational diabetes and psychosexual medicine. Yeah. Sir, approach to dysmenorrhea.
हे मोठं कसं करायचं? एकच मोठं करून द्या. Good morning everybody. Thanks to RMA for having me here today. After a very insightful lecture by the previous speaker, my topic is going to be little boring and the slides are going to be little monotonous. My organ is also very small. So let's begin. I'm Dr. Devdatta Dabolkar. I have 20 minutes and 35 slides. Let's start. Okay. Dysmenorrhea by definition means painful during menses or pain during menstruation of uterine origin. So pain originating from the general GI tract or ovary may not be classified as dysmenorrhea. Dysmenorrhea is the most common menstrual symptom and most common cause of self-medication. OTC preparations are most commonly taken for dysmenorrhea. In simple words, simple English, dysmenorrhea just means painful menstruation. Okay. Types of dysmenorrhea are two: primary dysmenorrhea and secondary dysmenorrhea. Primary dysmenorrhea is menstrual pain not associated with macroscopic pelvic pathology. Okay, that is sonography report and laparoscopy report may also be negative, but there may be pain. Okay, the most important thing here to be considered is endometriosis. Secondary dysmenorrhea is when the menstrual pain is from anatomic or macroscopic pelvic pathology. Primary dysmenorrhea occurs 2 to 3 years after onset of menses, that is menarche, and it is occurring when the cycles becomes ovulatory. So whenever a girl complains of painful menstruation, be sure that she is ovulating. That is a very important clinical point that we should discuss. Henceforth, in today's topic, we will discuss primary dysmenorrhea, because secondary dysmenorrhea per se will be a very huge topic. Talking about adenomyosis, fibroids and all it will not be covered in 20 minutes. Okay, incidence 25% of adolescents are having dysmenorrhea. 90% of the reproductive age women have dysmenorrhea. 34.2 people women have severe dysmenorrhea, 36.6 have moderate, and 29.2 have mild dysmenorrhea. By severe dysmenorrhea means that lady cannot work. She has to take abstinence from work or her college or her office, whatever. And only 15% of the girls take medical attention or medical advice for dysmenorrhea. Okay, risk factors for primary dysmenorrhea is early menarche. Nowadays it is very common, but girls who start menstruating before the age of 12 years are very common to have dysmenorrhea. Nulliparity women who do not have marriage or who have heavy menstrual flow, that is menorrhagia, are very prone to have dysmenorrhea. Smoking is antiestrogenic very prone to have dysmenorrhea. A family history and obesity are two modifiable risk factors for primary dysmenorrhea. Secondary dysmenorrhea does not have risk factors. It has causes myoma, adenomyosis, PID, tuberous abscess, ovarian masses. Endometriosis is a very special category here. Endometriosis is the commonest differential diagnosis of primary dysmenorrhea. If you have primary dysmenorrhea and there is nothing else to be done or no diagnosis to be had, then treat it as endometriosis. Okay, epidemiology and dysmenorrhea is very common in rich women, reason not known. It is very common in women with stressful career because they have premenstrual syndromes, very common in obese women, very common in women with premenstrual syndrome, very common in women with menorrhagia. Bleeding for more than 5 days during each cycle increases the risk of dysmenorrhea by about 2 times. And the most important thing, despite of treatment, 50% of women continue to have dysmenorrhea. Whatever treatment you may give, they will be having dysmenorrhea of some sort. The severity may wax and wane, it may increase, decrease, but dysmenorrhea will continue. Pathophysiology, primary dysmenorrhea is due to prostaglandin PGF2 alpha release, which is a potent myometrial stimulant and a vasoconstrictor in the secretory endometrium. Leukotrienes increase the sensitivity of pain fibers. In primary dysmenorrhea, there is complex interplay between hormones and mediators, basal body temperature, sleep patterns, and central nervous system, extent of which is not completely known. Now, this is an exam-oriented slide. Luckily, we have all passed our exams, so we may not remember this. One myth I would like to clear is that cervical stenosis has a role in secondary dysmenorrhea, not in primary dysmenorrhea. बऱ्याच वेळेला असं म्हणतं की cervical dilatation केलं तर dysmenorrhea जाईल. तर that is not true for primary dysmenorrhea. That is what is to be understood. Features of the pain, pain begins just before menses. पाळी येण्याच्या अगोदर पोटात दुखायला लागतं. Pain lasts for as little as 8 hours and as much as 7 to 8 hours. Pain always radiates to the back and the thighs. Pain is severe on the first day and the second day. On the third day and the fourth day, if bleeding is there, pain is little less. And it is always associated with some other symptoms like insomnia, nausea, vomiting, diarrhea and fatigue. Pain of primary dysmenorrhea is relieved by pressure and massage. Any perforative peritonitis or any other pain will not be relieved by massage and pressure. But by application of heat, if the pain is getting relieved, it may be more likely to be dysmenorrhea. Okay, history taking in dysmenorrhea, age at menarche is very common because we have already mentioned that girls who have early menarche have dysmenorrhea. Regularity of the cycles, length of the cycles, number of pads and the presence of intermenstrual bleeding. Intermenstrual bleeding, again, the newest entity is cesarean scar pregnancy or what we call as isthmocele. Onset, duration and severity of the pain, impact of pain on social activity, associated symptoms and progression of symptom severity. Girls who are sexually active and who are pregnant, history has to be taken in details because that has a special thing. Special points in history, family history helps to differentiate endometriotic pain from primary dysmenorrhea because endometriosis is a familial disease, dysmenorrhea may not be. And family history of sickle cell disease, or if screening is not done, sickle cell crisis or sickle cell pain is precipitated a little more during menses. That is the reason why we should ask for this history. Sexual abuse is associated with dysmenorrhea and chronic pelvic pain. Internal examination should be and must be done for non-virginal girls or girls who are sexually active. We just cannot say that she is a girl, I will not do an internal examination. That is very important. Now we will just mention a little about dysmenorrhea of endometriosis. It is the most common misdiagnosis of primary dysmenorrhea. We keep on treating the girl thinking that her scan is normal and we are giving painkillers, and actually what she has is endometriosis. Endometriosis now is very common. It has got nothing to, endometriosis is reported even before the onset of menses. That is what is to be understood. In endometriotic, the pain begins before menses, definitely before menses. Dysmenorrhea pain can begin just at the onset of menses, but endometriosis related pelvic pain will start 1 or 2 days before the menses. It will reach peak at about 1 to 2 days before, and it will be relieved by the onset of flow and shortly thereafter. Most spasmodic dysmenorrheas will be relieved when the bleeding starts. They are cervical related. Diagnostic laparoscopy, as we all know, is the gold standard to diagnose endometriosis. Okay, severe dyspareunia will be associated if girl is married and or sexually active and you do PV, there will be adnexal tenderness or there will be bluish color spots in the vagina on speculum examination. Adolescent on laparoscopy done for other reasons, adolescent and adult endometriotic deposits appear different in color. Adolescent are clear and red, bright red in color, and adult endometriotic are gunpowder or old clotted blood in color. Women who have pain in spite of laparoscopy and oral contraceptive pills often benefit from 6 months of GnRH analog and add-back therapy. This is an ACOG, American College of Obstetrics and Gynec Society guideline. In simple word, it means that if everything is done and still the pain is not relieved, you can give GnRH analogs. The commonest form of GnRH analog that we use is lupred acetate. Lupred acetate 3.75 milligram देऊन जर पेन थांबलं तर it is of endometriotic origin. Okay, this is laboratory, basic laboratory that we do. Basically, we are doing these cases to rule out other causes. CBC for infection, SCG for ectopic, ESR for salpingitis, UTI साठी urine analysis. This is very important. Stool examination is not routinely done, but any GI cause of bleeding might be there which may mimic or get precipitated during menses and reflect as dysmenorrhea. CA125 should always be done. It has got nothing to do with other things. It is not very specific, but it is indicative of endometriosis. And prolactin somehow, reasons not known, but prolactin is known to be associated, hyperprolactinemia is known to be associated with dysmenorrhea. In imaging, we basically do, if a girl is unmarried, we can do a full bladder scan, but full bladder abdominal scan will not be able to pick up endometriosis. Transvaginal sonography is the, in girls which are permissible, it is the first line imaging technology. HSG and sonosonography can be done to diagnose polyps and Mullerian anomalies. CT and MRI can be done to diagnose, differentiate between adenomyosis and myoma. Now, always we have this doubt whether when to do CT scan and when to do MRI. If you are expecting or thinking that the mass might be malignant or it has deposits, then we can do a CT scan. And when the origin of the mass is in doubt, whether we think it is from the bladder or the bowel or the large bowel, it is better to do an MRI. Okay, treatment of dysmenorrhea in general, we are talking about the treatment of primary dysmenorrhea. Skillful manipulation of psychological behavioral factors, this is the primary thing, and selective medication, because most of the girls are very young, you cannot give them long-term treatment. Okay, empiric therapy can be started if the history is negative and the physical examination is negative. Empiric treatment means giving treatment without sonography or any other blood test. जर पेशंटची हिस्ट्री बरोबर आहे आणि तिच्या palpable mass नाही आहे तर तुम्ही तिला NSAIDs देऊ शकता. If dysmenorrhea is severe and not controlled, laparoscopy has to be done to rule out secondary causes. Okay, any pain which is not relieved by oral contraceptive pills and NSAIDs should be evaluated by laparoscopy. Non-pharmacological modifications during periods, a warm bath, oil massage, lying down in supine position, continuous low topical therapy. Exercise improves blood supply and relieves spasmodic dysmenorrhea. Cochrane review tells that TENS is more effective than placebo. Acupuncture and acupressure both have a role. Yoga is effective for almost everything. And most important thing is to avoid coffee, junk food and smoking, at least during menses. This is very important. And this can be counseled and the girl can do it herself. Okay, dietary modifications during menses for a girl who has severe dysmenorrhea, she can avoid tea, mint, ginger can be taken. Low fat vegetarian diet is very important. Among the vitamins, you can give her a multivitamin tablet containing vitamin E, vitamin D and thiamine. Food containing omega-3 fatty acids are very useful. Fish liver oil is very useful. Dietary inflammatory index shows that individuals who are on vegan diet have very low rate of inflammation. But just going on a vegan diet for dysmenorrhea may not be possible. Now, herbal medications, there is a randomized control trial which says that these herbal medications are effective for primary dysmenorrhea. This is a combination of 300 milligrams of Valeriana officinalis, 30 milligrams of Humulus lupulus and 80 milligrams of Passiflora incarbonate. I have no personal experience of using this, but there is a RCT, randomized control trial, which says that these medicines, herbal medicines are useful for primary dysmenorrhea. NSAIDs are the first choice drugs for the treatment of dysmenorrheas. All NSAIDs are equally effective. It is not that this particular drug is effective than that drug, or it is your preference and the patient relief that is grow. Ibuprofen and naproxen are the most commonly used drugs. NSAID is the best part of it is they are available and not very costly. Okay, NSAIDs decrease menstrual pain by decreasing intrauterine pressure and lowering PGF2 alpha levels in menstrual period. NSAIDs inhibit type PG1 synthetase and suppress production of cyclical endoperoxidase, that is COX-2 selective agents, propionic acids and indole acetic acids. Active symptoms by decreasing endometrial and menstrual fluid in the PG concentration. Okay, just some clinical pointers on NSAIDs. Ibuprofen is the drug of choice. Diclofenac, if you are using, use diclofenac potassium, not diclofenac sodium. Mefenamic acid has the least side effects among all the NSAIDs that can be used. Indomethacin is a very effective drug, but it should be the last choice NSAIDs because it has some side effects. Aspirin somehow is not effective because aspirin does not act on the uterus. Paracetamol may not relieve dysmenorrhea as effectively as it relieves other pains. Okay, precautions, all NSAIDs cause GI upsets. They are absolutely contraindicated in patients with GI ulcers and renal diseases, and monitor patients for GI bleeding and renal diseases. Contraindications are renal insufficiency, creatinine 1 more than 1, generally avoid NSAIDs, peptic ulcer, known cases, gastritis, bleeding, and lady can skip her NSAID on the day of she is fasting. उपासाच्या दिवशी ही गोळी न घेतलेली बरी कारण की त्याचे उलट्या होतात. FDA approved NSAIDs diclofenac in the dose of 50 mg TDS after breakfast, after lunch, after dinner. Ibuprofen 800 mg loading dose followed by 400 mg TDS. Ketoprofen 500 mg TDS. Celecoxib 400 mg loading dose. Mefenamic acid 500 mg loading dose followed by 200 to 500. Naproxen and indomethacin. Doses will vary according to the weight of the patient. Do not follow strictly. If a patient is overweight, she may require a little extra dose. Antiprostaglandins are another group of drugs, higher order NSAIDs which can be used. They work by blocking prostaglandin synthesis and metabolism. Once the pain has been established, antiprostaglandins are not really effective. So the key question or key message here is for NSAIDs and antiprostaglandins to be effective, start them before menses, before the pain starts. Every lady knows or every lady has some symptoms due to which she realizes that she is going to menstruate or menses is going to start in next 1 or 2 days. If she starts her medication 2 days earlier, it will be very effective. COX-2 specific inhibitors are effective in relieving menstrual pain and selectively reduce GI symptoms caused by inhibition of COX-1 receptor. Oral contraceptive pills, these are the second choice after NSAIDs. Cyclic administration in the lowest dose. Menorrhagia, the dose of ethinyl estradiol. As you all know, oral contraceptive pills contain ethinyl estradiol and some progesterone. Ethinyl estradiol differentiate whether it is a high dose oral contraceptive pill or a low dose oral contraceptive pills. When the ethinyl estradiol dose is more than 30, it is high dose. For menorrhagia, you require to give high dose oral contraceptive pills. But dysmenorrhea, you can give low dose contraceptive pills. That is very important. Progesterone component blocks the production of prostaglandins. Thin endometrium, oral contraceptive pills do not allow ovulation to occur, do not allow endometrial thickness to build. So thin endometrium contains less arachidonic acid, which is a prostaglandin precursor. There is less uterine contractility and reduced intrauterine pressure as volume of menstrual fluid is reduced. That's why there is reduced dysmenorrhea. Okay. Low dose or high dose oral contraceptive pill generally does not make any difference in dysmenorrhea. Long term administration, because nowadays girls are preparing for their exams, they have colleges, they have so many other activities. It is better to have willful menstruation. If a girl has a NEET exam, she can take oral contraceptive pills for say 4 cycles and then have 1 menstruation. She will not be disturbed, or her cycle or her college may not be disturbed during those days. Now, another important or misconception is height is affected. Most of the doctors feel that if you give oral contraceptive pills, the girl may not achieve her adult height. This is not true for low dose oral contraceptive pills. Any oral contraceptive pills having less than 30 micrograms of ethinyl estradiol will not affect the adult height. That is very important. And one more practical point is 2 years after menses, height generally does not increase, and primary dysmenorrhea begins almost 2 years after menses. So primary dysmenorrhea can very well be treated by low dose continuous regime of oral contraceptive pills. That is the take home message for oral contraceptive pills. Calcium channel blocker, especially nifedipine, is a very good drug which is used for primary dysmenorrhea. It inhibits myometrial contractility. Uterus la te shanta karta. Dose is 30 to 80 milligrams. Side effects are headache and constipation. Now all of us will be thinking that nifedipine is an antihypertensive medication and it may cause hypotension, but it will not cause hypotension in normotensive patients. We are using it as a very effective tocolytic in pregnant patients, and it does not cause hypotension. It is used for acute tocolysis. It can be used in similar doses for primary dysmenorrhea, but it is the 3rd or the 4th line treatment. First you have to give NSAIDs, then try with oral contraceptive pills, and if nothing else works, you can have a shot of nifedipine. Okay, progestogens are also very important. Progestogens are anti-inflammatory effect and they inhibit metalloproteinase, useful for women who have associated premenstrual symptoms, physical symptoms. Psychiatric symptoms have to be treated with different medicines. Oral micronized progesterone is the progesterone of choice. Now there are 2 important progesterones that we all use in private practice. One is medroxyprogesterone acetate and one is norethistron. So when a woman comes to you for postponement of menses, घरात पूजा आहे किंवा कुठे जायचं आहे, तर medroxyprogesterone acetate is the progesterone of choice. And if a lady comes to you that I am bleeding for last 8 to 10 days, my UPT is negative and I am bleeding, then that bleeding can be effectively stopped by norethistron. This is an offhand, but I thought I should put this. Okay, progesterones can be used in other methods also. Injection depomedroxyprogesterone, which we are using as contraception, very useful. LNGIS, which we call as Mirena, very useful. And transdermal patch, not very useful. Transdermal patch as it is not available in India. But DMPA and LNGIS can be used for contraception as well as dysmenorrhea. Surgical treatment is the last option for primary dysmenorrhea. Cervical dilatation, which is very commonly done, has success rate of only 25%. Local injections of alcohol and anesthetic agents given in the uterosacral ligaments have success. Presacral neurectomy or laparoscopic uterine nerve ablation, LUNA as we call it, you can be used in refractory cases, but Cochrane review says that there is no concrete evidence to recommend these therapies. Okay, any girl who is having relief with local injection can respond to PSN and LUNA provided that the dysmenorrhea is bilateral, it is not unilateral. Okay, conclusions, we'll just end the lecture. Counseling, most mothers of the girls will be very tense ki what is going to happen. So just tell them that dysmenorrhea is a maximum 2 to 3 days problem. The rest 26 to 28 days of the month are with the girl. She will not be having anything. Primary dysmenorrhea, always go for symptomatic treatment. Secondary dysmenorrhea, always treat the cause. Complementary therapy, if at all, always have a role in dysmenorrhea. This is one condition in OBGYN where complementary therapies, acupuncture, acupressure, yoga, all these medicines do have a role. Okay. Dysmenorrhea is never associated with cancer. Prolapse does not cause dysmenorrhea. Pseudomenopausal regime by giving GnRH analogs is a very good test of seeing that the dysmenorrhea is because of uterine origin. Hysterectomy is never a treatment. It should be the last parameter. Okay. And one very important thing in counseling we are telling की तुझी delivery झाल्यावर तुझे pain जाईल. तर that delivery has to be vaginal delivery. Cesarean केलं तर dysmenorrhea जाणार नाही. तिच्यानंतर परत तिला dysmenorrhea होणार. This is very important thing. And except labor pains, all other pains are useless. Okay, doctor should evaluate, counsel and diagnose and treat pain, woman with pain. That is all. Thank you very much. Questions if any, I will be happy to answer. Yeah, please. No, mefenamic acid will contract the uterus and make the uterus relax. Bleeding is because of contractions that are happening. So it will be more effective for menorrhagia associated dysmenorrhea. आणि मेफ्टाल स्पासमध्ये ड्रोटीन टाकून मेफ्टाल डी वगैरे ज्या गोळ्या आहेत ना त्या ओव्हर द काउंटर त्याचं मार्केटिंग चांगलं झाल्यामुळे त्या गोळ्या वापरल्या जात आहेत बट दे आर नॉट प्रायमरीली फॉर डिस्मेनोरिया. आयबोप्रोफिन इज दी एनाल्जेसिक ऑफ चॉईस फॉर डिस्मेनोरिया, प्रायमरी डिस्मेनोरिया.
Sir, what is your opinion about per rectal examination if laparoscopy is not possible?
Very good question, sir. I forgot to mention that point. Per rectal examination will definitely tell you whether the uterus is in center. It should be done in all. There is no contraindication. Age-wise contraindication is not there. And if the uterus is deviated to the center or uterus appears fixed to the cul-de-sac, that is the POD is obliterated, it is a very good examination which will help you to counsel the patient for laparoscopy. Okay, I forgot that point. Thank you so much, sir, for bringing it up.
Sir, can you please shed light on mid-cycle pain, maybe in cases of endometriosis?
Mid-cycle pain is called Mittelsmark. It is ovulation pain. That pain is caused because of rupture of the dominant follicle.
So in cases of endometriosis?
Endometriosis, it will be severe because endometriosis, the ovary is stuck either to the uterus or to the lateric pelvic wall. So the follicle may not rupture as easily as it should rupture. It is Mittelsmark. What we call.
How to deal with that?
It can be dealt as primary dysmenorrhea, similarly. And for these things, rectal triamidal pessaries are very effective. If you give a single shot of rectal triamidal pessary, and that will tell you that the lady is ovulating. That is one good thing about it. And this is not a very severe pain. This is a bearable pain. But mid-cycle, lot of women have that pain. Thank you.
थँक्यू सर. इतक्या साध्या सोप्या सरळ भाषेमध्ये तुम्ही एवढा अवघड स्त्रियांना होणारा त्रास डिस्मेनोरियाचा समजावून सांगितलात. यानंतर मी आपले चेअरपर्सन यांना विनंती करते की त्यांनी मोमेंटो देऊन आपल्या स्पीकरचं फॅलिसिटेशन करावं. याच्यानंतर लेक्चर कोण घेतं? यानंतर मी दाभोळकर सरांना विनंती करते की आपले चेअरपर्सन यांचं त्यांनी फेलिसिटेशन करावं. सर लकी ड्रॉ काढायचं आहे आपल्याला PCCCने स्पॉन्सर केलेला. अरे वा. आपण सरांसोबत एक फोटो काढून घेऊया कारण PCCCचे PRO अजून आले नाही आहेत. अडवळे सर आपण एक सरांसोबत फोटो काढूया. सर या. थँक्यू सर. यानंतर पुढील कार्यक्रमाची सूत्र मी डॉक्टर मनीष यांच्याकडे सोपर्द करते.
थँक्यू.
सर बुक
Let's continue our next session. The next topic is orofacial pain, what every general practitioner should know. It will be delivered by our guest speaker, Dr. Abhijit Lele sir. I request Dr. Ashish Karve sir and Dr. Aditya Jangam to escort our guest speaker to the dais. Okay. I request Dr. Karve sir and Dr. Aditya Jangam to please welcome our guest speaker with a small token of love on behalf of Raicon. Lucky draw. Lucky draw घेऊया. Lucky draw घेऊया. I will take a lucky draw. I request our guest speaker to please pick up a coupon which is sponsored by Mumbai Oncology Center. Lucky draw.
ज्यांचं नाव आधी निघालेलं आहे ना त्यांनी घ्यायचं नाही. ते चुकून मिक्स झालेत काय.
हां पण आता ते पण आपणच ती सीटच साईडला करून ठेवूया. आशिष कर्वे. डॉक्टर आशिष कर्वे, कॉंग्रॅच्युलेशन सर. त्या चिठ्ठीत नाव आलं का असंच घेतलंय ते माहित नाही. गिफ्ट. Thank you, sir. Now, a brief introduction of our speaker. Dr. Abhijit Lele, sir, is postgraduated in clinical dentistry from prestigious King's College of London. He is in private practice in Pune since 2001. His focus in clinical practice includes advanced restorative work, full mouth rehabilitation, implants, aesthetic dentistry, management of temporomandibular disorders, and sleep apnea. He has completed his core curriculum of Dawson Academy from USA that deals with the concept of complete dentistry. He has conducted numerous workshops on restorative dentistry aesthetic dentistry, FMRs, temporomandibular disorders, and he has been presenter at various national and international meets. I request Dr. Lele sir, now please enlighten us with his lecture.
रिमोट आहे का? हॅलो हॅलो हॅलो. So at the outset, let me thank Raigad Medical Association for giving me this opportunity to talk to this August gathering of medical practitioners. We are probably few in numbers, the dentist gang, but I think this particular presentation is relevant to most of you who are used to see patients day in and day out. Huh? Huh. No. Okay. किससे इससे आगे जाएगा. Okay, so now that I am standing in front of all medical practitioners, this takes me back to my college days when a particular surgeon who used to be our teacher came and right in the first year of our college told us, तुमको मालूम है क्या तुम लोग पहले कौन थे? बार्बर थे, बार्बर. So that is how we started, and I feel happy that our profession has made certain amount of progress that it is contributing to overall health of individuals also now. Now that's my modest setup in Pune. We undertake a lot of advanced dental work, including TMD, sleep apnea management, and implants, and so on and so forth. These are just a few institutes that I have been trained into, King's College and then Dawson Academy and all that. So today we are going to talk about orofacial pain, and these people are really in a lot of distress, and many of you must be seeing them, and they have real vague symptoms, and you don't really know what is going on with them and what exactly is the source of pain and how to tackle that. So many a times it may be just a symptomatic treatment of prescribing medicines and do some hot fomentation and all that, and do some pranayama and meditation and reduce your stress and all that. So we are going to try and delve deeper into the etiology of these problems. The real problem in diagnosing is that they have very vague complaints. There are no patterns to their complaints. The pain is sometimes always shifting, and complaints also can be extremely unusual complaints, and we'll see some of those later on. So when it comes to differential diagnosis, first thing that you should consider is dental pain, okay? But this is one of the easier ones to diagnose because the patient will almost invariably be knowing the source of pain. And in case of dental pain, 95% of times the patient will point at least a region of the mouth from where the pain is emanating. Okay, so that is relatively easy. The other thing is about sinusitis, which is again very, very common and prevalent given the allergies and pollution related problems that people are having nowadays. So here you get pain over the zygoma or the forehead, and pain in maxillary posterior region. It is worse on bending forward, and there will always be nasal symptoms also. Okay, now this is a sort of a crossover area between dental people and medicals or ENT surgeons. So I am going to spend a couple of minutes on this. It is very common for us to accidentally find sinusitis during routine investigations for dental implants. Okay, so we very routinely prescribe something called as a CBCT scan for getting maxillary implants done, and on many occasions we find completely filled up and choked sinuses, maybe unilaterally or bilaterally or both. Sometimes that infection is found to be of odontogenic origin. Because the root tips are extremely close to the floor of the maxillary sinus, there is always a possibility that the infection at the root apices can start communicating with the sinus, and then the sinuses get inflamed and you get polyps, or they are fluid filled and all that. So here you can see that one of the sinuses where one molar was already treated with root canal, but it had a recurrent infection and that had gone into the sinus. Now, why can I say this is because the contralateral sinus is absolutely healthy, and only the other one which is above the treated tooth is got infected. So you do see such polyps. The other thing is trigeminal neuralgia. Again, this is quite, I would say, actually this should be very easy to diagnose, but this is confused by a lot of people. And so it is pathognomonic that these people have current-like sensations whenever the trigger zones are touched or felt by the patient or the examining person. But there are a lot of misconceptions. Sometimes people say that I have trigeminal neuralgia and it is nothing of that sort. The most common thing is that if you prescribe carbamazepine, the trigeminal neuralgia goes down. Okay, if carbamazepine is not working at all, then it is probably something else. Some people also have come to my clinic and told me that I have bilateral trigeminal neuralgia, and that is, I think, one of the, I have not heard of it being existent. So in such cases, you have to go deeper and examine as to what is going wrong. Similarly, glossopharyngeal neuralgia, or what you call Eagle syndrome, which happens due to elongated styloid process. Now, migraine is very common, but it is usually associated with pulsating pain, photophobia, which is again one of the important distinguishing features which can differentiate from the other forms of orofacial pain. And cervical is very, very common nowadays, especially people in our areas working in IT and continuously in front of a desktop screen, and posture has gone wrong, and all such things are causing these problems. So now coming to the main topic of today is temporomandibular disorders. It is a problem that affects the masticatory system. Now, unfortunately, we all, even the dentists, consider our body as made of systems like respiratory, digestive, reproductive, and all that. The dentists have forgotten that we are in charge of the masticatory system, and we have sort of gotten into a habit of looking only onto minute problems of teeth only and treating them, and forgotten that teeth are a part of the system which is called as masticatory system. And the balance of the system is very important. If something affects the balance of the masticatory system, you start having problems in the system. So if the teeth are not able to adapt to the problems, you will have dental problems. If the muscles of the mastication are not able to adapt to the variable problems in the system, then you will start having muscular symptoms. And if the joint is not able to adapt to the problem, then you will have symptoms related to the joint. Okay, so these are the disorders that affect, sorry, I need to read the definition. I am a clinician, so I don't know definitions usually. Any disorder that affects or is affected by deformity, disease, misalignment, or dysfunction of the temporomandibular articulation. And this includes occlusal deflection of the temporomandibular joints and the associated responses in the musculature. So what is exactly occlusion? Occlusion is nothing but bite. Okay? So the way the upper and lower teeth meet each other is called occlusion. This is for the medicos in the room. Okay, now, so TMDs are characterized by intracapsular problems like disc displacement, joint effusion, marrow edema, bony erosions. That is what we call degenerative joint disease. It is the exact same picture that happens in a shoulder joint or a knee joint or a hip joint. Okay. The only difference is in all these joints, both the bones are mobile. In case of temporomandibular joint, the glenoid fossa or the skull is stationary. It is only the mandible that moves. And what is occlusomuscular disorder? These are the ones which are characterized by only muscular involvement and symptoms. So if the joint proper is affected, we call it TMD. If the joint is not affected, but the patient has problems like inability to open the jaw or pain over the face and all, then we call it occlusomuscular disorder. Now very quickly, let's go over the clinical picture. Now these people are extremely distressed. They have incapacitating pain, so their day-to-day life is affected. They may have visited multiple doctors. People usually go to their simple physician, then the physician sends them to the probably ENT surgeon, then another neurologist, and people do get all investigations done, MRI, this, that, brain MRI, whatnot. And they have not arrived on a proper diagnosis. And they are most commonly middle-aged females. What are the symptoms? Whole host of symptoms can be there. There may be many of these in one single case, or there may be a couple, or there may be even one simple symptom like a clicking joint, even though it is painless. Okay? Visual disturbances, there are many symptoms that can be there, and that is why it can create a confusing picture. Now very quickly, I am going to try and just explain to you what is an imbalance. So look at this particular picture. The patient has closed the mouth, but only one tooth at the back is meeting. Okay, and then the patient has to slide the jaw forwards, and only then the other teeth will meet. So this is an imbalance in the system. This is not a smooth closure, and this is what is causing all the cascading problems. So the patient's joint position and dental position are not in sync. Okay, and that's why there is a tussle between two groups of muscles, and that is where incoordinated muscle activity starts, and the muscles remain hyperactive. Once they remain hyperactive, the disc is pulled out of the joint, and that's where you start getting a click. Then the disc will become non-reducible, and then you will have bone-to-bone contact, and then beaking of the bones and erosions and degeneration, and the whole thing will keep on progressing further. Okay, so let me go to this particular X-ray. So you have open and closed position of the joint. So this is the radiological picture. This is the normal joint. Okay, the condyles are very well seated in the glenoid fossa when the jaw is closed, and when you open, the condyles will descend down along the articular eminence, and that is how you will see it. But in case of TMDs, what happens is, this is the normal joint. You will see that, I think I missed one. Yeah, look at this picture. In this picture, you have, even in closed position, the joints they have descended down. So they are not sitting in their right place, and that is why this is where the patient is trying to make the teeth meet by bringing the jaw forwards, and that's why the condyles have gone down. So later on you start having deformed condyles and all that. You will have flattened articular eminence. You will have erosions on the bony surfaces. So what are the reasons? One of the very common reasons is bruxism, which is nighttime grinding of teeth. Why it happens and when it happens, to whom it happens is slightly an enigma, and we have not found out reasons, but whenever that happens, there is enormous amount of tension and pressure on the joint, and that can cause disc displacements and bony degeneration. Another variant of this is sleep apnea related TMD. So people who have sleep apnea problem, they are prone to doing violent movements of the jaw during night to get enough amount of oxygen going down their airway, and that is why when you do those movements, there will be again stress and tension on the joint, which will cause this problem. Okay. And recently, or not very recently, but from last about 5 to 10 years, this triad of TMD, GERD and sleep apnea is supposed or is taken as a syndrome. Okay, and these three symptoms are found in conjunction with each other many times, or in many individuals. And so that is why we have started to call it a lifestyle problem and not really one problem related to masticatory system. And that's why you have to attack the problem from all sides. So lifestyle change is one of the things. Sorry. Now there's one variant of the problem. This is called idiopathic condylar resorption. This happens to, if you see a lot of patients, this will be present in people or especially ladies, adolescent or young adult ladies who will be short in stature, extremely thin, fragile, and their jaws or entire skull is little underdeveloped. And these people start having condylar resorption right in their adolescent age. Okay, and this is one of the very severe problems which we are starting to see more and more. And the best possible correction is surgical reposition, protraction of the jaws and making enough amount of airway at the back which will keep them at, they will have relief. Okay, so how do we manage is, we do something, the basic mainstay of management is splint therapy. We have adjunct treatments like TENS, laser therapy, psychological counseling, lifestyle improvement, all that. And if nothing else, then surgery is there. But TM joint surgeries are not very, very, I would say, predictable or highly successful. So they are done only as last resorts. So what is a splint therapy? It's a removable device to be worn during sleep. It is designed in such a way that the system imbalance, what we saw, is temporarily restored. This keeps the muscles of mastication in a peaceful state throughout the night, and once the muscular pull on the disc is minimized, the disc may get recaptured. Okay, so we take several measurements of the patient and we do a splint, and they start using it every night. Please understand that this is not a night guard. A night guard is given to a patient who is bruxing. So the night guard will not work as a splint, but the splint will work as both, as the splint or a stabilization device and a protective device for teeth. Okay, so it provides symptomatic relief, stabilizes the joint, and it is non-invasive trial for the bite correction. So the flow of the treatment is that once the patient is diagnosed, we give them a splint, then there is a stabilization period of almost 6 to 9 months, wherein we see the patient periodically, we do some changes in the splint that are required. Once we find that on a sustainable basis, the patient is stable and relatively symptom free, typically in my practice it is a period of 3 months that the patient should have relatively negligible symptoms. Only then we can say that the joint is now stable, and then the splint can be discontinued, but the bite correction has to happen. Otherwise the problem is going to recur. Okay, so this at the end just one simple case of TM joint problem, and wherein we ended up giving the patient a splint therapy and the stabilization period of 6 to 9 months, and then whatever bite correction was required was done. So this patient had severe amount of tooth wear. You can see that one tooth which is inside, that was causing the problem. Okay, we call it cross bite. So we now have very, very advanced techniques for doing dental treatments, and we can very predictably and nowadays very quickly rehabilitate patients. But the stabilization period of TM joint, you cannot jump and take shortcuts in that. So at least for 6 to 9 months, the joint has to be stabilized before you take up any kind of rehabilitation, and that is how the treatment is. So in this case, we did splint, then that one tooth which was inside was brought into line with aligners, and then these are little bit technical aspects of the treatment which you may not understand, but it's not required. You need to understand only the basic flow is diagnose, then if you want to do your investigations. The best investigation is MRI for TM joint, because CT or CBCT will not show you the position of the disc. So MRI has to be done, and then that gives you the baseline. And once the patient starts responding to splint therapy, if you want, then you can do another MRI and check what are the improvements that have happened. Okay. And then the splint is discontinued, and then we undertake occlusal rehabilitation or bite rehabilitation. In most of the instances, it is called as full mouth rehabilitation. This can be done purely. Now this patient had a lot of wear and tear on teeth, so we had to restore the teeth also. But if it's a young patient, there is no wear, the teeth are pristine but little aurally arranged, then only braces are enough. Then you don't need any crowns and all that stuff. So it depends on case to case. So if couple of teeth are interfering in the closure, we may even selectively grind those teeth and bring the jaw in a nice closure, which will be in sync with the joint position. So these are the things that help the patient in long term. So I mean, the patient cannot keep on wearing a splint for life, right? So at some point in time they have to discontinue it. So after they discontinue it, you have to undertake occlusal rehabilitation. If you don't, then the problem will recur. So all these patients are in need of help. The general practitioner should identify if the problem is related to TM joint or the masticatory system. They can very easily rule out things. And like how people say that काही वर्षांनी नवरा बायको सेम दिसायला लागतात, तसं काही वर्षांनी हे पेशंट ट्रीट करून करून आमची पण अवस्था अशी होते. But the referring doctor is okay. So you all can relax, we can take care of the problems. Okay, thank you. Thank you very much.
Hello. Excellent session by Dr. Abhijit Lele. We have a question.
How often does bruxism need active treatment?
So bruxism always needs treatment, sir. So because if it is, it depends on the amount of damage that it has caused. So if it is minimal damage onto the teeth, you can prescribe a night guard, and the patient, if they are compliant, they will keep on wearing it. If they understand the seriousness of not having their teeth worn down in early age, they will use the night guard. But if the bruxism is having joint related symptoms, then it definitely needs to be treated. Otherwise, only preventive management in terms of a night guard is fine. But you cannot simply ignore and leave it untreated. So you need to again, we have certain ways into which we can compare teeth at several intervals. So I can actually nowadays overlap a scan done 1 year after I have seen the patient and see the changes. Even if there are little bit of changes, I can know that. So then that is more educative for the patient, and they start understand the seriousness of the problem, and then they are compliant.
Any more questions from the audience? Thank you very much, Dr. Abhijit sir, for the wonderful presentation. And I would like to hand over the mic to Dr. Manish sir.
Thank you, sir, for enlightening us on temporomandibular disorders and orofacial pain. Now I request our chairperson to felicitate our guest speaker, Dr. Abhijit Lele, sir. And I request Abhijit Lele, sir, to please felicitate our chairpersons, Dr. Ashish Karve, sir, and Dr. Aditya Jangam. Now we have a lucky draw over here, which is sponsored by Pushpak Chirmade Oncology Center. अजून एक हाँ ना yes, yes. नितीन देशमुख. No, he's not there.
डॉक्टर हरिओम म्हात्रे 251. डॉक्टर दीपक सूद 215.
Thank you.
गुड मॉर्निंग डॉक्टर्स. पुढचं लेक्चर आहे जर्नी फ्रॉम GP टू कन्सल्टंट. आपले स्पीकर आहे डॉक्टर भूपेश पाटील. चेअरपर्सन डॉक्टर शेवाळे आणि डॉक्टर चित्ते यांना मी विनंती करतो की त्यांनी आपले गेस्ट स्पीकर यांना एस्कॉर्ट करायचं आहे. वेलकम सर. This lecture is sponsored by Health OK Hospital, धुळे. मी चेअरपर्सनना विनंती करतो की त्यांनी आपले स्पीकर डॉक्टर भूपेश पाटील यांचं वेलकम करायचं आहे बुके देऊन. डॉक्टर भूपेश पाटील MBBS FLPS मेडिसिन AFIH physician and intensivist, founder of Health OK, practicing in Dhule. Health OK has empowered 150 plus general practitioners across Dhule, Jalgaon, Nashik, Thane and Mumbai, driving healthcare transformation with one clinic at a time model. या लेक्चरचा फर्स्ट लकी ड्रॉ आहे, घेणार आहोत आता आपण.
डॉक्टर राजश्री चांदोरकर.
डॉक्टर ललित प्रभा पाटील. नंबर 415 अब्दुल राहत वितकर. नाही, नॉट फ्रॉम हिअर. मी माईक घेतो आणि इथून कंट्रोल करू का? येस. ओके. इथं प्रोजेक्ट होत नाही ना ते. प्रोजेक्ट सर स्लाइड होत नाही पुढे, म्हणजे नेक्स्ट होत नाही आहे. ओ सॉरी. ओके फाईन. येस कळलं. नेक्स्ट ठीक आहे. आर वी रेडी? सो थँक यू Raicon 2026 and all the doctors for this great opportunity to represent our new age healthcare startup Health OK Hospitals. I am Dr. Bhupesh Patil, a physician and consultant working at Dhule. So Health OK Hospital is started with a special vision to deliver a standard, ethical, efficient healthcare system all across Maharashtra and later on all over India. So एक standard, ethical healthcare system बनवण्यासाठी मला तुमच्या सगळ्या डॉक्टरांची मदत लागते. आणि इन फर्स्ट फेज ऑफ Health OK Hospital, we are associating with general practitioner, authentic general practitioners, म्हणजे जे BMS, BHMS, MBBS जनरल प्रॅक्टिशनर आहेत, अशा डॉक्टर्सला अपग्रेड आणि अपडेट करण्यासाठी आम्ही मदत करतो. आणि तुमच्याद्वारेच एक बेस्ट हेल्थकेअर सोल्युशन तुमच्या आजूबाजूच्या सर्व पेशंट्सला आम्ही देतोय. तर हेल्थ ओके हॉस्पिटल करतं काय, तर हे अपग्रेडेशनसाठी एक वेल डिझाईन प्रोग्राम बनवला आहे, ज्या अंतर्गत आम्ही या डॉक्टरांचे ऑनलाईन ऑफलाईन सेशन्स पण घेतो. हे विकली बेसिसवर असतात आणि ओव्हर अ पिरियड ऑफ 1 year to 1.5 years हे सेशन चालू असतात. त्यानंतर हे चालूच राहतात, पण मेजॉरिटी एक जो प्रायमरी कोर्स आहे तो 1 वर्षापर्यंत चालतो. आणि आमचं युनिकनेस आहे की आमचे प्रोग्रामचे जे सेशन्स आहेत, आमचे प्रोग्राम सेशन्स आटल्यानंतर आपले सगळे डॉक्टर्स जे आधी ECG करत नव्हते, डायबिटीजची एखादीच गोळी देत होते, हायपरटेन्शनची फक्त एखादीच गोळी देत होते, किंवा फिवर प्रोटोकॉल्स वेगळे होते, त्यांचे सगळे प्रोटोकॉल बदलतात. आणि कन्सल्टंट लेवलची प्रॅक्टिस जशी असेल, ज्या प्रकारे फिजिकल एक्झामिनेशन केलं जाईल एक जनरल मेडिसिन डॉक्टर, त्या प्रकारचं जनरल फिजिकल एक्झामिनेशन आमच्या डॉक्टर्स करतात. कॉन्फिडेंटली ECG, डायबिटीज, हायपरटेन्शन, ॲनिमिया, थायरॉइड असे सगळेच आजार मॅनेज करायला सुरुवात करतात. आणि त्याची गॅरंटी आमचे आत्तापर्यंत जॉईन झालेले 200पेक्षा जास्त सेंटर्स आहेत. आणि त्यानंतर फक्त सेशन्स घेऊन आम्ही थांबत नाही, तर आम्ही आमच्या डॉक्टरांचा हँड होल्डही करतो. म्हणजे काय, एक 24 hour कन्सल्टंट बॅकअपही देतो. म्हणजे जर का ह्या डॉक्टरांना त्यांच्या प्रॅक्टिसमध्ये करताना काही ECG शेअर करायचे आहेत, कधी काही लॅब शेअर करायचे, एखाद्या पेशंटबद्दल काही डिस्कस करायचं आहे, तर तेही आम्ही 24 hour कन्सल्टंट बॅकअप देतो, ज्याच्याने ॲक्च्युअल नॉलेज आणि एक्सपिरियन्स शेअर होतं. आणि त्यामुळे ह्या डॉक्टरची प्रॅक्टिस अजून इम्प्रूव्ह होते. सो नॉट ओनली लेक्चर्स, 24 hour कन्सल्टंट बॅकअप, वी ऑल्सो हॅव अन ॲप, ज्याद्वारे हे सेशन्स परत परत कितीही वेळा अनलिमिटेड टाईम्स बघता येतात. आणि मग इव्हेंच्युअली जेव्हा आम्हाला आमच्या डॉक्टरांच्या क्वालिटी ऑफ हेल्थकेअरबद्दल गॅरंटी असते की त्यांचं फिजिकल एक्झामिनेशन इम्प्रूव्ह झालं आहे, त्यांचं फिवर प्रोटोकॉल इम्प्रूव्ह झालेत, त्यांचं डायबिटीज, हायपरटेन्शन, ECG आणि बाकी पण आजारांचे त्यांचे प्रोटोकॉल आता चांगले झालेत, तेव्हा आम्ही त्यांची मार्केटिंग करतो. हे आमचं एक पॅम्पलेट आहे जे आम्ही ऑनलाईन ऑफलाईन सगळीकडे, म्हणजे तुमच्या क्लिनिकमध्ये पेशंटचा फ्लो वाढावा आणि त्यांचा कॉन्फिडन्स वाढावा. सो हेल्थ ओके तुम्हाला प्रॅक्टिसच्या प्रत्येक स्टेपला मदत करतं आहे. आणि 2 वर्षापूर्वी चालू झालेला आमचा प्रवास आता 200पेक्षा जास्त डॉक्टरांपर्यंत पोहोचला आहे. हे प्रेझेंटेशनसोबत मला एक छोटा टॉपिक पण तुम्हाला सगळ्यांना शेअर करायचं आहे की आम्ही तुम्हाला कुठपर्यंत घेऊन जाऊ शकतो. आणि त्यासाठी एक छोटासा टॉपिक, ॲसिडपेप्टिक डिसीज. जनरली हा टॉपिक मला प्रेझेंट करण्यासाठी मला अंदाजे 3 तास लागतात, बट आय विल ट्राय की 15 मिनिटात मला तुमचा ॲटलिस्ट ॲक्शन प्लॅन तरी तुम्हाला देता यावा. सो ॲसिडपेप्टिक डिसीजची ट्रीटमेंट करताना मेजॉरिटी आपण फक्त काय करतो, पॅन्टोप्रेझोल देतच असतो आणि तिथंच त्याच्या पुढे जनरली आपण खूप कमी वेळा जातो. सो ॲसिडपेप्टिक डिसीज ह्या आजाराचा जेव्हा आपण विचार करू तर पोटाच्या सगळ्या आजारांसाठी आणि सगळ्या कंप्लेंटसाठी, म्हणजे काय, कॉन्स्टिपेशन असेल, ॲसिडिटी असेल, बर्निंग होत असेल, रिगर्जिटेशन ऑफ फूड, पोट फुगतं आहे, ब्लोटिंग होतं आहे, इंडायजेशन होतं आहे, पोटात गोळे येत आहेत, भूक लागत नाही आहे, पोट व्यवस्थित साफ होत नाही किंवा वजन वाढत नाही, असे भरपूर कंप्लेंट घेऊन तुमच्याकडे पेशंट्स येतात. आणि त्यांचं करायचं काय हे आपल्याला कळत नाही. बऱ्याच वेळा हे लाईफस्टाईल रिलेटेड आजार असल्यामुळे हेडेक, मायग्रेन, स्ट्रेस, ॲसिडिटी अशाही कंप्लेंट त्याच्यासोबत असतात. ॲसिड पेप्टिक डिसीज म्हटलं तर आपण पुस्तकामध्ये काय बघतो, GERD, गॅस्ट्रिक अल्सर किंवा डिओडिनल अल्सर, पण राईट फ्रॉम माउथ. सो राईट फ्रॉम माउथ जोपर्यंत तुम्ही GI ट्रॅकचा राईट फ्रॉम माउथ तो इसोफेगस, स्टमक, डिओडिनम, स्मॉल इंटेस्टाईन, सिकम, अपेंडिक्स, कोलॉन, रेक्टम आणि ॲनल ओपनिंग असा पूर्ण विचार करत नाही तोपर्यंत तुम्ही ॲसिड पेप्टिक डिसीजची कंप्लीट मॅनेजमेंट करू शकणार नाही आहेत. त्यामुळे या सगळ्यांचा आपल्याला विचार करायचा आहे. ॲसिडिटी म्हणजे काय, महिन्यातून फक्त जर का 2दा ॲसिडिटी झाली तर त्याला आपण ॲसिड पेप्टिक डिसीज नाही म्हणत, दॅट इज ओनली बिकॉज ऑफ डिस्टर्ब लाईफस्टाईल. पण जोपर्यंत ही ॲसिडिटी ॲटलिस्ट वन्स इन अ वीक अशी जात नाही, म्हणजे आठवड्यातून कमीत कमी एकदा तरी त्यांना ॲसिडिटी व्हायला पाहिजे, जोपर्यंत इथपर्यंत आपण जात नाही तोपर्यंत त्यांना आपण ॲसिड पेप्टिक डिसीज म्हणू शकत नाही आहे. ओके. आणि कॉन्स्टिपेशन ही गोष्ट आपण विचार करायचा आहे. ओके. सो हे मी घेतोच आहे. आपण इंडियन सबकॉन्टिनेंटमध्ये असतो आणि पोटाच्या जेही कंप्लेंट घेऊन तुमच्याकडे पेशंट येत असतील तर मेक शुअर आपले पेशंट डेली एक मोशन तरी पास करतात. WHO ने गाईडलाईन दिल्या आहेत की 1 मोशन इन 3 days to 3 मोशन्स पर डे हे नॉर्मल रेशो आहे नॉर्मल मोशनचा. पण इफ यू आर इन इंडिया आणि इंडियन सबकॉन्टिनेंट आपल्या प्रत्येक पेशंटचं सकाळीच आयडियली सकाळीच मोशन पास झालेलं पाहिजे आणि ते आपलं टार्गेट आहे. तर पोटाच्या सगळ्या आजारांसाठी पहिले कॉन्स्टिपेशन रिलीव्ह करणं आपलं काम आहे. आता ॲसिड पेप्टिक डिसीजच्या आजारामध्ये गॅस्ट्रिक अल्सर, ड्युरिनल अल्सर आणि GRD जर का आपण बघितलं तर फिजिकल एक्झामिनेशनमध्ये काहीच फाइंडिंग नाही आहेत. जर का कोणी म्हटलं की फॅटी ॲब्डोमेन आहे, हेपेटोमेगॅली आहे किंवा एपिगॅस्ट्रिक टेंडनेस, तर दीज आर नॉट कन्फर्मेटरी फिजिकल एक्झामिनेशन फाइंडिंग ज्याच्याने आपण म्हणू शकतो की ह्या पेशंटला कन्फर्म ॲसिड पेप्टिक डिसीज आहे. सो फर्स्ट हिस्ट्री इज द की. ॲसिड पेप्टिक डिसीजच्या आजारांमध्ये हिस्ट्री एलिसिट करणंच हेच आपलं मेन टार्गेट आहे. तर त्याला किती दिवसातून ॲसिडिटी होते, कधी ॲसिडिटी होते आणि काय केल्यावर ॲसिडिटी बरी होते हे विचारणं जास्त महत्त्वाचं आहे. सो हाऊ डू यू डिफरेन्शिएट बिटवीन गॅस्ट्रिक अल्सर, डिओडिनल अल्सर अँड GRD. सर आठवड्यातून कमीत कमी 1 दिवस तरी त्यांना असा त्रास झाला पाहिजे. त्यातला गॅस्ट्रिक अल्सरमध्ये काय होतं तर पेशंट जेव्हा जेवायला सुरुवात करतो तर पहिल्या दुसऱ्या घासालाच त्याला ॲसिडिटी होते आणि त्याचा जेवणातला सगळा इंटरेस्ट निघतो आणि मग ह्या पेशंटला उपाशीपोटीच बरं वाटतं. मग हे ते लोक आहेत ते सकाळी 10ला जेवण केलं तर रात्री डायरेक्ट 8, 9, 10ला जेवण करतात. मधल्या काळात त्यांना चहा पाणी काहीच लागत नाही आणि आपल्याला शरीर वाटतं की 12-12 तास कसं बिना जेवणाचे राहतात. सो जनरली हे फूड अवॉइड करतात आणि इव्हेंच्युअली यांचं वेट लॉस असतं किंवा अंडरवेट किंवा लो BMI म्हणजे आपण त्याला म्हणू शकतो की 18-20 ह्या रेंजमध्ये त्यांचा BM असतो. दीज आर ऑल कॉन्स्टिपेटेड असोसिएशन. गॅस्ट्रिक अल्सरच्या एक्झॅक्टली ऑपोजिट प्रेझेंटेशन असतं ड्युरिनल अल्सरचं. ड्युरिनल अल्सरची ॲसिडिटी होते जेवणानंतर 2 तासांनी. गॅस्ट्रिक अल्सरची जेवणाच्या सुरुवातीला, ड्युरिनल अल्सरची होते जेवणानंतर 2 तासांनी आणि काही खाल्लं की यांना बरं वाटतं. मग ड्युरिनल अल्सरवाल्या पेशंटने जर का चहा पिला तरी त्याला बरं वाटेल. आपण म्हणतो ना की दूध पिलं की ॲसिडिटी जाते, ते ड्युरिनल अल्सरवाले. गॅस्ट्रिक अल्सरवाल्या पेशंटला काही खाल्लं तर ॲसिडिटी वाढणारच आहे, कमी होणार नाहीच आहे. आणि हे फूडी असतात, यांना दर 2-2 तासात काही ना काही लागतं. मग 9 वाजता, 12 वाजता, 2 वाजता, 3 वाजता, परत संध्याकाळी स्नॅक्स आणि जेवणानंतर रात्री पण उशिरा हे काही ना काही पाहिजेच असतात. सो हे थोडेसे वेट पुट ऑन करणारे लोक आहेत. आणि मायग्रेन रिलेटेड हेडेक जे आपण म्हणतो ते पर्टिक्युलरली ड्युरिनल अल्सरवाल्या पेशंटला असतात. ओके. आणि सगळ्यात शेवटचं ॲसिड पेप्टिक डिसीजला अजून एक व्हेरिएशन आहे GRD. GRD म्हणजे गॅस्ट्रोइसोफेजियल रिफ्लक्स डिसीज. त्याची ॲसिडिटी होते जेवणानंतर लगेच. सो जेवणाच्या सुरुवातीला होते का जेवणानंतर लगेच होते का जेवणानंतर 2 ते 3 तासांनी होते. अशी हिस्ट्री घेतल्यावर तुम्हाला कळेल की ह्या पेशंटच्या एंडोस्कोपीमध्ये काय सापडेल. सो गॅस्ट्रोइसोफेजियल रिफ्लक्स डिसीजची ॲसिडिटी होते जेवणानंतर इमिजिएटली आणि 2 तासात त्यांना बरं वाटायला लागतं. ह्यांचे लाईफस्टाईल रिलेटेड प्रॉब्लेम सगळ्यात असतात की रात्री उशिरा जेवण करणं, न चालणं, न फिरणं, भाज्या न खाणं, सॅलड न खाणं, पाणी कमी पिणं आणि बिलकुलच ॲक्टिव्हिटी नसते, फिजिकल ॲक्टिव्हिटी. सो दिस इज हाऊ यू डिफरेन्शिएट की ॲसिडिटी कधी झाली, कशाने रिलीज झाली आणि काय केल्यावर बरं वाटतं. आता आपल्याला कोणत्याही आजाराच्या डायग्नोसिसपर्यंत पोहोचण्यासाठी 3 अस्त्र असतात आपल्याकडे. एक असतं हिस्ट्री टेकिंग फर्स्ट अस्त्र, दुसरं असतं फिजिकल एक्झामिनेशन आणि तिसरं असतं लॅब इन्व्हेस्टिगेशन. सो हिस्ट्री टेकिंग इज द की आणि फिजिकल एक्झामिनेशनमध्ये काहीच फाइंडिंग नाही आहेत ज्या तुम्हाला 100% सांगतील की ह्या पेशंटला ॲसिड पेप्टिक डिसीजपैकी GRD आहे का गॅस्ट्रिक अल्सर आहे का ड्युरिनल अल्सर आहे. मग आपल्याला काय करावं लागतं इन्व्हेस्टिगेशन. पण ॲसिड पेप्टिक डिसीजचा जर का पेशंट आला आणि तुम्ही म्हटलं करा एंडोस्कोपी विच इज द गोल्ड स्टँडर्ड UGSस्कोपी, शक्य आहे का? नाही शक्य. आपलं प्रत्येक पेशंटला जर का ॲसिडिटी झाली ना आपण UGSस्कोपी सांगितलं तर अफोर्डेबिलिटी हा एक मोठा इश्यू आहे. दुसरी गोष्ट जर का मी अफोर्डेबल असेल तर मी लगेच करून घेईल का एंडोस्कोपी? ती प्रोसिजर पण नको आहे ना बऱ्याच जणांना. सो जी गोल्ड स्टँडर्ड इन्व्हेस्टिगेशन आहे ते आपल्याला अवेलेबल नाही आहे. दुसरं एक अजून असतं की UGSस्कोपी, युरिया ब्रेथ टेस्ट, ही पण एक टेस्ट अवेलेबल असते पण ती पण आपल्याकडे लगेच अवेलेबल नसतात. पण काहीतरी इन्व्हेस्टिगेशन करायला पाहिजे टू मूव्ह ऑन फॉर इन्व्हेस्टिगेशन. तर CBC, ESR आणि स्टोलुटी नॉकल ब्लड ह्या जर का 3 टेस्ट ह्या पेशंटच्या नॉर्मल असतील, ESR जर का <20 <40 असेल, CBC नॉर्मल आहे आणि स्टोलुटी नॉकल ब्लड निगेटिव्ह असेल तर अशा पेशंटला 100% ट्रीटमेंट करायला काहीच हरकत नाही आहे. म्हणजे एंडोस्कोपी करून आपण काही वेगळं अचीव करणार नाही. आणि तुम्ही बघत असाल की बऱ्याच एंडोस्कोपी करून पेशंट तुमच्याकडे येतो काय निघतं एंट्रल गॅस्ट्रायटिस, त्याच्याने काय फरक पडणार आहे का? म्हणजे लाईन ऑफ ट्रीटमेंट बदलत नाही आहे. सो विल स्टार्ट जर का 3 लॅब करायचे असतील, या 3 लॅब नॉर्मल असतील सो वी कॅन मूव्ह अहेड फॉर अ ट्रीटमेंट. LFT, RFT, लिपिड प्रोफाईल याचा ॲसिड पेप्टिक डिसीजशी डायरेक्टली काही संबंध नाही आहे, पण असोसिएटेड काही कंप्लेंट असतील तर तुम्ही इन्व्हेस्टिगेशन करू शकतात. आय एम जस्ट टेकिंग यू की हेल्थ ओके तुम्हाला कोणत्या लेवलपर्यंत ट्रीटमेंट करायला शिकवतं आहे. ओके, आता लाईफस्टाईल मॉडिफिकेशन हा एक मोठा टॉपिक आहे. तो जर का मी घेतला तर हे 10 मिनटं कधीच संपून जाते. मी ते घेत नाही, मी डायरेक्ट फार्माकोलॉजिकल ट्रीटमेंटवर जातो आहे. सो आपण विल स्टार्ट विथ फार्माकोलॉजिकल ट्रीटमेंट. हे लाईफस्टाईल मॉडिफिकेशन कसं पाहिजे, सकाळी 6 वाजता उठणं, दुपारी त्याच्या सकाळी 9च्या आधी तुमचा एक वर्कआउट झालं पाहिजे, मग लंच आवर, ऑफिस टाईम, एक पॉवर नॅप इज इम्पॉर्टंट. पॉवर नॅपचं खूप महत्त्व आहे, ते कधीतरी नंतर सांगेल. मग संध्याकाळी 6ला आल्यानंतर तुमचा लगेच डिनर झालं पाहिजे आणि त्यानंतर परत तुम्हाला 2 ते 3 तास मिळतात फॅमिली टाईम आणि अदर ॲक्टिव्हिटीज. दिस इज युअर आयडियल डे. आयडियल डे कसा पाहिजे. ओके, आपण सगळ्यांनी OPDला जायच्या आधी संध्याकाळी तुमचं जेवण झालेलं पाहिजे. हा मेसेज तरी तुम्ही सगळ्यांनी संध्याकाळच्या OPDच्या आधी आपल्या सगळ्यांचं जेवण झालेलं पाहिजे. ओके, सो फर्स्ट स्टेप ऑफ ॲसिड पेप्टिक डिसीज मॅनेजमेंट इज डिवर्मिंग. डिवर्मिंग. आता डिवर्मिंग जेव्हा आपण करतो, आपण काय करतो, एक अल्बेंडाझोल देतो सिंगल डोस आणि थांबतो. पण विथ हेल्थ ओके प्रोटोकॉल आपलं डिवर्मिंग आहे मेबेडाझोल 100 मिलीग्रॅम BD 2-3 दिवस, डल्कोलॅक्सच्या ऐवजी डल्कोलॅक्स आयव्हरमेक्टिन म्हणजे बँडी प्लसच द्यायचं आहे, ज्याच्यामध्ये आयव्हरमेक्टिन प्लस अल्बेंडाझोल आहे. सो मेबेंडाझोल 100 मिलीग्रॅम BD फॉर 3 days, बँडी प्लस सिंगल डोस और कॅन बी रिपीटेड आफ्टर अ वीक. आणि एक खास गोष्ट जी आपण देतो ती आहे बिसाकोडिल. डल्कोलॅक्स मी ब्रँड्स का लिहितो लक्षात राहतात, मला फार्माकोलॉजिकलमध्ये जास्त किचकट नाही बनवायचं आहे. सो डल्कोलॅक्स हा मॉलिक्यूल तुम्हाला सगळ्यांना माहिती आहे. तर डल्कोलॅक्सचं लॉजिक असं आहे की 1, 2 किंवा 3 गोळ्या एका वेळेला रात्री, डिपेंडिंग त्या पेशंटचा कोठा किती जड आहे. काहींचा कोठा हलका असतो, काहींचा जड असतो. इतका डल्कोलॅक्स द्यायचा आहे की त्याला दुसऱ्या दिवशी 2दा-3दा गुडगुड करून पोट साफ झालं पाहिजे, कारण की आपल्याला गॅस्ट्रिक मोटिलिटी वाढवायची. आणि कॉन्स्टिपेशन एक मेजर असोसिएशन असतं ॲसिड पेप्टिक डिसीजच्या आजारांमध्ये. त्याचं पोट साफ, त्याच्या पोटाचे 50% जास्त प्रॉब्लेम असे सॉल्व्ह झालेत. सो इन फर्स्ट स्टेप ऑफ ॲसिड पेप्टिक डिसीज वी आर नॉट गिविंग एनी पॅन्टोप्राझोल. आपण कोणतंच अँटासिड दिलेलं नाही आहे. डिवर्मिंग, कम्प्लीट डिवर्मिंग. आपण जे मायक्रोबायोलॉजीमध्ये शिकलो आहे 40 पॅरासाइट्स, त्यातले ऑलमोस्ट 30 पॅरासाइट्स याच्याने जातात. आता स्टुलुटिनमध्ये काहीतरी सापडेल आणि मगच डिवर्मिंग करू असं काही अपेक्षा नाही आहे. भारतामध्ये प्रत्येक माणसाने 6 महिन्यानंतर एवढं करायला हरकत नाही आहे. ह्याला काहीच कॉन्ट्राइंडिकेशन नाही, आपण सर्रास करू शकतो. सो मेबेंडाझोल, बँडी प्लस अँड डल्कोलॅक्स फॉर 3 days. 3 दिवसामध्ये हा कोर्स संपला, त्यानंतर पेशंटला बोलवायचं आहे 10 दिवसांनी फॉलोअपसाठी. दिस इज फर्स्ट स्टेप ऑफ ॲसिड पेप्टिक डिसीज. मग 10 दिवसांनी जेव्हा तुम्ही बोलवतात, आता विचारायचं की आता कसं आहे. यू हॅव टू टेक अ फॉलोअप ना, की पेशंटला फरक पडला आहे की नाही फरक पडला आहे. आणि जर का 10 दिवसांनी तुम्ही बोलवलं तर ते जर का 100 पेशंट असतील त्यातले 50% लोक म्हणतात सर एव्हरीथिंग इज फाईन, आत्ता काही प्रॉब्लेम. तर 50% लोकांना फक्त ह्या डिवर्मिंगने फरक पडतो. त्यांचा मेन प्रॉब्लेम होता लाईफस्टाईल आणि कॉन्स्टिपेशन. ॲसिड पेप्टिक डिसीज ॲज सच काही नव्हतंच. आणि म्हणजे 50% उरतात त्यांना आपल्याला नेक्स्ट स्टेपला जावं लागतं. ते काय करायचं ते आपण बघू. तो फर्स्ट स्टेप इज मे बी कम्प्लीट डिवर्मिंग, टेक अ फॉलोअप आफ्टर 10 days. आणि 10 दिवसानंतर विचारा की आता कसं आहे. 50% जो पण येईल ते म्हणते पहिल्या दिवशी त्रास झाला पण आता आम्हाला हलकं आहे, पोट हलकं वाटतंय, जेवण जातंय, चालणं फिरणं मोकळं झालं आहे आणि फ्रेश वाटतंय कारण की पोट साफ आहे. सो फर्स्ट स्टेप ऑफ ॲसिड पेप्टिक डिसीज इज ओनली डिवर्मिंग विदाउट पॅन्टोप्राझोल. जर का विदाउट पॅन्टोप्राझोल ॲसिडिटी रिलीज झाली म्हणजे त्यांना ॲसिड पेप्टिक डिसीज नव्हता. आणि मग जे 50% उरलेत त्यांना आपल्याला जायचं आहे सेकंड स्टेप ऑफ ॲसिड पेप्टिक डिसीज विच इज प्रोटॉन पंप इनिबिटर. पॅन्टोप्राझोल, रॅबिप्राझोल, इसोमेप्राझोल, अजून पण भरपूर मॉलिक्यूल आहेत. जो तुमचा फेवरेट MR असेल किंवा कंपनी असेल त्याचं लिहायचं. आपण पॅन्टोप्राझोल लिहायला काही हरकत नाही आहे. बेसिक मी जनरली ते लिहितो. सो पॅन्टोप्राझोल गिव्ह इट फॉर OD फॉर अ मंथ. 15 दिवस देऊन थांबू नका. आपल्याला लॉंग टर्म रिलीफ पाहिजे जो मोर दॅन 9 months 1 year आहे की नाही. 15 दिवसाच्या पॅन्टोप्राझोलने काही फरक पडणार नाही. तर ऑलवेज गिव्ह इट फॉर मंथ. दॅट इज सेकंड स्टेप ऑफ ॲसिड पेप्टिक डिसीज. फर्स्ट इज deworming, Mebex, Dulcolax, Bandy Plus. After 10 days, if patient is still symptomatic, give pantoprazole OD for 1 month. ह्याला काही कॉन्ट्राइंडिकेशन आहे का? काहीच नाही की नाही. एक बेसिक फार्माकोलॉजीमध्ये आपल्याला ह्या मॉलिक्युलर द्यायला काही टेन्शन नाही आहे, देऊ शकतात. आणि मग हे दिल्यानंतर 1 महिन्याने पॅन्टोप्राझोल थांबवायचं आहे. आणि मग 15 दिवसांनी महिन्याभरानंतर फॉलोअप घ्यायचं आणि विचारायचं की आता कसं आहे. तर जे 50% पेशंट उरलेत त्यातले पण 50% म्हणतात की आता बरं आहे. मेक शुअर की ह्या पेशंटचं कॉन्स्टिपेशन रिलीव्ह झालं आहे. ओके. सो ऑलमोस्ट 75% पेशंट तुमच्या स्टेप 2 ऑफ ॲसिडपेप्टिक डिसीजच्या प्रोटोकॉलने सेटल्ड होणार आहे. त्याला काही मेजर सायन्स नाही, आपल्याला हिस्ट्री माहिती आहे, फिजिकल एक्झामिनेशन माहिती आहे, लॅब काय करायची ते माहिती आहे आणि प्रोटोकॉल पण आपल्याला माहिती आहेत. मग आता जे उरलेत पेशंट 25% आणि ते म्हणतात की एव्हरीबडी इज हॅपी की सर बरं आहे, हे चांगलं आहे, आमचं पोट चांगलं साफ व्हायला लागलं आहे, आता ॲसिडिटी खाणं पिण्याच्या गोष्टी बदलल्या आहेत, आम्हाला आता बऱ्यापैकी बाहेरचं पण बऱ्यापैकी सहन होतं आणि घरात आम्हाला आता काही एकदमच कमी तिखट खायची गरज पडत नाही आहे, पण अजून काही बरं होऊ शकतं का असं जर का ते इफ दे आर स्टील सिम्टोमॅटिक, तेव्हा तुम्ही जातात ॲसिडपेप्टिक डिसीजच्या 3rd स्टेपला विच इज अँटी एच पॅलोरी रेजिमेन. आता आपण सगळ्यांनी कोणी HP किट व्हापरलं आहे? ओके, येस. HP किट म्हणजे अँटी एच पॅलोरी किट. जर का तुम्ही किट दिलं तर एका किटची व्हॅल्यू आहे एक पर डे 200 to 250 रुपीज पर डे. तुम्ही लिहिणार आहात महिन्याभरासाठी, तुमचे पेशंट घेणार नाहीच आहेत. 8,000 आणि 9,000 रुपये ॲसिडिटी ट्रीटमेंटसाठी जर का आज कोणी खर्च करणार नाही आहेत आणि जर का खर्च करतील तर जनरल प्रॅक्टिशनरकडे बरं काय येतील, दे विल गो टू कन्सल्टंट की नाही. सो आपल्याला एच पॅलोरी किट द्यायला हरकत नाही आहे, पण ते सोपन करायचं असेल तर रेडीमेड किटच्या ऐवजी हा प्रोटोकॉल द्यायचा. ॲमॉक्सिसिलिन 500 मिलीग्रॅम 202 टॅबलेट म्हणजे 1 ग्रॅम BID, मेट्रो 400 मिलीग्रॅम 1 BID आणि पॅन्टोप्रेझोल 1 ODने चालतं पण 1 BID द्या, कारण की कन्फ्यूज करू नका. एक गोळी 3दा, एक गोळी 2दा, एक गोळी एकदा असं म्हटलं तर तुमचे सगळे पेशंट एकदाच गोळ्या खाणार आहेत. सो आपल्याला आपल्या पेशंटचा सोशो इकॉनॉमिकल बॅकग्राऊंड माहिती पाहिजे, त्यांचं कंप्लायन्स इन्शुअर करायचं आहे. म्हणून ॲमॉक्स, मेट्रो, पॅन 40 सगळ्या गोळ्या सकाळ संध्याकाळ, आणि हे पण 15 दिवस न देता किती दिवस येणार? 1 मंथ. कारण की आपल्याला लॉंग टर्म रिझल्ट अचीव करायचा आहे. अँड आयडियल रिझल्ट फॉर ॲसिडपेप्टिक डिसीज इज रिलीफ फ्रॉम ॲसिडिटी फॉर 9 months to 12 months आफ्टर स्टॉपिंग द ट्रीटमेंट. सो दिस इज स्टेप 3 ऑफ ॲसिडपेप्टिक डिसीज. मला तुमच्याकडनं जाणून घ्यायचं की तुमच्यापैकी किती लोक इथपर्यंत ट्रीटमेंट करत आहेत जनरल बेसिसवर, आणि ह्याला काय हे जनरल बेसिसवर होऊ शकतं. जनरल फिजिशियन, कोणतेही कन्सल्टंट असू द्या, आपल्या बेसिसवर आपल्या OPDला ॲसिडपेप्टिक डिसीजची मॅनेजमेंट करायला काहीच हरकत नाही आहे की नाही. सो दिस इज स्टेप 3. टाईम 3 मिनटं आहेत, थोडं बोलतो. आणि जर का एखादा पेशंट आफ्टर स्टेप 3 99% पेशंटचा किंवा 95% पेशंटचा ॲसिडपेप्टिक डिसीजची मेडिकल मॅनेजमेंट झालेली आहे, यांना काही पुढे प्रॉब्लेम नाही आहे. पण एखादा पेशंट असा आला की सर आम्ही एंडोस्कोपी केली होती, लास्ट डे ट्रीटमेंट घेतली, पण तेवढा फरक नाही पडला, 3 महिने 4 महिन्यानंतर फरक पडला नाही, त्याच पेशंटला स्टेप 4ची ट्रीटमेंट द्यावी लागते. त्याच्यामध्ये काय बदलतं? ॲमॉक्स, मेट्रोपॅन 40 आणि क्लॅरिथ्रोमायसिन. अँड दिस इज कॉस्टली. आपण त्या HP किटची व्हॅल्यू होती 200 रुपये पर डे, ते ॲमॉक्स, मेट्रोपॅन 40 असं वेगळं देऊन 30 रुपये पर डेवर आणली होती. अँड विच इज व्हेरी अफोर्डेबल. तर 1,000 रुपये जर का म्हणायला लागले तर दॅट इज अफोर्डेबिलिटी. सर राईट फ्रॉम 9 to 10,000 किंवा 8,000चे आपण 1,000पर्यंत प्राईस घेऊन आलो होतो. आता हे स्टेप 4मध्ये शक्य नाही आहे, म्हणून हे स्टेप 4 ठेवलं आहे. दॅट इज फॉर रेजिस्टंट केसेस, ज्यांना पहिल्या स्टेप 3पर्यंत गेल्यानंतर पण फरक नाही पडला, त्यांनाच फक्त हे द्यायचं आहे. त्यामुळे जर का तुमच्या पेशंटला 1 वर्ष चांगला फरक पडला आणि तो पेशंट परत आला, सो यू विल स्टार्ट विथ स्टेप 1 फर्स्ट, deworming. Second step is proton pump inhibitor and third step is anti-H pylori kit. रेडीमेड किट देऊ शकतात किंवा ॲमॉक्स, मेट्रोपॅन 40. आय एम 100% शुअर यातली एकही नवीन गोळी मी तुम्हाला आज शिकवलेली नाही आहे, तुम्ही सगळं वापरतात. सो यांना काही कॉन्ट्राइंडिकेशन नाही आहे. आय एम जस्ट गिविंग यू प्रोटोकॉल्स अँड दीज आर हाऊ हेल्थ ओके सेशन्स आर, की जे तुम्हाला माहिती होतं पण प्रॉपर प्रोटोकॉल माहीत नव्हते. आता मला 100% माहिती आहे की इथून पुढे 30 वर्ष तुमच्या प्रत्येक पेशंटचे जर का ॲसिडपेप्टिक डिसीजची ट्रीटमेंट असेल, तुम्हाला स्टेप 4पर्यंत मॅनेजमेंट माहिती होती, जी 15 मिनिटापूर्वी किती लोकांना माहीत होती मला माहीत नाही, पण आता इथून पुढे 30 वर्ष माहीत असेल. आणि ह्याच प्रकारे आम्ही डायबिटीज, हायपरटेन्शन, फीवर, ॲनिमिया लेक्चर इतके सोपे करून सांगतो की लक्षात राहतील. मी तुम्हाला एक ग्रुप बनवला आहे, त्या ग्रुपला प्लीज सगळेजण जॉईन व्हा. माझा स्टॉल आहे 31 नंबरला. एक व्हॉट्सअप ग्रुपला मी तुम्हाला ॲड करणार आहे. आणि मंडळी फक्त मला पहिलं विचारायचं की ॲसिडपेप्टिक डिसीजची फर्स्ट स्टेप काय आहे? ॲसिडपेप्टिक डिसीजची फर्स्ट स्टेप काय ट्रीटमेंट? डिवर्मिंग प्रोटोकॉल सांगता येतील का? व्हॉट इज डिवर्मिंग प्रोटोकॉल सर प्लीज? येस येस, ए बँडी प्लस. सो मेबेक्स बँडी प्लस अँड डलक्लॅक्स किती? 1, 2 or 3 given 2 to 3 लूज मोशन नेक्स्ट डे झाले पाहिजे. सो ह्या प्रकारे हँडहोल्डिंग करत हेल्थ ओके 200पेक्षा जास्त डॉक्टरांच्या जनरल प्रॅक्टिसमध्ये एक खूप मोठा बदल आम्ही घडवला आहे. आणि हा बदल इव्हेंच्युअली आपल्या पेशंटपर्यंत जातो. आणि हेल्थ ओकेचं जे विजन आहे एक स्टँडर्ड एथिकल एफिशियंट हेल्थकेअर केअर सिस्टीम ऑल ओव्हर महाराष्ट्र आणि नंतर ऑल ओव्हर इंडिया घेऊन जाणं, त्यासाठी मला तुमच्या सगळ्यांची मदत लागणार आहे. हा प्रोग्राम कसा घेतला जाणार आहे, कसं करायचं आहे, लेक्चर्स कसे असतील, ऑनलाईन प्लॅटफॉर्म कसा असणार आहे, झूम मीट कधी होणार आहे, त्यासाठी मला एका ऑनलाईन व्हॉट्सअप ग्रुपला तुम्ही सगळेजण जॉईन व्हा. जनरल प्रॅक्टिशनर सगळ्या लोकांना मी सेशन्स घेईल आणि मग नंतर आपण सांगू. नेक्स्ट सेशन जे असणार आहे माझं ऑनलाईन ते नेक्स्ट सॅटर्डेला 9:30ला मी शेड्यूल केलं आहे, तर त्याची लिंक पण त्या ग्रुपवर येईल. तुम्ही हा प्रोग्राम पहिले 2 टॉपिक ऐका, फिजिकल एक्झामिनेशन आणि ॲसिड पेप्टिक डिसीज डिटेल, आणि त्यानंतर ठरवा की तुम्हाला जॉईन व्हायचं आहे का नाही. त्याचे चार्जेस वगैरे सगळं मी कन्व्हे करू. मला वाटतं थँक्यू ऑल फॉर दिस अपॉर्च्युनिटी अँड पीसफुल पेशंट लिसनिंग. थँक्यू.
थँक्यू सर. मी चेअरपर्सन यांना विनंती करतो की आपले गेस्ट स्पीकर डॉक्टर भूपेश पाटील यांचा मोमेंटो देऊन सत्कार करायचा आहे. स्क्रीनवर एक QR कोड डिस्प्ले होत आहे. ऑर्गन डोनेशन आणि बॉडी डोनेशनचा तो QR कोड आहे. ॲडिशनल सिव्हिल सर्जन मॅडमनी आपल्याला रिक्वेस्ट केलेली आहे की या QR कोडला स्कॅन करून आपण याच्याबद्दल माहिती घ्यायची आहे. नाऊ आय रिक्वेस्ट स्पीकर टू प्लीज फेलिसिटेट आवर चेअरपर्सन डॉक्टर नागेश सर. and Dr. Shevale sir. Thank you sir. Thank you. I will hand over mic to Dr. Kamini.
Good morning everyone. Thank you Dr. Kunal Rathod for seamless transition. Thank you Dr. Bhupesh Patil sir for such a valuable information. Sir's Health OK startup is truly ensuring your health should be always okay. So thank you sir. Moving to our next session, I would like to introduce our next speaker, Dr. Kunal Goel sir. He has done MBBS MD DM clinical hematology. Sir is HOD of hemato-oncology, bone marrow transplant and chimeric antigen receptor T cell therapy at Indian Cancer Treatment Center, Mumbai. Sir is a consultant, bone marrow transplant and CAR-T specialist in Kokilaben Dhirubhai Ambani Hospital. He is chief consultant and strategic advisor in CAR-T, trained at Tata Memorial Center, Mumbai, founder member of Indian Association of Cells and Gene Therapy, 7+ year experience in clinical hematology. Sir performed 300+ bone marrow transplant and first CAR-T private setup in Navi Mumbai, including first successful CAR-T in CNS lymphoma. So I would like to request Chairperson Dr. Aditi Karve ma'am and Co-Chairperson Dr. J.R. Edekar ma'am to please accompany our guest speaker to dais. Change करायचं ना.
Okay. You need connect. Madam, Our President and Team Raicon would like to felicitate a special personality in the auditorium, our additional Civil Surgeon Madam,
Dr. Sheetal Joshi. Madam, I would like to call you. Our President and Raicon likes to felicitate.
Thank you. I request Chairperson Dr. Aditi Karve ma'am to please welcome our guest speaker by offering bouquet on behalf of Raicon 2526. Thank you, ma'am. Now it's time for first lucky draw sponsored by MOC Hospital Cancer Research Center, Panvel. Lucky draw. I request our guest speaker to do the honor and take out one lucky winner name from the box. Dr. Prachi Patil. Next. No. Dr. Vishal Vani. Dr. Vishal Vani. Dr. Varsha Gaikwad. No. Dr. Avinash, okay, he's here. Congratulations, Dr. Avinash. Now I request guest speaker to start lecture about topic relapse refractory leukemia and leukemia in the era of cellular therapies, CAR-T case studies. Thank you.
Very good morning to everyone. Thank you for sparing on Sunday morning. And I'm grateful for Raicon Association to invite me. And today we will be discussing about our country's journey in cell and gene therapy. We are now leading force in terms of cancer and treatment. We are providing affordable yet quality treatment, and we are no less than the Western countries right now. In fact, our country is like a destination for medical tourism, not only for the affordable care, but the kind of care that we are providing at an affordable rates. We are seeing the incidents like Canada, where the patient is asked to wait for 8 hours in the casualty and he suffers myocardial infarction. Whereas in India, you can get a super specialty appointment in 30 minutes. Even and the kind of awareness now we are having, it's phenomenal in last 5 years or 10 years, and I believe that in next 5 to 10 years there will be a complete revolution in the field of cancer and oncology. We are in an era where we are not following the Western people, we are just leading them. So this talk is about when science fights back, and this is about the patients who were previously deemed palliative care. So they were sent back home citing that they have no treatment available. So I am Dr. Kunal. I am a hematologist, transplant and CAR-T physician. I do transplants and CAR-T in Kokilaben, Dhirubhai Ambani Hospital. The reason for that is to make transplants and CAR-T affordable, and our cost of transplants and CAR-T is almost equal or even less than Tata. So, in nutshell, a journey of cancer patient. Whenever a patient of cancer, blood cancer is diagnosed, he is subjected to chemotherapy. After chemotherapy, there is a complete remission. Then the patient is subjected to observation and maintenance therapy. Suppose if this cancer doesn't do well and the treatment which is he is subjected to, on that he relapse or progress, then what we do? In blood cancer like lymphomas, we do autologous transplant. In leukemias, we do allotransplants, match, haplos or whatever. So after bone marrow transplantation, the patients have lots of problems like GVHD, graft rejections. There is a long survive, means there is a 1 or 2 year follow-up and everything. Even after that, they face lots of challenges in these day-to-day problems. The transplants are limited to only Tier 1, Tier 2 cities, and the follow-up is very difficult. Suppose even after reaching a bone marrow transplant stage, which in India there is 5% of the patients we are doing transplants out of 100 patients eligible. Then what if the patients relapse on transplant? What do you do? Anybody? If a patient relapse after transplant, what is the options left for these patients? Any guess? What do you do with this patient who relapse after transplant? Nothing. So the patients most of the times is subjected to palliative care. A survival of few weeks. If I say I still have a curative option for these patients, then how many patients would be, how many patients would like to take these therapies? I think nobody denies for this. Everybody wants a curative option. So this is about CAR T cell therapy. When I say this therapy, there is no chemotherapy involved, and this is just a modulation of your own T cells and reprogramming of your own T cells that selectively kills your cancer cells inside your body, and it requires a good understanding of immunology to treat these patients for the possible side effects. So a CAR T. CAR T, the first thought of re-engineering of T cells was started in 1990s. It took a great turn when the landmark clinical trial by Carl June, he treated a girl, her name was Emily Whitefield. She was a case of acute leukemia and she had a relapse refractory disease. After 2 or 3 lines of therapy, after transplant, she was sent home for a palliative care. His father ran from everywhere across the world to find a solution. But everywhere she was sent home. So she met Dr. Carl June when he was trying for re-engineering trials for CAR T cell therapy. The child underwent CAR T cell therapy for initial 7 to 8 days after CAR T cell infusion. She underwent lots of issues like immunological problems. She had a comatose state and she remained in ICU. But after few days in ICU, she received some steroid and then she came out from that comatose state. To the surprise of everybody, her disease was cured, almost gone. So what is all about, why there is so much of excitement for CAR T cell therapy? For relapse, ALL, lymphomas, leukemias, myelomas, everywhere when there is no probability or remission or cure, you have a chance that you can give a good quality life to these people with almost 60 to 70% of CR rate, complete remission rate, in those patients who are heavily treated and in those patients where survival is almost impossible. So this was the girl I was talking about. She is Emily Whitefield. At the age of 6 years, she was sent home as a palliative care patient. Now she is almost 14-15 years cancer free, and she is also married, you know. So this is the life-changing thing that was done. If Dr. Carl June has not taken this case, there was no changes in the field of cellular therapies and gene therapy which we are seeing. In fact, why these cellular therapies, immunotherapy is important, if you see in the last decades, most of the advances in the immunology and cancer therapies, because of the PDL1 and so many other things, has brought the revolution. And I believe in next 5 to 10 years, you will see most of the liquid cancers, maybe 50%, will get cured. So what is CAR T cell therapy? It's a genetically modification of your own T cells. These T cells helps in protection against virus, bacteria and cancer cells. So what happens with these cells when a cancer develops? These T cells are not able to identify a cancer cell, and cancer cell bypass our natural mechanism. So what we do? We modify these T cells, we collect them from the peripheral blood, and then subject to a complicated lab mechanism where this T cells are modified with the help of a virus that contains genetic material, and this genetic material is incorporated in the genome of T cells of a patient. This genome cause a change in the structure of T cells, and it enables to develop receptors which was previously not present in the body. So these receptors in turn, when they are put back into your body, they identify the cancer cell, they multiply like a normal T cell, and they have a memory, and they kill selectively the cancer cells, sparing the normal body. So it has an antibody-like response, like our immunity. It has a cellular therapy response. It has a vaccine-like memory activity. It is capable of rapid proliferation as per the disease, and persistence is one of the property of that. It is independent of HLA, and single infusion is required. So who are the patients who require these? Currently, this is approved for lymphoma, leukemia, myeloma, and autoimmune disease like SLE. So I will be showing few of my cases. Those were the landmark cases, and like CAR-T in the CNS lymphoma. In CAR-T, when there was an extranodal disease was present, I think there is some problem out there. It's okay? Okay. Can you hold on this thing for a minute? Yeah. क्या Can we start?
Hello everyone. Should we proceed with the lecture? Yes.
Yeah.
Okay. All delegates are requested, please be seated.
So I hope the gentleman is fine and he is in a best shape. So, we will be discussing some of the cases for CAR T cell therapy when in different scenarios where they were utilized and how it changed the life of a patient, in a relapse refractory lymphoma, leukemias, myelomas, and so many cases. So this is a story about a 39-year male. He was working in US as a manager in the restaurant, and he presented with the typical symptoms of lymphoma. He had an abdominal pain. He underwent USG. There was a large 10 by 10 centimeter mass in the bilateral adrenal glands, and it was quite aggressive. He presented within 15 days of the symptoms to India, and he came to India when there was a big mass, and PET CT shows the same findings in the adrenal and cervical glands. So he had high-grade DLBCL, CNSAP score 4. He left his job in US hoping to rejoin post-treatment. So like a typical treatment of R-CHOP, he underwent 6 cycles of R-CHOP, and he was thinking that he had a very good response, and he also got the good response. 6 cycles R-CHOP, the disease was gone. So he was hoping for returning back to his home for his work. But fate has something else for him. He presented with severe headache, and this was the first time I encountered this patient. So I read about his history of adrenal glands, so I thought it must be a disease only. These patients with adrenal gland present most of the times with CNS relapse. So likewise, his MRI shows there was a big mass in the cerebellar region. So this was a patient who relapsed within 12 months of treatment. And when there is a early relapse on lymphoma, these patients do very bad with the conventional chemotherapies and autologous transplant. With autologous transplant, even if the patient gets a remission, then these patients have a survival, 1 year survival of less than 5%. So with this, but he had lots of complications as well. His father had underwent leg amputation 1 month back. His mother is a musician who was supporting the home. His brother underwent CAVG at 40 years of age and complicated by stroke. He was all alone with no money left, and then we decided to try with the CNS active drugs like methotrexate, temozolomide, and with this he also received with the MTR there was some hope ignited, and we were hoping that we can go ahead with the autologous transplant if he shows response. But after showing a partial response, the tumor was decreasing. We were happy. But in the 9th week, the tumor increased from 1 centimeter to 5 centimeter in a span of 1 week. So the kind of progression it was so aggressive one, and it was a life-threatening emergency. He went to 8 different places in Mumbai and so many other places, and everywhere he was sent home as a palliative care patient. So he was refractory to chemotherapy, and the disease was again there. he has very less options now, like radiation, whatever we, for these patients we do radiation and followed by lenalidomide or sent home. So with this, we decided like we want to go ahead with the CAR T cell therapy for this patient. And so we decided to go with the CAR T, and CAR T was not approved in the CNS lymphoma settings. So in most of the trials, it was an exclusion criteria for CNS disease. So it was very difficult to prove that CAR T can work in the CNS as well. So we worked with King's London College and so many other places who have tried for some evidence for CNS penetration of CAR T cell therapy. So we did some literature search and everything, but it was not tried priorly. So we tailored a regimen. Our plan was to make the disease blood-brain barrier leaky so that CAR T cell can go inside the brain. So he has received the whole brain radiotherapy, CNS boost and acalabrutinib, underwent CAR T cell therapy, and to the surprise, there was no CNS side effects. There was nothing, ICANS, no ICA and everything, and the outcome was disease-free. At day 28, MRI shows there was no disease in the brain. So it was kind of a surprise for everybody. Even family members were not able to understand whether what worked or what not. And the outcome was he is now post 1 year. He has completed almost 1.5 years disease-free, and he is working as a manager now in Indigo. So this is the story of a patient when there was nothing else. He was not survival. His survival was not there for 1 or 2 weeks, and he is now doing his normal life, enjoying his normal life. So that changed the entire scenario of his life. Another story of a patient from Mauritius. He had a high-grade lymphoma. He received 6 cycles of R-CHOP and again progressed. This time the progression is in the thigh. So he was initially diagnosed as sarcoma. He came to India for second opinion and we did the biopsy review. It was DLBCL. So these patients with thigh mass, they do poorly with all the conventional therapies and almost palliative ones. So we did the surgery. Actually it was sarcoma, so surgery was already done. But we asked the patients to do some immunochemotherapy before CAR T because we have to reduce the disease bulk for CAR T. And he received CAR T cell therapy. And in last December he underwent CAR T cell therapy. He is in complete remission after CAR T cell therapy. And this is life after 2 months of CAR T cell therapy. He was enjoying in his yacht at his home place. And in general, post-transplant patients are subjected to stay in home care and everything. He was enjoying his life. After a palliative care life, he was enjoying his life, And this is 1 year after CAR T. He made stupa at his home place. And recently, he went to Ladakh for his other journey. So, is it? No? So this is, I am not able to move. Yeah. So this is about his life, after CAR T. A patient, palliative one, enjoying his life in Ladakh, and extremes of life. Another one, 72-year male, palliative care in France. No chemotherapy was working on him. It was a big mass in the axilla. 72-year patients, we generally tell, go home. Don't take even the smallest of the chemotherapy. He was subjected to 8 cycles of R-CHOP, 6 cycles of GVD in France. But he couldn't afford CAR T in France. It was too costly, 8 crore rupees. So he came to India. The maximum size of tumor was 17 centimeter in the maximum diameter. And we did the reduced bulking of the disease. And he had complications, immune-related complications, because he had a rheumatoid arthritis underlying. He underwent CAR-T and the disease was gone in day 8 of CAR-T infusion. A story of a girl from Calcutta. This was a girl, 10-year-old, came to us in a state when she presented to us with the brain hemorrhage, foot drop, 90% blast in the bone marrow, 90% blast in the CNS. This was a third relapse. She was diagnosed in 2018, received treatment, had a remission. Then she had first relapse, again received chemotherapy, had remission. But she was so friable because she couldn't undergo transplant under that point. In few days, she had again relapsed. She received blinatumomab costing around 40 lakh rupees at that point of time. She had a response for 1 or 2 years. Then at this point of time when she was 10-year-old, 90% blast in the bone marrow, blood, foot drop, seizure, MRI shows epidural hemorrhage. And on the top of that, she has pneumonia, Acinetobacter baumannii complex. If any intensivists know about this, they know Acinetobacter baumannii is too complicated. In addition to that, she has RSV. It was very difficult to take out those T cells, so we have taken another chance to give some inotuzumab with the excellent care and management for the infection part. She underwent CAR T cell therapy. And now she is doing fine. Her MRD is negative. In between, she had grade 4 HLH, spleen increased from 11 centimeter to 20 centimeter. And there was severe pancytopenia, but magically she again came back, the fighter girl, and responded nicely. Now she went back home to Calcutta and living her life on maintenance. So third relapse, after hemorrhage, after everything, when there was no chances of survival, she survived and doing well. So this is a girl and we discharged her and she is enjoying her life. She had a ptosis, she had lots of things. So another 2 cases with when the disease was 90% refractory, not working, no therapies were working. And we did immunotherapies prior to CAR-T, and after CAR-T cell therapies, they were in remission. These were the reports, MRD negative reports. So my concluding remarks, CAR-T is the future for liquid malignancies and refractory immunological disorders like SLEs, rheumatoid arthritis. It can also work in MS. It is affordable now, and now matching the cost of transplant. It requires extensive immunology knowledge and well-trained staff and plant staff for handling the same. I conclude my talks. Thank you.
Thank you so much, sir, for such an insightful session. I request Chairperson Dr. Aditi Karve ma'am to please felicitate our guest speaker on behalf of Raicon 2526. Thank you, ma'am. Now I request our guest speaker to please felicitate our chairpersons. J.R. Redekar, ma'am. Thank you. I would like to express gratitude towards Kokilaben Ambani Hospital for sponsoring the lecture. Aditi Karve ma'am, thank you. Thank you, guest speaker, for felicitating our chair and co-chairperson. Okay, sir.
I just want to make announcement like I am starting CAR-T trials. I'm enrolling patients, around 40 to 50 patients for the CAR T. Anybody who has relapse refractory lymphoma patients, I can enroll between mid of January to mid of February. So they will be eligible for CAR T product free of cost, and that is a US based CAR T. And the motive behind that is their phase 2 trial already done in US, and they are doing wonders. A 2-year PFS of 80% with that CAR T product. So, and that is ready in 1 day. So we will be starting this accrual after the DGCI approval, which is pending in 1 or 2 weeks. So once this approval is done, so we can take those patients for CAR T cell therapy on a trial basis. So you are free to send those patients who are the needy ones, who we can save life. Thank you.
Thank you, Dr. Kunal Goel sir, and Chair and Co-Chair person, Dr. Aditi Karve ma'am and Dr. Jaya Redekar ma'am. Thank you, Dr. Kunal Goel sir, for such a comprehensive knowledge about CAR T therapy.
As you see on the screen, there is a bumper gift from ICTC Hospital, and this bumper gift will be given at last lecture only. So you have to be present till end of this session, end of this CME. And the bumper draw is Samsung mobile phone worth rupees 50,000.
So now everyone need to stay here till 3 p.m. Not for lecture, at least for bumper draw. So thank you. Now I'll invite Dr. Sheetal ma'am. Before that, I just like to express gratitude towards Kokilaben Ambani Hospital, Navi Mumbai. Thank you for sponsoring this lecture. Thank you.
Good morning, everyone. We now begin the next scientific session of the conference on the topic Robotic Surgery in Gastrointestinal Cancer. This session is sponsored by Kokilaben Dhirubhai Ambani Hospital, Navi Mumbai. And our guest speaker for the topic is Dr. Prasad Pandey sir. I request chairpersons Dr. Dilip Savale sir and Dr. Mahesh Shirsat to kindly accompany our guest speaker to the dais. Welcome. Center. Thank you, sir. I request our chairpersons, Dr. Dilip Savale and Dr. Mahesh Shirsat, to welcome Dr. Prasad Pandey, sir, by offering a bouquet on behalf of RMA's Raicon 2026. Thank you, sir. Before we proceed, may I request Dr. Prasad Pandey, sir, to kindly take out the lucky draw. This lucky draw is sponsored by Mumbai Oncology Center. Dr. Kalpesh Paushe. Dr. Kalpesh.
145. Dr. Rushikesh Urankar, 496.
आहे. Okay. Well, congratulations to the winner. It gives me immense pleasure to introduce our guest speaker, Dr. Prasad Pandey, sir. Dr. Prasad Pandey, sir, is a renowned expert in advanced minimally invasive and robotic gastrointestinal surgery. He is gastrointestinal and hepatopancreatobiliary surgeon. He is Director at Gastron Surgery Clinic, Vashi. Dr. Pandey sir is trained at Nair Hospital, Mumbai and GB Pant Hospital, New Delhi. He has more than 10 years of experience with more than 3,000 laparoscopic and gastrointestinal cancer surgeries. He is an expert in gastrointestinal and hepatopancreatobiliary surgery, pancreatitis, colorectal and liver surgeries. I now invite Dr. Prasad Pandey sir to begin his lecture.
Thank you to the organizers for giving me this wonderful opportunity. And I would first of all like to thank Dr. Kunal. He's given a wonderful lecture on the liquid cancers, as we call it, the blood cancers, the lymphomas, leukemias. And from that, now we come to the solid malignancies, the gastrointestinal cancers and the hepatobiliary cancers. Now, as a group, the gastrointestinal and hepatobiliary cancers form the largest proportion of cancers throughout the world. Colorectal cancers form a large chunk of it, but the liver cancers, the pancreatic cancers are also rising in incidence. Now, when I began my GI cancer journey, that was say around 12-13 years ago, even the concept of laparoscopy for cancers was frowned upon. है ना, लोग बोलते थे कि नहीं, कैंसर में लैप्रोस्कोपी नहीं करना चाहिए, कैंसर स्प्रेड हो जाता है, लैप्रोस्कोपी में कैंसर पूरा नहीं निकलता है, लिम्फ नोड्स पूरे नहीं निकलते हैं. So that was barely 1 decade ago, and from there we have now come to a place where not just laparoscopy but a robotic platform is being used for successful and, as you will see, a better removal of the cancer, the tumors. So the robot that we have is SSI Mantra. It is the first completely Indian developed robot. All the other platforms that are in use throughout India, they may be assembled here, but the parts are manufactured and imported from outside. This is the first completely Indian developed. It has 5 separate arms, which gives you the freedom to use 2 or 3 or 4 arms as may be needed. It is an open console, whereas the other systems currently have a closed console so that you are not aware of the surrounding happenings in the operation theatre. It has head tracking for safety. So the moment you look away from the screen, the robot will freeze. So no movement will occur without you concentrating on the movement. It of course has a 3D 4K vision, and we have a superimposition of 3D diagnostic images. This is something very special which I will come to later. Now, be it a robot, be it a laparoscopic platform, the aim is to do the surgery safely and completely. So what is the advantage of using a robot? The first and foremost is robot offers a 10x vision, which is unparalleled. No laparoscopic platform, even the best laparoscopic platforms, offer a vision of 3.5 to 4x. A robot offers a vision of 10 times magnification. So you can see the smallest of tissue with extreme clarity. At the same time, it is very precise and very accurate. All hand tremors are eliminated. The movements are millimeter perfect. And at the same time, the surgeon's energy is not spent in concentrating on those millimeter perfect events, because the surgeon is comfortably sitting on a chair and operating. It is a robot which performs the precise and accurate movements. And as a result of that, the blood loss is lesser, the hospital stay is lesser, and the recovery is faster. Now, most importantly for most of our working patients, the time to return to work has been less than half of what it was with traditional open surgery. Now, I will show the various cancers in which robotic platform is being used and has been used by us also. Now, liver surgery forms the absolute pinnacle of all gastrointestinal surgeries. But as you can see, even in liver surgeries, do we have a pointer? This one? Yeah, as you can see, with these, that's the pointer. Yeah, with these 4 to 5 small cuts, the entire right lobe of liver is resected and it is delivered from this small incision, which will be hidden under the clothes. So no large incisions, no wound infections, and this was the open surgery incision that used to be taken. Now with robotic surgery, this is what is seen. And even donor hepatectomies for liver transplants are now being routinely done with a robotic platform. So the largest study that was published in AJT of almost 3,500 cases has conclusively proven that donor hepatectomies done with robotic platform have a much better outcome. Now coming to pancreas, which is personally my favorite kind of surgery. This was a large cystic lesion in the neck region of the pancreas. As you can see, this cystic tumor was pretty big and it was causing obstruction of the pancreatic duct also. So at any other center, this probably would have undergone a Whipple surgery with its, the morbidity and mortality related to Whipple surgery. But because of the robotic platform, this cystic lesion, because it was not an upfront malignancy, we could safely do a distal subtotal pancreatectomy along with a splenectomy, along with just these 5 robotic arms. So patient went home on the 4th postoperative day because there was no anastomosis. The patient went home on 4th postoperative day, no ICU stay, no blood transfusion. And the histopathology showed a branch duct IPMN, which is a pre-malignant lesion, but there was no active malignancy. So of course, no question of any chemotherapy. So this is the kind of surgical precision that the robotic platform offers. And with open surgery, this would be a definite Whipple surgery, which has a much higher morbidity. Now, esophagectomy, the unique challenge of esophageal surgery is that you have to open the abdomen, you have to open the chest, you have to open the neck. But now with robotic platform, all of this can be done robotically, and even the reconstruction, the stapling can be done robotically. The closure of the enterotomy can be done robotically. So there is no need for a thoracotomy, no need for a laparotomy, and after this reconstruction, the patient goes home in 4 to 5 days. Now similarly, gallbladder cancer is known for its high morbidity and aggressive biology. But even with that, with robotic surgery, removal of the surrounding liver and lymphadenectomy becomes quite easy. As you can see, the entire liver wedge has been removed, all the vessels have been cleared of the lymph nodes, and the tumor is completely out. This patient went home on the 3rd postoperative day. Now, colorectal cancer is where the robotic platform was initially used with the highest success rate, and as you can see, it has slightly longer operative time, but that is compensated by lesser hospital stay, higher oncologic outcome, more lymph node harvest, and less conversion to open surgery. So if you see across the board, right colectomy, left colectomy, and rectal resections, the robotic platform offers a much better clinical as well as oncological outcome. So this is a case in point where if you can see, this kind of a wrist-like movement is not possible with laparoscopy. It is only possible with robotics. And this was a rectal cancer which was operated using just these 5 ports. And even the reconstruction, the stapling was done robotically. So there is no need for bigger incisions to do the anastomosis. And this was a young guy, 44-year-old guy who was working in a software office. He had upper rectal cancer, he underwent robotic surgery, no ICU stay, no blood transfusion. We could start him on liquids on the 1st postoperative day, and he went home on the 5th postoperative day, went back to work on the 9th day. So with a rectal cancer, if the patient can go back to his routine within 10 days, I think that is something that only a advanced robotic platform can offer. Now this is a special case where we had a 72-year-old lady who was in the outskirts of, the interiors of Maharashtra, and she had persistent anemia for close to 6 to 7 months. Every time she used to just go to her nearby doctor and they used to give her blood. But nobody bothered to check why she was developing anemia again and again. So we did a CT, and the CT showed these arterially enhancing lesions in the first and second part of duodenum. So we did what we call a DOTA scan. A DOTA scan is specific for neuroendocrine tumors. And on DOTA scan, as you can see, we could see one lesion in the first part of duodenum and another lesion in the second part of duodenum. So this was a neuroendocrine tumor in the duodenum which was causing continuous blood loss and leading to anemia. So again, with its proximity to pancreas, with any open surgery, this would have surely resulted in a Whipple's procedure. But with the robotic platform's accuracy, we could do what we call a pancreas sparing supraampullary duodenectomy. We only resected the first and second part of duodenum above the ampulla, and we spared the pancreas completely. So again, no ICU stay, no blood transfusion, and the patient went home on the 4th postoperative day. This is the specimen. These are the 4 tumors that were seen, 1, 2, 3 and 4. Even the scan could pick up only 2 lesions, but with our limited and accurate resection, we could remove all 4 lesions. Now, this is what I meant by superimposition of imaging. This is the urologist who is doing a partial nephrectomy. This is a kidney tumor, and he is using the endobronchial ultrasound probe to do a intraoperative ultrasound. And as you can see, that ultrasound image is being directly projected on the screen of the robotic screen, so that the surgeon can actually guide the ultrasound to guide his surgical resection. And this kind of precision, this kind of accuracy is only available with a robotic platform. So to summarize, any and all cancers can definitely be operated using a robotic platform, mainly because it has an unmatched technological advantage. Most GI cancers, most HPV cancers can definitely be safely operated with better outcomes than open or even laparoscopic surgery. The recovery is faster, the bleeding is lesser, the infection rates are very low, the hospital stay is very short, and antibiotic and analgesic requirement is extremely low. So the most important part is that the oncological outcomes are at least equal, or in most cases they are better, which is what we want for our cancer patients. Now, over the last 1 year, we have done 31 cases on our GI HPV robot, and out of which close to 14 were cancers, 5 were pancreatic or duodenal resections, 6 colon cancers and 3 rectal cancers. The others were benign cases, and in none of these cases were there any immediate complications within 30 days. We only had to convert one procedure to open because of a large and bulky tumor, but apart from that, there was no immediate complications in any of the cancer cases. Thank you.
Thank you, sir, for this insightful presentation. I now request Dr. Dilip Savale sir and Dr. Mahesh Shirsat sir to felicitate our guest speaker. A big round of applause, please. I also request Dr. Prasad Pandey sir to kindly felicitate our chairpersons, Dr. Dilip Savale and Dr. Mahesh Shirsat. Thank you, sir. Thank you. I now request Dr. Amruta Patil to kindly take over.
Thank you, Dr. Sheetal. Good morning, everyone. Our next session, we continue with our next session, that is Technology in Total Knee Replacement Joint by Dr. Yogesh Vaidya, Little Bones, Big Problems, Spotting Orthopedic Issues in Children by Dr. Sandeep Vaidya, Wrist Pain Demystified, a Practical Guide for All Clinicians by Dr. Parag Lad. I request our chairperson, Dr. Vinay Sangre and Dr. Chidanand Nazirkar to escort our speakers to the dais. We are welcoming Dr. Sandeep Vaidya. I request Dr. Vinay Sangre sir to felicitate our speaker. Continue with your scientific session, sir, please.
Okay, thank you. So I am Dr. Sandeep Vaidya. Can I have the presentation? So basically myself, Parag and Dr. Yogesh Vaidya, we are all from Pinnacle Ortho Center Hospital, Thane. Most of you might be aware, but for the benefit of those who are not aware, Pinnacle is a 50-bedded orthopedic super specialty hospital, and I manage the pediatric orthopedic part of it. I deal with children less than 16 years old. Parag does the hand surgery work, and Dr. Yogesh Vaidya does the trauma and arthroplasty. So today, you see, basically for the benefit of our delegates, I'm going to just highlight two conditions in pediatric orthopedics, two common conditions which I see. You may not be seeing these that frequently, but still I'm going to highlight these conditions. And at the end of this, you will realize that to achieve an optimal outcome in most of the conditions, the primary care physician like you has a great role, because picking them up and referring them at the right time makes a great difference in the outcome. So two conditions that I will highlight, say 3 months or 6 months. So that is not the case. Please remember that if a newborn comes with a clubfoot deformity, the easiest thing is treating it as early as possible, because the outcomes are best then. Furthermore, after we start the plaster, remember that the plasters are changed every weekly. It is not that in one plaster we are going to correct the entire deformity. Okay? So every weekly we keep changing the plaster, and with every passing week you will see a gradual correction of the deformity. First week there might be some mild correction, second week it will be better, third week it will be even better, right? And so these plasters we change it every weekly till we reach this stage. So as you can see now from the front, if you look at it, the foot looks completely corrected. Okay? So, and this is at the end of approximately 6 weeks, right? So the foot is almost corrected if you look at the front, but if you turn it from the side, you will see that there is still an equinus deformity. That is, the ankle is, the heel is up, the fingers are pointing downward. And this is because there is a tight, muscle at the back side of the heel, which is called a tendo Achilles. And at this time, we do a minimally invasive surgery called a tendo Achilles tenotomy. And this is an actual video of the tenotomy surgery. It's a less than 1 minute job, an incision less than about 2 millimeter wide, and in which we release that tender. And once that is done, the equinus deformity is completely corrected. So now this deformity is completely corrected. Of course, it is very important that after the deformity is corrected, we need to maintain the correction by application of this special type of braces. Okay, for the first 4 months we need to apply the braces full time, and then we need to apply the braces only sleep time. Okay, and then this deformity is completely corrected. These children do very well. You can see the follow-up at 1 year and then follow-up at 5 years. And these feet, they look normally. These children, they walk normally, they run normally, they can participate in whatever sports they want. Okay, but the key point over here is your role as a primary care physician, picking them up and referring them as early as possible, because the earlier sent, the better and the easier the treatment. We still see cases like this, and this is what I mean by, delayed, presentation, the problems with delayed presentation. Now this is not amenable to just treatment by plasterings and tenotomy. This requires a much more, extensive treatment, which I will come to in a moment. Or we sometimes see cases like this. So this is a clubfoot, but in addition to clubfoot, if you look that the child has a scar on the spine, so this is a spina bifida, a meningomyosal with a clubfoot. And in these cases, the treatment becomes more complicated. And I'm putting up this picture deliberately so you can see that, from a minor, small 2 mm incision, just because the presentation is late or it is a complex presentation, we need to resort to a much more extensive surgery. Even after this type of surgery, we get a good result. It is not that we do not get a good result, but the point is that instead of, needing just a minimally invasive small surgery, now the children has needed much more extensive surgery just because the referral has been late. So that is the importance of early referral. Unfortunately, we still see cases like this. This is a 21-year-old lady residing in some remote area of Konkan, did not ever seek treatment, and now, now that she has reached a marriageable age, has come for treatment. And in this case, the treatment becomes even more complex. Now the bones are completely deformed, and we need to actually cut the bones to set it straight. But the point is, this stage should never be reached. And if we spread the awareness at the root, at the grassroots levels, this situation will never arise. And that is the primary purpose of this talk. If we are able to prevent such late referrals, then it will be a win-win situation for everyone. Now that was about clubfoot. Now I will talk about another, common deformity which we see in older children, and I'm talking about deformities around the knee. And I'm sure, all of you must have seen this. This is the one to the left is a genu valgum deformity in a layman's language. It is called knock knees. And the one to the right, it is called a genu varum or a bow legs deformity. And I'm sure all of you have seen this in your practice as well. However, the point that you all need to know is not every knock knee or every bow legs that present to you is abnormal. So I will just put up, 2 examples over here. To the left, you can see a child who is 15 months old at this stage and presenting with bow legs. The parents are extremely concerned about bow legs. To the right, you can see a child who is now 4 years old, and as you can clearly see, this child has knock knees, has a genu valgum deformity. Now, what if I tell you that both these are normal? Okay? So the key point here is how do you identify normal and what is abnormal? And for this, I think this is the most important slide in this part of the presentation over here. And you as a primary care physicians, if you just remember this chart, you will understand what is normal, what is abnormal. So what this chart basically tells you is that at birth, almost every child has bow legs. Every child is born with bow legs. The extent of bow legs may differ. Some may have it slightly more, some may have it less. But almost every child has bow legs. Then in the second year of life, as the child starts walking, gradually the bow leg starts resolving. By the age of 2.5 to 3, the bow legs is completely corrected. So it reaches an angle of 0. From here on, the bow legs, it starts going in the opposite direction. So it starts becoming a knock knees now. And by the age of around 4.5 to 5 years, it reaches a peak knock knees angle of around 10 to 12 degrees, valgus angle. After which it again starts coming inward and reaches an adult angle of about 5 to 6 degrees valgus by the age of 7 to 8 years. So if you remember this chart, you will know that, okay, this child is falling in this range, therefore this is normal. Anything that does not fall in this range is abnormal. So this child, the one I put up in the first slide, so this is a 1.5-year-old child, has a bow legs. So you know that in a 1.5-year-old child, bow legs is normal. And therefore, this child we chose just to observe. We did not offer any intervention. And sure enough, by the age of around 3 years, he was completely straight. So physiological thing, you have to differentiate from pathological. So that brings us to the question, what is abnormal and how do you treat abnormal? Okay. So this is a child who is almost 4 years old now. And look at it, has a severe bow legs only on one side and the bow legs is almost 20 degrees. So this is obviously not normal. You wouldn't expect to see a Bolex deformity in a child is 4 years old. So this is abnormal. Additionally, if you look at the X-ray, you can see a small defect over there in the tibia. So this is not normal. So this was treated surgically, and after the surgery, the leg alignment was completely corrected. So that is the importance of differentiating what is normal, what does not need treatment, from what is abnormal, which requires treatment, right? So this was the first case. Second case. Now, this is a child again who is around 10 years old and who is presenting with knock knees in this case, right? So almost 10 years old, knock knees, this is again not normal, okay? So in this case, we treat this by a technique called growth modulation, where we apply clips on the adjoining the growth plates. So the whole concept over here is, once we apply the clips, what happens is, as the child's height grows, the deformity gradually corrects, and as you can see, after about a period of 1 to 1.5 years, the deformity completely corrects, and after that the clips, which are known as the 8 plates, they are taken out, right? So this is how knock knees can be corrected in children whose height is still growing. However, please note that for this technique to work, it is important that the children are caught young, and that's again where your role as a primary care physician comes in. You have to refer these children as early as possible before their height stops growing. Only then this simple technique of guided growth will work. On the other hand, if, many times we see this condition where the children are told that, no, wait till your height stops growing, only then you correct it. And then we'll end up with a situation like this. So you can see that now this is a very severe deformity. Additionally, what has happened is that the growth plates have completely closed. So now here that option of offering the simple surgery does not exist anymore. That guided growth surgery is not going to work over here, because the growth plates are already closed, the growth is already over. And in this case, we have to do a more significant or a more bigger surgery, which is called an osteotomy. So in this surgery, we literally have to cut the bone, we have to correct the alignment, then fix it with a large plate. And this all has happened because the child has come in late. If they had come earlier, this could have been avoided. Now, even after osteotomy, we get a good result. It's not that we do not get a good result with osteotomy, but the point is we miss the bus where we could have corrected it with a small, minimally invasive surgery. And that's where your role as a primary care physician in early referral comes in. Also, sometimes we see situations like this. Again, this was a 21-year-old female, okay, had a deformity since early childhood. However, for some reason was told that to wait, and that surgery may have may not have a complete result in this particular case, and therefore they did not undergo surgery at that age. And I will tell you that this is not a very good opinion that she has received. So this is such a severe deformity that in this case we have to treat it by something called as an application of a ring fixator. So you can see as a big apparatus which has been applied. With this, now this is the left side deformity which has been corrected, and then finally the right side deformity was also corrected by the same surgery. But this whole procedure took almost 1.5–2 years. The left side procedure took about 6 to 8 months. Then we give a break of about 6 months. Then the second side procedure took about 6 months. So the point is that all this can be prevented. Early referral is the key to give a good result, and that's specifically the reason why I picked up these two conditions for today's talk. Thank you so much for your kind attendance.
Sorry sir, 2 minute थांबा. Thank you sir for your lecture. आणि प्रोटोकॉलनुसार तुमचं इंट्रोडक्शन द्यायचं होतं ते माझ्याकडून राहिलं गेलेलं आहे, तर मी त्याबद्दल दिलगीर आहे. 2 मिनिट मी सरांचा इंट्रोडक्शन करून देते आहे. ज्यांनी आत्ता आपल्याला लेक्चर दिलेलं आहे, डॉक्टर संदीप वैद्य, कन्सल्टंट पिडॅट्रिक ऑर्थोपेडिक सर्जन, 10+ year experience in pediatric bone and joint disorders, internationally fellowship trained in pediatric orthopedics, 4,000+ surgeries in neonates, children and adolescents. Special interest, clubfoot, pediatric hip disorders, cerebral palsy, deformity correction. Thank you, sir. Sir, please be seated. आपण एक छोटंसं पॉज घेतोय.
Parag sir, just a moment. RMA would actually like to have a special felicitation. We would approbate two persons who are not at all resident of Raigad district. They are from Ratnagiri district आणि गेले 20 वर्ष ते RMAच्या कॉन्फरन्समध्ये सातत्याने येत आहेत, रायगडचे नसून. तर प्रेसिडेंट RMA त्यांना फेलिसिटेट करतील. तर मी प्रेसिडेंटना रिक्वेस्ट करतो की प्रेसिडेंट आणि डॉक्टर सचिन पवार यांनी डायसवर यावं. आणि डॉक्टर पराग वैशंपायन मंडणगडचे आहेत, रत्नागिरी जिल्ह्यातले. आणि डॉक्टर बिपिन शहा विसापूर दापोली रत्नागिरीचे आहेत. तर मी प्रेसिडेंट आणि जॉईंट सेक्रेटरी दोघांना विनंती करतो की प्रत्येकाने त्यांना फेलिसिटेट करावं. ज्युनियर प्रॅक्टिशनर्सनी असं सातत्य CMEs आणि ह्याच्या येण्याचं घेतलं तर कदाचित अनेक गोष्टी शिकायला मिळतील. थँक्यू.
Now I request Dr. Parag Lad to please come on the dais. And our chairperson to felicitate Dr. Parag Lad. Nice sir. Welcome with a bouquet of love. Dr. Parag Lad his topic is wrist pain demystified, a practical guide for all clinicians. He is a consultant hand and reconstructive microsurgeon practicing since 2012. Advanced training at Bombay Hospital, Mumbai, Ganga Hospital, Coimbatore and National University Hospital, Singapore. Expertise in hand and wrist trauma, brachial plexus and peripheral nerve injuries, congenital hand conditions, fractures, tumors, infections and arthritis related deformities. 5500 plus hand surgeries performed successfully. Thank you. I request Dr. Parag Lad sir to continue his lecture.
I feel like coming home, and after long time I am addressing to a gathering of not only a orthopedic surgeon, I am addressing a gathering of all subspecialty. So my topic today, most of us know, I mean at least one patient a week of all practitioner must be seeing a patient of a wrist pain, not in your clinic but at your home also. And most of the time we say it's a muscular pain. But as a clinician, we must know like what are the most common etiologies of a wrist pain. We see fractures around wrist because of the sports injury. Just like we get the twisting injury of the ankle, we get the twisting injury of the wrist. We see many of the tendinopathies because around the wrist there are named at least 30 tendons. So we get some inflammation of the tendons. We see infections, we see tumors. Just like we get the avascular necrosis of the femur, we have avascular necrosis of the wrist bones also. Just like we see arthritis in the knee joint, we also see arthritis in the wrist. In the wrist, there are two important nerves, median and ulnar. They also give compression and they cause tingling, numbness, etc. So I would like to go through each of this. Scope of my talk is we should have some diagnosis, We should have reliable investigation and some case examples. Whenever first message to all clinicians that if any patient is complaining of a wrist pain, just check whether these 4 movements are present or not. For a simple language, ask the patient to do namaskar, ask the patient to do ulta namaskar, ask the patient to do prasad taking action, and ask the patient to do supination. If patient has these 4 movements, most of the things are not able, we may not need a surgical management and they will have a good function. So these are the movement of the wrist, okay? These are not functions of the wrist. The actual functions of the wrist is this, like weight bearing activity, Surya Namaskar, push-ups, pull-ups, or throwing activity, throwing. That is the movement of the wrist, or circumduction, goal, rotation movements. So after checking Namaskar, Ulta Namaskar, Prasad and Ashirwad, you must check that pain, has it affected his daily function or not. So these are the functions of the wrist that you have to first check whenever any patients for a wrist pain. Now the diagnosis is very, very important. Ask the patient to pinpoint where exactly he has pain. You cannot have mala ikde dukta tikde dukta. No, you have to tell him, you tell me where it is the pain. And I am very sure 90% of the patients you will be able to diagnose the condition. Now this lady, I will show these cases in my talk. Then you have to examine wrist into these 5 core areas. Manje काय? The radius is on the thumb side, the ulna is on the little side, little finger side. म्हणून we call it as a radial, we call it as a ulnar. चेक करा पेशंटला रेडियल साइडला पेन आहे की अल्नार साइडला पेन आहे. चेक करा पेशंटला डॉर्सल आस्पेक्टला पेन आहे की पाम आस्पेक्टला पेन आहे. सो दीज आर द 5 एरियाज वेअर यू हॅव टू चेक आफ्टर चेकिंग नमस्कार, function, this point of tenderness. Once you now let us check one by one. If the patient has a radial sided wrist pain, manje base of the thumb, sometimes you see a bump, okay? And the commonest condition is called tendinopathy. The medical word for that is called decurvant stenosynovitis. Terminology is out there, but the thumb extensor tendons, they get stuck and they give severe pain at that region. Okay, and most of the patients, to me, that sheath, once you see the bony prominence, once you release it properly and you see the 3 tendons that are delivered, the patient's pain instantly goes away. So this is the tendinopathy around wrist joint. So that is the simple operations done under local anesthesia. But make sure all these patients who have radial sided pain and we diagnose it as a tendinopathy, so you please take a X-ray, because you see there is a movements are normal, mag tumhala X-ray kashala pahije. The reason to take a X-ray, you will miss the tumor underneath the bone. The same patient who was supposed for the tendon operation, but somehow she were known to us and they came us for opinion. All investigations were done. Usually they do sonography because the tendon problem was diagnosed. But we took a X-ray and this patient had a tumor in the distal radius. And the cause of pain was on the radial side. The treatment is completely different. Now, as a clinician, we must understand the wrist X-rays properly. How do you understand the wrist X-rays? So whenever see a X-ray, make sure that you see these 3 parallel lines. If there is any line distortion, refer this patient to orthopedic surgeon. So make sure that these 3 parallel lines you see on the X-ray. That's all. If you don't see this parallel line, there is something wrong. Okay, so this is the second message that I want to give. Then there are something called spaces. What does the space mean? Okay, so this is the space. So these are the carpal bones. We don't need to know the names of these bones, but all these spaces are equal. Suddenly I see some space is increased. So that is the ligament injury and this requires a surgery. This is a Terry Thomas sign because this person had this gap. That's why they had described this sign. Forget the name. These are called spaces. Then, so this is the normal X-ray. All spaces between all carpal bones are normal. If you see any space that is more, there is a problem. Then sometime you see parallelism, means every carpal bone has parallel axis. They are never distorted. Every axis is parallel, but suddenly you see here loss of parallelism. So that means there is a problem in these two bones. These patients will have pain, less movement and a movement. Now you see a family physician complaining of a wrist pain, no history of trauma. And technically speaking, there was nothing visible outside. Of course, everybody will take a X-ray first, but this patient had severe tenderness and you have to do a really high quality MRI, and this patient had a occult ganglion. The size of the ganglion cyst was 0.5 centimeter, but it was on the nerve called posterior interosseous nerve and it was giving us severe pain, and this is the cyst that was causing the pain. So even if the X-ray is normal and if the ganglion cyst can be, cause this pain. Now see the face of this patient. I am pressing, ask him, where is the pain? He is complaining of pain at the snub box and radial side. So most of the patient after fall, there are only two diagnoses, either distal radius fracture or a scaphoid fracture. Now see where I am pressing. I am pressing in the snub box. And don't treat this patient lightly. Now this patient was taken an X-ray. There is something called ring sign. So this is the ring sign in the scaphoid. So there is again some doubtful. So this X-ray, anybody will label it. And then this patient, we have to do a special view and we label it as an undisplaced fracture of the scaphoid, and that was treated in a plaster. So that is the fracture, undisplaced fracture. Scaphoid is a very notorious bone. 60% cases it does not heal. It requires surgery. Now this patient had a good wrist of movement. But again, as I told you, something wrong in the X-ray. If you are in doubt, if your X-ray is abnormal, please take opposite side X-ray. So this patient's opposite side X-ray, so left side was symptomatic, right side was a problem. So now you try to see each bone. And here what I observed, the lunate of this bone was normal and the shape here was abnormal. So this is the condition where avascular necrosis of the lunate bone also can occur. It cannot happen only in the femur, it can happen in the wrist also. So this bone had a different blood supply, and the surgery we performed, we removed that bone and articulated the distal joint into the radius, and she had an excellent function. Now the next, so as I told you, now see this patient. He came to us 3 months after the fall with restricted movement. This is the normal movement. This was the restricted movement. As I told you, you have to draw three arcs. If the arcs are not, now I am not seeing 3 arcs here. So that means there is a problem. There is a problem in the corpus. So how do we identify that? Now this is one X-ray. This is radius. Okay, this is radius. This is lunate. This is capitate. They form one line. Always see that. But if you now that same patient's X-ray, radius, lunate and the capitate was behind and the line was not maintained. It was missed by even orthopedic surgeon. But it is common. So you have to see this. 3 bones should be well aligned, and that was the lunate fracture dislocation. The same patient, this is normal, this is abnormal. This requires surgery intervention. Now 62-year-old female, she was operated, she had these sinuses and these were the fracture, she had this fracture. She was treated by K-wiring, which is normal, there is no problem at all. But 3 months post-surgery, if the patient has pain in the wrist and cannot move the wrist, and if X-rays are well treated, then you have to suspect something called osteomyelitis, if there are discharging sinus. Now there was some bone was eaten away with the infection. We did MRI, there was a gap, and then this was a large sequestrum. A simple K-wiring in the wrist can cause osteomyelitis. So we had to do, complete curettage and the treatment. The another thing that I would like to mention here is another patient. Some investigations we have to do, and okay, so this patient had a restricted pronosupination, and you have to make sure that if there is a supination was normal, but the pronation was restricted. See, the pronation was restricted. She had dislocation of the joint, and that required a proper open reduction and surgery. So the conclusion message here I would like to give in these cases, that another case that I would just like to mention here, that the patient has pain on the ulnar aspect of the Guyon's canal, and the patient had clawing of the hand. She had pain here, but the clawing of the fingers were missing. So that means there was compression of there was a wasting of the muscles in the hand. So this patient was, everybody she was telling there was a pressure here. So we did the MRI and the MRI suggestive of the ganglion cyst that was causing pressure on the nerve, and ulnar nerve was completely free. To conclude my talk, if you find tenderness in the snub box is here, identify scaphoid fracture. If you see pain on the dorsal aspect of the wrist, identify some ganglion or avian of the carpus bone. If you find restricted pronosupination, Prasad Ashirwad movement, if it is restricted, there is a problem in distal radioulnar joint. If you find wrist pain with numbness and tingling in the hand, there is a problem not only in the bone, there is a problem in the nerves also. And if you feel local warmth and painful movement, please mention about, look for infections in the wrist. Thank you so much for your attention.
Thank you, Doctor, for this wonderful and informative lecture. Now I request Dr. Yogesh Vaidya to come on the dais, and our chairperson to welcome him with a bouquet of flower. I am privileged to introduce our speaker, Dr. Yogesh Vaidya. He is a consultant joint replacement and trauma surgeon, 15 plus years experience in orthopedics, trauma and joint replacement. Practicing in Thane since 2004. Founder of OrthoCare Hospital and Pinnacle Ortho Center Hospital, Thane. 5,000 plus surgeries including primary and revision joint replacement. Sir's today's topic is technology in total knee replacement. Please continue with your lecture, sir.
Thank you and good afternoon everyone. First of all, let me thank Raicon for giving us this opportunity to talk here. So robotic surgery is the latest buzzword in the field of surgery nowadays. So in the previous lecture we saw role of robotic surgery in GI surgery. Now we will see role of robotic surgery in joint replacement arthroplasty. So as we all know, osteoarthritis is the most common indication for which we do a knee replacement surgery. So whenever a patient for a knee pain or advanced arthritis comes to us and we advise him knee replacement, the first question they ask us is, "Mala chalta yeil ka operation nantar?" So there is a lot of fear or lot of apprehension in the minds of patient when we advise them knee replacement surgery. So why that is so? So if we look at the literature, there is almost a 20% rate wherein patients are not satisfied with their surgery world across. So when we dig deeper into this, we find out why the patients are not happy with their surgery. So if we see the traditional knee replacement which was performed before the advent of robotic surgery, it was all based on the surgeon's skill and use of traditional instruments or jigs which we used to use to cut the bone. So it was like a one size fits most approach, and it was all based on intraoperative landmarks wherein the surgeon could go wrong at times or there could be some human error in the surgery. So there was some kind of a dissatisfaction rate amongst the patients. So what are the mechanical goals to achieve an ideal TKR? First is to restore the alignment, preserving the joint line, maintaining the soft tissue balance across the knee, and ultimately it should have a good patellofemoral tracking. So where is the problem? Why the knee replacements are failing today? So most common cause is instability, wherein the soft tissues around the knee are not properly balanced, or there is some kind of a malalignment. So better alignment leads to improved outcome, which leads in less wear and better implant survivorship. So knee implants may last longer when accurately aligned. So many times patients ask us, how long will that last? Will I have to undergo another surgery maybe after 5 years or 10 years? So yes, that was the case previously, but now with advanced kind of implants that are available and better surgical techniques and robotics, we can safely tell them that they can last for around 20-25 years. So how we can improve or how we can use technology in our surgery. So these are the previous instruments which were used for, of course they are used still today, for doing the TKR. So these are a little bulky instruments. There were use of intramedullary rods which lead many a time, there was a theoretical risk of causing fat embolism in during the surgery. So these were kind of conventional TKR instruments which were used. So it was more of a one size fits all kind of approach. So we had some standard sizes and standard jigs which we used for all the patients. So why should we use technology? Now first, technology we are to use to reduce the human errors which are happening during the surgery. So, and what should that ideal technology be? So whenever we are introducing technology, it should not be a costly technology. It should not have a more of a large learning curve. It should not increase the operative time, and it should not, the cost of the technology should not be passed on to the patient. Previously, when we started doing robotic surgery 2 or 3 years ago, firstly, it was many of our colleagues used to label it as it's just a marketing tool, nothing more than a marketing tool. There is nothing more to it. We are doing it for so many years. Why we need technology? But then now as the results are coming, they are also starting to accept the role of technology. So the first precursor to robotic surgery was a computer assisted surgery, wherein if you see this, there was a camera which was there, and the patient's knees were applied some kind of infrared trackers. So the data was relayed to the camera, and the computer used to create a 3D model. But however, in this computer assisted surgery, only the computer used to give us a plan. Ultimately, the surgery used to be carried out by the surgeon only. So again, the role of human error was there. So in the next advancement, then came the robotic surgery. So in the robotic surgery, these are the various robots that are available in orthopedic surgery today. So it helps not only to plan the surgery, but it also helps us to execute the surgery. So execution part is the most important part. Planning, it was always there with the computer navigation also. So another thing is that when patients come to us for robotic surgery, they feel that some robot is going to perform the surgery. So firstly, we have to drive out this misconception that it is always a robotic assisted surgery, not a robot doing the surgery. So robot assists the surgeon in doing the surgery. In general surgery or the previous talk, we saw the robot was actually doing the surgery and surgeon was sitting remotely away from the operating field. But here, the surgeon performs the surgery and the robot assists the surgeon. So this is the Cori or the Smith and Nephew system which we have in our hospital. So this is one of the most compact and very small footprint kind of a robot. It is very portable robot which we have. So as I was telling, it is not just a marketing tool. There is definitely some advantage to it which we will see in the next few slides. So why we really need technology? Is every need same? No, the answer is different. There is something called as a constitutional virus. So what our previous thought process was that when patients develop osteoarthritis, gradually as the deformity progresses, he starts to develop more and more deformity and more virus. But if you see your own self or your own relatives, you will find that many of them at a younger age also have some element of varus or valgus deformity. So that is not a pathological deformity. So that we label it as a constitutional virus. So the problem happens when a patient is having a slight amount of varus or a valgus deformity all throughout his life, and then when you suddenly correct him to a neutral alignment, then he is not very happy with the results. So that is where the main role of robotic surgery comes in. So if we see, every person has got slight different alignment of their knee joints. No two knees are the same. So it is more of a personalized and a customized alignment or a personalized surgery. It is like a tailor-made fit for the patient. Previously, we had a standard set of implants or standard set of jigs which we used, and we used to try to fit in every patient with that implant. So this is more of a personalized and a customized alignment. So this is more, so here how the robot works with the surgeon. So first it helps to map the knee joint. So it helps to create a 3D model of the knee joint. It helps us to understand the deformities and the defects. It helps us in planning the surgery. We can know in real time before the final placement of the prosthesis how the prosthesis will be placed in the patient's body after the surgery. how much of soft tissue to be released, and how the execution and sculpting of the bone can be performed according to the plan. So what are the benefits of the robotic assisted surgery? It helps in improved accuracy, significantly improved patient outcome measures, decreased blood loss, decreased post-operative pain, shortened length of hospital stay. Previously, patient used to stay in the hospital for around 5 days, 7 days. Now we can discharge the patient within 3 days. Abroad, they do it on OPD basis. They send the patient home the same day. So earlier return to active lifestyle can be achieved with the help of robotic surgery. So what are the different steps in robotic surgery? First is we have to do, we'll see them in the next few slides. We have to set up the robot. We have to do the registration. That is, we have to feed the data to the patient robot. Then there is a stage of implant planning. Then we cut the bone as per the plan. Then we validate the cuts. That is, we verify whether the cuts are correctly performed. And then we do the trial implantation. If everything is fine, then we go ahead with the final component cementation and closure. So this is a typical setup for the robotic system, wherein the patient is draped. The robot is on the other side of the surgeon. So this is our setup wherein we are performing the surgery. These trackers, the blue dots which are there, they are attached to the patient's leg. So they help to transmit the data to the computer. So here I am providing the data to the robot. We map the patient's joint. That is, the computer has to know what is the size or what is the actual anatomy of the patient. So we have to map the joint. So here we are doing I should just show, this is a image-free registration. So what we are doing is that I am actually painting on the patient's knee, and the same data is being picked up by the computer. So the computer is now creating a 3D model of the patient's anatomy. So once that is done, it helps to give us a plan. So the computer has now provided a plan for this patient. So whatever is the size of the implant, what was the pre-operative deformity, what was the previous range of motion, all these things are picked up and given to us by the robot. So once this plan is approved or we are okay with the plan, then we go ahead with the execution. So now this is the main heart of the robot, that is the robotic arm. So at the end of the arm there is a burr kind of a round thing which is there, that helps to cut the bone, and the blue circles which are there, they are the trackers. So they help in verifying that we are doing the right thing. So here we are doing the removal of the bone. So the best part is that the burr which is there, it marks his own boundaries. So it's like a Lakshman Rekha for the burr. So even if the burr crosses, we put the burr on a normal part, it won't run. But once it is placed on the affected part, it will start to run. And once the level of resection is achieved, it will automatically stop. So here you see once it becomes white, that means the level of resection is achieved. So similarly for the tibia, it is doing the same thing. The surgeon is cutting the bone. So there is no evidence of any human error now which can happen in this. So if you want to cut 3 millimeter, only 3 millimeter will be cut. So that is the best part of the robot. So we can assess the gaps throughout the range of movement. Actually we can see, we move the joint through the whole range of movement and see all the gaps are balanced. The joint is balanced throughout the range of movement. And so this is the graph which we get at the end of surgery. And once this is how the bone prepared bone looks like before the implantation, and this is how we have the final implantation. So the robot guides us to do the surgery accurately without any error. So what are the additional goals? That the surgical time should not increase as a result of technology. There should not be any increase in the infection because of increased OR time. The patient's pain has to be reduced, the stay has to reduce, and at the end of everything there has to be a happy surgeon and a happy team, and the patient has to be happy only if the cost is effective to the patient. The technology should not be passed on to the patient. Last slide. To conclude, technology, technology and teamwork all go hand in hand. Robot for knee replacement has brought a paradigm shift in the way we perform our surgeries. It forces an average surgeon to think, plan and become better, and a good surgeon to introspect and adapt. Technique, common sense and good team are essential. The best way to predict the future is to create it. Now, and with the advent of AI, I feel the picture abhi baki hai, the more is yet to come. Thank you. Thank you for a kind hearing.
Thank you for this wonderful and informative lecture, sir. Today's session was sponsored by Pinnacle Hospital, Thane. I request our chairperson to felicitate our guest speaker, Dr. Sandeep Vaidya, Dr. Parag Lad, and Dr. Yogesh Vaidya by offering a memento on behalf of RMA Raicon 2026. थांबा सर काढायचं हो हो तिथे आहे दोन देते
A special reference. Parag is our own member of KMA. He is son of our past president, Dr. B.G. Lad. He is son of RMA secretary of 2009-10 body. So this is an honor for us to see how Parag has escalated in his field. And congratulations, Parag, and all the best.
Thank you.
I request our speakers to do the honors for the lucky draw sponsored by MOC Hospital, Panvel.
Dr. Aniruddha Joshi.
Dr. Aniruddha Joshi. Please. सर त्यांचंच नाव आहे ना
कर्जाची परतफेड केलेली आहे.
I request our speakers to felicitate our chairperson. Sir, एक minute. Please, sir. Felicitate our chairpersons. Dr. Vinay Sangre and Dr. Chidanand Nazirkar. This lucky draw was sponsored by Dr. Pushpak Chirmade, Cancer Care at Panvel, Vashi and Thane. I request Dr. Aniruddha Joshi, sir, to continue with next sessions.
Let us continue at our next session. Topic is on oncology by Dr. Amit Ghanekar sir. I request Nazirkar sir and Dr. Sanjay Kurungole to please escort Dr. Ghanekar sir to the dais. Ali. Dr. Sanjay Kurungule is President-elect for 2027 RMA. I request Dr. Kurungule to please welcome Dr. Ghanekar sir. A special bumper prize is been announced by Indian Cancer Treatment Center of Dr. Ghanekar sir. It has been displayed. It is probably a high-end mobile. This is what I don't know, sir, but we are being told that it is 50,000 plus the cost of the mobile is. So I request all the delegates to be in the auditorium because this probably will be presented by sir himself after the lecture. This is what is been told by sir. Last. Okay. RMA president says that it will be given at the last. Will do. I request sir to please do the honors of lucky draw ceremony which is sponsored by MOC. Dr. Ganesh Mengad. Dr. Ganesh Mengad. Dr. Bhagyashri Kulgude. Ghanekar sir has completed his MD Internal Medicine and DNB Medical Oncology along with his fellowship in oncology and bone marrow transplantation. A senior oncologist with more than 22 years of experience providing advanced and comprehensive cancer care across all the malignancies. Sir has served at leading hospitals including the Jaslok, Nanavati, Prince Ali Khan. He specializes in stem cell, bone marrow transplants and treatment of complex cancers such as leukemia, lymphomas, myelomas, as well as rare immune diseases. Known for his precision about approach to chemotherapy, radiotherapy and targeted therapy, Sir is currently attached with the Indian Cancer Treatment Center placed in Kalyan, Dombivali and Ulhasnagar Center. Sir, the mic is all yours.
Hello. Yeah. Good morning, everybody. I hope I keep you awake and engaged. Thanks, Raicon, for this wonderful opportunity. And a slight correction before I begin. Indian Cancer Treatment Center is a chain of chemotherapy daycares which is formed by like-minded oncologists. It's not just entity by Dr. Ghanekar himself. He's a part of it. So, as I was just going through the list of talks, many of the topics were about oncology. And that is because oncology is all about cancers. Cancer seems to be going up. We are seeing lot of complex cases, young patients. The moment you say cancer, zameen halleli aste. Patient, natevaik, family physician, caregiver, bazuche auntie, buildings are watchmen. Everybody has a say. So people do reach our OPDs, but they reach with biased minds and lot of negativity. So this is how it is perceived today. So my topic is to brush up some practical aspects, give you some insights. We are definitely far more better than probably what we were when I started my practice. So it definitely is the most top topic. Killer cancer. I mean, it just kills. Non-communicable disease में number 1 आला है. Our OPDs today are this way. 1/6 of the patients are metastatic. Half of them are locally advanced because we can't treat everybody correctly. Many of them relapse also. And what is more alarming is we are seeing lot of younger patients, lot of aggressive types. As I was just discussing with one of my colleagues here, it is not very weird to see a 28-year-old lady with a breast cancer, 38 with a lung cancer, 42 with a myeloma, 50 with a colon. They are like coming 15-20 years ahead as what is described. So if cancer seems to be pounding us, are we better? I would prove by the end of this talk we definitely are. We have made some dramatic advances in diagnostic modalities, therapeutic options, and we have learned to define our enemy far more better. So not all of them are alike. We are in the era of what we call as precision oncology. प्रत्येकाला काहीतरी वेगळं मिळणार आहे, a tailored made approach. And as I get a phone call की सर स्टेज 4 आहे काय करू, my answer is यार पाठवून दे, बरंच काही करता येईल. Outcomes have definitely improved. कारण यमाचा रेडा दिसला की मरायचं कोणालाच नसतं, in my words. So we can make them live longer. So today we have people 80 plus, 90 plus being treated. We have quoted a few examples. So this review is like the team captain, which is the oncologist, looking at the cancer scenario. Perceptions, facts, why is it unique? What are the ominous symptoms and signs? An entity called as incidental cancers. What are the non-chemo oncotherapy options? Myths and facts, which we all need to echo strongly. And some high-end things. But at the end of the day, I always feel it's a team effort. We require a dedicated team which has to be led by a qualified oncologist. कारण जसं मी क्रिकेटमध्ये एक्झाम्पल देतो, I am the batsman number 5, 6 or 7. It will all begin with you. So that is the need of the hour. So now why are we so hellbound on precision oncology? Why are we trying to insist की प्रत्येक कॅन्सर वेगळा आहे, प्रत्येक ब्रेस्ट कॅन्सर फॉर दॅट मॅटर वेगळा आहे? ते विल जस्टिफाय बाय दिस फ्यू एक्झाम्पल्स. सो टिपिकली अ ब्रेस्ट कॅन्सर लेडी ओपडीत गप्पा होतात, तुलना होते, तुला किती 4 किमो, मला 1 वर्षभर का? तर कारण असं असतं की ER/PR पॉझिटिव्ह will give hormonal therapy. The lowermost type, everything negative, we will be giving aggressive chemotherapy. And HER2 positive, we will be obviously combining chemo and the hormone with anti-HER2 therapy. So definitely they are unique. Another example is of a lymphoma. As we have tried to different types that we'll end up with, we tell them that all of them are lymphoma, yes, but all of them are different cancers. And each of them merits a different type of chemotherapy. It can be aggressive R-CHOP, it can be slightly peaceful R-BENDA, it can be a simple tablet like ibrutinib, or it can be, as Dr. Kunal spoke about, CAR T-cell. So lymphomas definitely are just not the same. Similarly, a prostate cancer example, as we are seeing more longevity, people are reaching 80s and 80 plus, the number of prostate cancers is sizably gone up. Paradoxically, we are also seeing prostate cancers in 50s, which was not really heard of 20 years back, 15 years back. So each of these situations is a different prostate cancer patient for me. A castration sensitive, it will be only hormonal tablets. 56-year-old fellow, I will be hellbound on gene mutations. Somebody with liver mets, I will be going for aggressive chemotherapy. And that definitely probably is good enough to say that we should have an approach of not one size fits all. So what is the need of the hour? When the numbers are rising and the causes really are not known, you need to be extra aware. You need to be suspecting everything. प्रत्येक गाठ कॅन्सर नसते, पण सस्पिशन स्ट्रॉंग पाहिजे, कारण मोस्ट ऑफ दिस पेशंट्स आर लाईक दिस जेंटलमॅन. बी व्हेरी प्रोएक्टिव्ह इन्व्हेस्टिगेशन्स. तपास करून नाही म्हणा, कारण टीमली रेफरल मॅटर्स. देन कम्स अवर रोल फॉर द करेक्ट ट्रीटमेंट, बिकॉज इट इज द टायमिंग दॅट मॅटर्स द मोस्ट. Especially even in stage 4 cases, we can meaningfully extend their life by appropriate sequencing, which is our role but comes later. Because the later you diagnose, the stage goes up, the outcome prognosis dramatically comes down. So let's brush up the common cancer warning signs. Sudden onset retention, sudden onset constipation, loose motions, non-healing stool, menopausal lady with a PV discharge, black color in the motions, pain or painful hematuria, any lump in the breast that is hard, menopausal lady with a painless lump in the testis, sudden onset of difficulty in swallowing or unexplained digestion, not well. So these are the things we all are aware. They are labeled as the classical warning signs of cancer. What is missed is the second part. There are certain signs, patient may not tell you directly, but you have to pick them up. Weight loss, unexplained significant. It could be rectum GE junctions. Unknown origin fever, no infection, no inflammatory cause. They are the germ cell tumors, cysts, sarcomas. Unexplained fatigue and tiredness. Routine causes are out. Myelomas and CMLs. Unexplained or painless jaundice picked up by the relative or by the friend or family. Periampullary pancreatic cancers. DVTs, the one that are visceral, the one that are recurrent. They are harbingers of MPNs, ovaries and prostates. unexplained effusions, sadly so, receive empirical AKT for 2 months or more before they land up in our OPD. So think of these potential malignancies in the background. Similarly, ascites, liver, heart, kidney is fine. Think of cholangios, HCCs, peritoneal carcinomas and ovaries. Something about the most evolved diagnostic modalities. Immunohistochemistry, they are basically antibodies directed to specific organs. They have made our life easy. A practical example to justify importance of IHC. This lady had presented with fatigue, extensively worked up, referred for a bone marrow. Going to the basics, we first do a clinical examination and we picked up a subtle lump in the breast. To the point that she was denying it, we had to convince her for a biopsy, which confirmed it to be an invasive duct carcinoma. PET scan, which is something that is in fashion, was done, picked up nothing. Meanwhile, bone marrow report comes, and then we were wiser to interpret that. Otherwise, would have been missed. We picked up these cells which were confirmed as ERPR positive on IHC, which matches with the biopsy report. So then this lady was not put on chemotherapy. One of the evolving agents then, this was a patient 6 years back, CDK4 inhibitors, and today 6 years plus she remains off transfusion. So this IHC has helped us for the so-called CUP, cancer of unknown primaries, the poor differentiated types, the midline tumors, and obviously it is not just lung cancer for us today, it is small cell, non-small cell, adeno, NET because of IHC, which makes a big change in the outcome. Another emerging modality, NGS, next generation sequencing. So this patient was referred for a pre-op fitness for a big hernia, incidentally found to have low platelets, grade 4 thrombocytopenia. Bone marrow was done, which showed some subtle features of an MPN, but nothing very classical. The conventional mutation panel was negative. So we did the NGS, and it did pick up a rare mutation by the name JAK3. Is put on ruxolitinib, oral TKI tablet with minimal trouble and very, very peaceful, once a day dosing. 4 weeks platelets recovery, undergoes surgery. Because of his young age, we have discussed about a potential BMT in the future. We would have struggled with this case. So this elderly fellow was referred as a case of liver cancer. PET scan biopsy confirmed that actually it's not a liver cancer, it's a metastatic sarcoma. Not his age, but his poor heart made him ineligible for any chemotherapy. He was otherwise stage 4, would have succumbed to the illness in probably 3-4 months. We did the next level of NGS, that is CGP, and we picked up that he has mutations in the pathways where I can target them with CDK4 mTOR inhibitors. He's put on that, and 1 year plus he's going all around the world. So even though not curative, it sounds palliative, but there is meaningful extension of life with simple tablets, possible because of this investigation. So in simplest words, I quote this as the biological kundali of the cancer, and this is one of the happening tests in oncology. Brief about our Pahila Prem, age-old chemotherapy. It is always used in different contexts. Only treatment option for stage 4, before surgery with radiation therapy, after surgery. As per the intent, we label that as palliative chemotherapy or curative chemotherapy. Drugs may not differ so. This is because there are some concepts about its usage. So as the word chemotherapy is said, it comes with a baggage of side effects, and we are today far more better in mending the side effects with many good pre and post medications. To quote an example from the conventional paclitaxel, where anaphylactic reactions, bad neuropathies, and waxing waning sugars was a big concern, we have moved on to the refined versions. So black and white TV gela hai, LCD OLED TV ala hai, and they are so smooth. The side effect profile is out. We are using them currently for patients above 80, which otherwise straight away know in the OPD. So from the conventional understanding of a cell kill, the non-chemotherapy, non-chemo-oncotherapy options have made us, take the fight to a different level. That is because we have understood what is inside the cell. The cell surface receptors, the ligands, the pathways, the nuclear level changes, and that has helped us to identify the weak link of the cancer. Cancer chi dukti ras pakadta ali, so we catch these driver mutations, a classical example of lung cancer where they exist in more than 40%. So that is why even if I get a phone call today, ke stage 4 hai kai karta yel ka, तो माय आन्सर इज के यार भेज दो, बरंच काही करण्यासारखं आहे. दिस इज वॉट वी डेस्परेटली हंट, इज ऑल अपार्ट फ्रॉम कीमो. Of what magnitude they are. It started off probably 18 years back with first discovery of EGFR, with then had only erlotinib, generation 1, today we have generation 2, generation 3. And this is a classical example of how good the drugs are. This elderly patient was referred with hip pains, evaluated to have a lung cancer, metastatic, biopsy confirmed it to have a EGFR mutation, started on first generation, then some chemotherapy, then second line chemotherapy, and then eventually by the time he survives for 3-4 years, we could offer him third generation. And this is a patient whose PET scan is absolutely near normal, even 6 years plus. So stage 4, sent with no hopes, identified a mutation and living 6 years and probably go on for more. And by the time he progresses, I might have the generation 4 of the TKI. So similarly, these mutations in lung and in general are only increasing day by day. It began with 1 and today we have close to 24 mutations. So we just need to hunt for them. We just need an opportunity. So what if this tissue is lost? बरेच वेळा असं होतं की सॅम्पल टाटामध्ये आहे किंवा डन इन सम आउटसाइड हॉस्पिटल और प्लेस अँड दे आर कमिंग टू अस, आय डोंट हॅव द ब्लॉक्स. So all I do is ask for a blood sample, what we call as liquid biopsy. Here the concept is these tumors are going to shed a DNA in the blood. If you can identify a DNA, you can get all the genetic information, all the mutation profile, and this, my belief, is the most happening tool and is going to come in a very big way. Not only diagnosis, but treatment and many other aspects are going to be quite fast and easy, reliable with this technology. A classical example is a chronic myeloid leukemia. Residency days, this was the 3rd or 4th common cancer we used to take for a transplant. Chemotherapy was bad, aggressive, and not so great results. Then comes imatinib, the first generation TKI by the brand Gleevec in America. It was labeled as the magical bullet, came in the Times magazine. Undoubtedly, because this discovery made chemotherapy and transplants practically absolute. So if imatinib didn't work for a few or it troubled few, we had a big list of second, third and the fourth generation now. So तेंडुलकर आउट झाला तर विराट कोहली आहे, नंतर रोहित शर्मा आहे, मग हार्दिक पांड्या आहे, युवराज सिंग and so on. So we have made this a chronic disease. Coming to targeted therapies, another big achievement in the last 1 decade. So this is chemotherapy, this is how target therapy works. एक shot, but it will bring down the enemy. The list has been evolving. And most of them are simple tablets, very peaceful to administer, very straightforward injections to the tune that we don't admit them, we just give it and they can go home. And they work wonderfully. They work irrespective of the age. They work irrespective of your heart, liver, kidney status, where chemotherapy becomes a task. So how good is that? A practical case that I put up. Elderly lady with lymphoma, on neck node biopsy. What was most alarming in this case was the age, 93. Anybody of that age, we would have just sent her home. But after a couple of, after a decade of practice and having this to my expense, we use this unique combination, brentuximab vedotin and nivolumab. And if you can appreciate, there's something, these were the before scans, and that was the after scans. And this was offered to somebody who is super elderly. Otherwise, probably 7-8 years back, I would have sent a lady home on palliative care only. This is how your target therapies work. Kill, to the point, surgical strike like. We also have them in huge numbers in the solid tumors. The list can just, go on increasing. And as I said, all of them are easy to administer tablets or simple OPD basis injections with minimal toxicity. So if this is chemo and targeted therapy, what is the next happening thing for oncologists is immunotherapy. They are the most smartest of the lot. How good they are. This is a case of multiply treated middle-aged fellow, chemo, surgery, radiation, map, saga sampler is sent to our OPD probably for palliative care only, which is very frustrating. So this was the time when low-dose immunotherapy was into the market, something new. So we did offer this, and if you can appreciate, I have not been able to put up the neck drawing, but it was a very horrible state of his tongue and neck recurrences. extreme pain, bleeding, wanted to do suicide. And this was the response after 6 to 8 doses of immunotherapy. And why are we so crazy about it? This is low dose immunotherapy. So here you actually offer just for 20% of the recommended dose. India is a cost resource limited settings. So this is our Indian Jugaad done in Tata Memorial Hospital, works wonderfully well. If not all, at least for 1/3 of the cases. So this palliative care fellow is alive for more than 3 years to the extent he travels from down Kalyan to CST for his job. So what wonders me is this a potential cure which was never even thought of before. So how does this work? So these are the tumor cells. They present the antigens picked up by the APCs. They trigger the T cells by this interaction and then they kill. So what happens is the tumor cells are very smart. They express this PDL1. They interact with the PD1 of the T cells and they block it. So now that we know this is how actually immunotherapy was discovered. So this interaction was blocked by this inverted Y-shaped things which are the immunotherapy agents. So what they do is they don't kill themselves directly as your chemotherapy or targeted therapy drugs do. They will actually prime your immune system, your T cells which are actually very good and very smart to identify the tumor cell and kill it. So this has been the most happening discovery for the last 1 decade, and it started with myeloma. And as you can see, we have a list of indications that are evolving. We are now learning to club them with other immunotherapy agent. We are learning to club them with chemotherapy agents. So a word of caution for immunotherapy is, as of now, it is not for all, but the rightly selected patient, you can have magical responses. Something about myths about cancer and its treatment, as because the audience is more of family physicians, I feel that we all need to echo these things to each and our patient who comes in the OPD with cancer. Definitely can be cured. It doesn't spread with biopsy. Every cancer is unique. Stage 4 is not just the end. Chemotherapy definitely is not painful. That is the most common and most हास्यास्पद प्रश्न आहे जो मी अजूनही ओपडीत आन्सर करतो. हेरिडिटरी नक्कीच नाही आहे. वी सी पेशंट्स हायडिंग द कॅन्सर बिकॉज ऑफ द फिअर दॅट आईला होता मुलीचं लग्न होणार नाही. दॅट्स ॲब्सोल्युटली रिडिक्युलस. इट इज नॉट हेरिडिटरी. वी कॅन आयडेंटिफाय दोज फ्यू. कंटेजियस ॲब्सोल्युटली नो. नोबडी शुड बी आयसोलेटेड. हा कोविड किंवा TB नाही. अँड देन रुटीन लाईफ नीड नॉट बी रिअली डिस्टर्ब जस्ट बिकॉज यू आर ऑन कीमो. So we all need to speak the same thing. Then this is one thing I make a point that every audience just glances through. They are the incidental cancers, not very symptomatic. They may just come to your OPD with some vague complaint or just for the sake of it. कि असंच fitness तपास केले, job change केला, this and that. High WBC counts, hemoglobin platelet more than upper limit, a painless neck node typically will come with this. Obviously, infection, inflammatory causes are out which you can clinically rule them. This is what you strongly suspect if you have a painless neck node. Unexplained vocal cord palsies, any complex lesion in the kidney more than 2 centimeter, any complex adnexal mass, by which it means फक्त cystic नहीं है, cystic आणि solid पण आहे. And then any male fellow above 50 without obviously no history of any catheter or any trauma, if the PSA is more than 10, I actually patient is to be convinced that probably you have a cancer, go for a biopsy. And why is this so important? Because these are the people who will be walking into your OPDs or you may interact with them. आणि लांबपर्यंत कॅन्सरची शक्यता कोणाच्या डोक्यात नाही आहे. पण इफ यू आर सस्पिशियस, इफ यू आर लाईक extra watchful, you will definitely catch these people and they are very, very curable today at this point. Otherwise, they are going to come in our OPDs maybe in June or July. Something about the practical aspects like FNSC or biopsy, भांडणाचा विषय असतो. मला बायोप्सी का हवी आहे, मला डायग्नोसिस नुसता नको आहे. I need all that. So biopsy is important. FNSC is not outdated. It's okay for the recurrent cases, thyroid CAs and difficult sites. So given a choice, biopsy. At least a core or excision. Tumor markers, definitely helpful for diagnosis, for monitoring and response assessment, but always in the context. So premenopausal lady, CA125, don't jump. Postmenopausal lady, abdominal discomfort, CA125, worrisome. Elderly, any male above 50, PSA more than 10, worrisome. AFP, male testis issues, worrisome. So with the context, I'll take 5 minutes. Something about chemotherapy devices. So many times these patients post-op, lengthy chemos, long duration chemos, vesicants in the backbone, you need to have this. This is something that we routinely use, something very practical. 10 पैकी 9 लोक नाही म्हणतात. The moment to tell them chemo port लावा. So what we do is we make them talk to the patient who's taking chemo. And this is the need of the hour. कारण एक गोष्ट असते quality of life. ती पण तेवढीच important आहे, which these devices can actually deliver very meaningfully. Something about PET scan, structural and functional imaging has made our life peaceful, gives us biopsy accuracies, helps you to assess the response. So it was a task in the pre-CT scan era, pre-PET scan era where biopsies were routine. Life is easier today. And then why do you give chemotherapy before surgery? That is what I tell my breast cancer patients, कि cancer free होना जरूरी असलं, रहना पण जरूरी है. So to conserve the breast, to salvage somebody's voice, to ensure good recovery in the ovary cases, to achieve a pathological CR, the triple negative breast cancers, rectums, HER2 positive breast cancers. If you actually achieve a pathological CR before surgery, which means the cancer is dead in the histopath specimen, that is going to multiply into years of non-cancer life. So worth offering in the right patient. So identifying and understanding has helped us to treat them with special drugs, specific agents. HER2 positive, HR positive, this list, triple negative immunotherapies, HER2 positive started with trastuzumab, and today we have a huge list. All of them are like very peaceful drugs to the point. Then difficult cancers like ovary, which used to struggle, we have multiple lines. We have anti-angiogenesis, we have olaparib, from few good years, many good years. Last but not the least, need of the hour, I am sure there must have been some talk about the cervical cancer. Second most common cancer comes in the younger and the middle age groups. Akka ghar khali basta. Cervical cancer vaccines definitely everybody should be propagating and talking about. This is our Indian own version with very good efficacy. Strongly recommended, need of the hour. This is my take on why cancers are rising, because 95% of the OPD patients have no addictions. I believe you will agree to these 4 P's. So this is what I would end my talk with, summarizing these points: awareness, strong suspicion, timely activity, team effort. That thing exists like an incidental cancer. We are in the era of precision oncology, and we all need to strongly echo the myths and the facts. Propagation of vaccine is the need of the hour, and this is the future of oncology to me looks like. A busy slide, but yes, we are in the era of making stage 4 cancers chronic. We are in the era of making life more meaningful, good quality, extended survival. Java, you can't prevent it, you should at least treat it. And this would be the last slide for those patients when I ask them ke jaan pyari hai ke baal, and they can't answer. This is what we offer them. Ke chama padun jau naka. Thank you.
Thank you, sir. It was a pleasure to have you with us. Sir, now I would like to request our chairperson, Dr. Nazirkar sir, to please felicitate our speaker, Dr. Ghanekar sir. Sir, please do the honors. Ghanekar sir, please felicitate both of our chairpersons. Sir. Now it's time for our next lucky draw session, which is sponsored by Dr. Pushkar Chirmadis Cancer Center, Vashi. I request Ghanekar sir to please do the honors. Ghanekar sir's ICTC has sponsored a bumper draw which will be actually drawn after the valedictory function. This is what is been told by Army President. डॉक्टर प्रभाकर आडनाव लिहिलेलं नाहीये 67 त्यांचा रजिस्ट्रेशन नंबर आहे काळे सर आहेत या Thank you, sir. Now Kunal will take over me.
थँक्यू सर. नेक्स्ट लेक्चर आहे लंग ट्रान्सप्लांट. गेस्ट स्पीकर आहेत डॉक्टर कपिल अय्यर. डॉक्टर प्रतीक कांबळी चेअरपर्सन यांना मी विनंती करतो की याचे गेस्ट स्पीकर यांना स्टेजवर घेऊन यायचे. वेलकम सर. चेअरपर्सन यांना मी विनंती करतो की गेस्ट स्पीकर यांचं बुके देऊन स्वागत करायचं आहे. डॉक्टर कपिल अय्यर, consultant pulmonologist and lung transplant specialist at Apollo Hospital, MD DNB MRCP UK, internationally trained in advanced respiratory medicine, expertise in interventional pulmonology, lung transplantation and critical care.
So good afternoon everyone. At the outset I would like to thank Raicon for giving me an opportunity and for inviting me, and to be very honest my audience mein baitha hua tha. This is the first time I'm seeing lucky draws and all of that, so I'm so thankful to the organizers for retaining the fun aspect of a medical conference. It's Sunday afternoon and to see the hall jam packed, it's really brilliant. So I'm going to be talking about the basics of lung transplantation. Not too much in detail, and I've got 20 minutes to do so, and I plan to finish slightly ahead of time so that if you all have any questions you all can please go ahead and ask. The outline of my talk is going to be a case presentation, introduction to lung transplantation. I'll give you few statistics, international and an Indian perspective. What are the indications, what are the contraindications of lung transplantation, what is the meaning of transplant window, referral guidelines, and lastly a word about logistics which happens in a lung transplant center. ठीक है? So first, जैसा मैंने बोला था, I'll be starting with a case. Now I am going to display the face also because permission from the patient and the family has been taken. Okay? Now I'm going back slightly to 3 years back. I was at that time in Ahmedabad, and the case which I'm going to present is the first lung transplantation which we did in the state of Gujarat. Now he's a 41-year-old male. He came all the way from Syria to India for lung transplantation. He was a farmer by occupation, no comorbidities. He was an occasional smoker. See, the problem is in Middle East, all of them are into hookah. So it's very hard for us to identify ki what is the smoking index. So quantifying thoda sa difficult ho jata hai. He had a positive family history of interstitial lung disease. Now, since 2 years, he was having dry cough, progressive breathlessness. He had shown to multiple physicians over there, must have taken steroids, we are very unsure. But unfortunately, over the last 3 months, there was a rapid clinical deterioration. So from room air, he actually went to 6 liters at rest of oxygen, and his exercise tolerance unfortunately was just a few feet on flat ground. Clinically, he was clubbed, and obviously the typical interstitial, crepitations or rails which we have at the basis. This was the chest x-ray. Now remember, this is a chest x-ray at diagnosis. You can see basis में थोड़ा सा reticular nodular opicities है, but otherwise it's not really such a bad chest x-ray. Now with this, because he clinically deteriorated, he decided to pursue lung transplantation, and through a lot of channels he decided to zero down and come to India. Now on the left you can see this is when he came on board the flight. You can see he was on 6 liters of oxygen. Now you can ask any pulmonologist, interstitial lung disease is one of the worst diseases which we actually face because patients आंखों के सामने deteriorate हो सकते. And this was a prime example. I mean, he came to us on 6 liters, he landed, in a few weeks he went on 10 liters. By the end of a month he was on non-rebreather on 80%. By the end of 1.5 months, this guy, see, you can see the non-rebreather photo on the right. By the end of 2 months, this guy was on 90% FiO2 requirement on a high flow, HFNC. This was the chest x-ray when he came to us. So you can see the increase in the chest x-ray 2 years ago. It was actually like this, and you can see by the time he came to us, as I mentioned, it was a rapidly progressing disease. And this is the CT scan. You can hardly see any normal lung. Now this guy on 90% FiO2 requirement could not even move from out of his bed. And I still remember, it was a Friday evening, foreigners को तो organ मिलना बहुत मुश्किल है. So we actually sat with him, we had a lengthy discussion, and he actually had succumbed to the fact that boss, he's gonna die. He cannot go back to his house. We took a negative consent for ECMO, and it was a Friday evening. Monday morning, you will not believe it, we got a call for an organ. I just want to play this video. I want you all to pay attention to the video. This is our entire team. When we did the retrieval, we actually came out. You can see the surgeons, and that's me. I'm carrying the organ retrieval, and you can see all of this wonderful gesture that is happening. So the journey from the operating theater up to the ambulance, which is just waiting outside, was approximately, let's say, 500 to 600 meters. Now I want you all to put yourself in the position of the relatives. आपके फैमिली में कोई तो unfortunately brain dead हो चुका है. The first thing is it's a heroic thing to actually sign up for organ donation. Second thing is जब हम organ retrieve कर रहे थे, हम जब बाहर आए, literally the people who are putting the flowers, the rose petals, is a combination of the relatives of the family and the hospital staff. And this happens only in India. It happens only in India जहाँ पे actually organ donation को celebrate किया जाता है. And I'm so thankful to the organizers. बीच में y'all were having a green color QR code of NATO because of the civil surgeon, who has come over here, Joshi ma'am. Really thank you. This is one of the few conferences जहाँ पे आप लोग बीच में organ donation को भी promote कर रहे हैं. In India, we badly need organs. 10 lakh Indians में से एक भी जन organ donate नहीं करता है in our country. This is the sad condition of organ donation in our country, unfortunately. Now, this is obviously, he got the organ. On the right, you can see the deceased, the lungs which we got out. You can see it was completely shrunken, fibrosed. And after the surgery, you can see his wife, they did not even know a word of English, but still they were recuperating well. Lot of post-operative rehab. And ultimately, you can see on the left the photo when he was discharged. He took 1.5 months in the hospital when he was discharged along with all of us. And the photo on the right is a 3-monthly follow-up. So usually after transplant, we keep these patients for 3 months because we need to, tailor their immunosuppression. We need to do bronchoscopies. We need to see that everything is okay. And this is ultimately how he went back home. Now, I'll tell you a very fun fact about this patient. 1 घंटे मैंने उसको काउंसिल किया था कि देखो लंग ट्रांसप्लांट के बाद 3 to 6 months please try to avoid mixing around with a lot of people and relatives. But he was from Syria. He was the first patient in the entire country to even get a lung transplantation. So he took back a lot of love from India, and this is how he was received. He actually landed from the airport, or airport से लेके उसका घर तक, you had the entire village who was accompanying him till the time he actually reached home. This is him, after his transplant anniversary. So I had sent a cake for him, and this is him celebrating with his children back home. Unfortunately, at the end of 2 years, we lost him to a road traffic accident, and it was a very gruesome end, unfortunately, to such a lovely story and such a lovely chapter. So yes, lung transplantation has emerged as a definitive treatment for all end-stage lung diseases. In India, there are centers which are performing lung transplantation, but we need a lot more to be done. Now just pay attention to the graph. Usually lung transplants, we do double lung transplant, that is dono. You can also do a single, but in the purple we see a lot more double lung transplants being done. पूरी दुनिया में आप अगर देखोगे तो the green bar is North America, the yellow bar is Europe, red is rest of the world. So India unfortunately is a part of the red bar which we see. India में approximately in a year 100 to 120 lung transplants होता है, as compared to let's say North America जहां पे एक साल में 4000 होता है. And believe me, our population is 5 times. So we need a lot more to be done, a lot more work needs to be done. Now in India also we see so much of differentiation. हमारे population इतना diverse है. This is 2024 data, और अगर आप देखोगे तमिलनाडु, तेलंगाना, महाराष्ट्र, कर्नाटक and Gujarat, these are the 5 states in India जहां पे you've got an active cadaver donation program. महाराष्ट्र 2024 पे नंबर 3 पे था, 2025 में it's become number 4, but it's always in the top 5. So it's something to cheer about, but still I say we need a lot more to be done as far as organ donation is concerned. Now, when should we do a lung transplantation? What are the indications, and when should we not do a lung transplantation? See, I have got a very simple explanation. You know, you see this table, it's unnecessary complicated. मैं आप लोग को एक simple चीज बताऊंगा. Any chronic lung disease which is progressive in nature is an indication for lung transplantation. So, fibrotic lung disease. Now, we are not going to fight about sarcoid hai, occupational hai, IPF hai, hypersensitivity. No, it's a fibrotic lung disease. At one point, it will need lung transplantation. Let's see COPDs. Whether it is smoking related, whether it is non-smoking related, whether it is occupational COPDs, at one point of time they will need lung transplantation. Same for bronchiectasis, and even same for pulmonary hypertensions. When not to do lung transplantation, we always prefer if the patient has only got damage of the lungs. So if your kidneys are really bad, your heart is really bad, your liver is really bad, obviously any other end organ damage is always a big risk. And obviously you've got many, contraindications like active sepsis, active tuberculosis, active chronic, infection, especially with Acinetobacter, all of these organisms, or if the patient has got a stroke just now in the last 30 days. Now, हमेशा transplant में, we always have a fight with the pulmonologist. हमेशा जब वो patient refer करते, we always tell them कि patient late आया है हमारे पास. So it's very important for you to understand the concept of a transplant window. अब देखिए कोई भी respiratory disease है, it always follows this trajectory. In the yellow boxes, when you have diagnosed, when the patient is somewhat doing okay, slowly day-to-day activities maintain कर रहा है, there will be a time when the green zone comes. The green zone is known as transplant window. In simple words, it is the time when a patient needs a lung transplantation but is fit enough to tolerate it. Okay, patient is unfit so that he needs a lung transplantation but fit enough to tolerate it. If we lose the green window, हम सीधा red zone में आ जाते हैं where it is too late. Believe me, 90% हमारे जो referrals आते हैं, it's almost at the end of the green zone. जहाँ पे patients are doing extremely bad, can't move, can't get up, and that is when someone will say, ये patient का हम lung transplantation करते, it's too late. Now again, there's a big fight. लोग हमेशा मुझे बोलते हैं, यार ये transplant window का photo दिखा तो, it's a subjective thing. See, your late can be my early, my late can be your early, right? So that is why we have got these guidelines. If any one of you want to take a photograph of this, please do. This is available in Google, in the internet. These are proper guidelines in which every single chronic lung disease may, when exactly do you need to refer objectively is given. So ILD में spirometry क्या होना चाहिए, 6 minute walk distance क्या होना चाहिए, सीटी में क्या चेंजेस आने चाहिए, पल्मोनरी हाइपरटेंशन कितना होना चाहिए, when you need to refer, everything is given in these guidelines. Now I'll just explain very briefly about logistics. So when a patient is referred to our center, remember the first is the role of a transplant pulmonologist. These are photographs of all my colleagues who are in different transplant centers all over India. Now usually transplant pulmonologist is the first point of contact. जब भी आपका जब patient जब आता है, believe me, there is a huge amount of tests which we need to do. इसको हम प्री ट्रांसप्लांट असेसमेंट कहते हैं. राइट फ्रॉम सीटी से लेके डेक्सा से लेके परफ्यूजन स्कैन से लेके राइट हार्ट कैथेटर से लेके अपर जीआई स्कोपी से लेके कोलोनोस्कोपी. इफ इट्स अ फीमेल यू वांट टू डू अ पीवी एग्जामिनेशन, different specialists need to see this patient. Cardiologist, infectious disease, your gastroenterologist, all of these, your physiotherapist, every single person will cast an eye on this patient just to ensure that everything from their systems is optimal. Usually we prefer to hospitalize such patients because ये सारे टेस्ट करते करते it will take at least 2 weeks. So we admit these patients and in about 4 to 5 days we get everything done. Once this is done, obviously we've got something which is known as an MDT, so a multidisciplinary team meeting, जिसमें all the transplant surgeons, intensivists, anesthesiologists, the pulmonologists, all of us sit together and we discuss about what can be optimized, what needs to be done, so on and so forth. And finally, इसके बाद जो लास्ट स्टेप है, ये डायग्राम आप सभी लोगों ने देखा हुआ रहेगा in the QR code, which is NOTO, which is the National Organ for Transplantation in India. हम पेशेंट्स को ऑफिशियली नोटो प्लस जो स्टेट ऑर्गेनाइजेशन है वहां पे लिस्ट करते. दिस प्रोसीजर इनफैक्ट इज नोन एज लिस्टिंग. एंड इसके बाद में इट डिपेंड्स कि पेशेंट कहां पे है. वंस यू गेट अ डोनर विच इज as per the blood group, as per the height, as per the size of the patient, we go ahead with the transplant. Now in Maharashtra, मैंने आप लोगों को पहली numbers दिखाया था. On an average, a patient has to wait for approximately 6 months. 6 to 9 months a patient has to wait in the state of Maharashtra before we get a blood group and a height and a thoracic cage fitted cadaver. And this is, lung transplantation is exclusively a cadaver based organ transplantation. So in summary, I would like to conclude by saying that yes, lung transplant is a definitive treatment goal for all end stage lung diseases. India needs much more lung transplant centers because there is so many respiratory diseases. You all must be seeing it regularly in your OPDs. But the most important crucial is we need an early referral and a timely referral, because if the patient comes late, unfortunately the amount of complications will increase. I would like to use this stage and this opportunity to mention 2 more things. First is, in Apollo Hospital, Navi Mumbai, we have now started a lung transplant program. We have already started listing patients. We've got a wonderful team of surgeons and transplant pulmonologists. The total experience of the entire team is almost up to 500 lung transplants. So please, if you have any patient you feel warrants an investigation or at least a consultation, please do reach out to us. And second, and the last thing which I will say is, I always do this in every one of my talks, whatever be the audience, please consider signing up for organ donation and pledging your organs. And please spread the word in your community, in your family, and amongst your friend circle. Thank you so very much. So the success rate will depend on a lot of things, but if I tell you success rates, sir, we talk in terms of percentages. So 1 year success rate is approximately 90%, 3 year success rate is approximately 75%, and a 7 to 8 year success rate is approximately 50%. So after lung transplantation, on an average, your patient will live for approximately 7 years. As compared to other organs, the lung is something which is constantly in touch with the atmosphere because we breathe every second. बाकी अगर आप हार्ट देखोगे, लिवर देखोगे, so after the surgery they are inside in a sterile cavity. which is why the average numbers of lung is slightly less compared to other organs. And also it depends on what stage the patient has been referred to you. Like I mentioned, an early referral means your success rate will be much better. But a late referral means obviously the success rate will start going down.
Thank you, sir. I request chairperson to felicitate our speaker. I request speaker, please felicitate our chairperson. Lucky draw from MOC Hospital. Dr. Ganesh Salunke, Chief Organizing Chairman, Raicon 2026. Congratulations. Thank you, sir. Yeah. I'll hand over mic to Dr. Sajid.
Thank you, Dr. Kunal. Now our next session will be typhoid vaccine. And to speak on more about this, we have invited our guest speaker, Dr. Rajesh Chokhani, sir. Now I request Chairperson Dr. P.B. Jain, sir, and Dr. Sampath Deshmukh to please accompany our guest speaker to the dais. I request Dr. P.B. Jain, sir, to please welcome our guest speaker by offering a bouquet. Thank you, sir. I am honored to introduce our guest speaker, Dr. Rajesh Chokhani, sir, who is an expert in his field. He is an MD, DCH, FRCP, CH, UK. Sir is a consultant pediatrician at Hinduja Hospital, Mahim in Mumbai. Additionally, he is a co-author of the book Lessons from Grand Rounds and the book Even When There Is a Doctor. He has been an examiner for MRCP, CH, UK, DNB, FCPS and DCN and the former president of IIP Mumbai. I now request sir to start his session.
Before that, I'll say that these conducting steer programs. YouTubes are available. You see those steer programs, clinical, basic clinical. You can learn from that steers program. Thank you.
Thank you, sir. And a very good afternoon to respected chairpersons, seniors and friends in the audience. Today, the topic that has been given to me is enteric fever, emerging antimicrobial resistance and protection by TCV in adults. At the outset, let me give a disclosure. This is a sponsored talk by Bharat Biotech. Now, before I come to the topic, some lighter moments. So, of Maga and Maha. This is a gentleman, whenever we are free, we use him to spend some lighter moments. He gives us a lot of stress because if we are grandparents, our children are probably in the US and he's giving us a lot of stress. But at the same time, he is a big stress buster with all his funny comments and ideas. So when he came in, he said, MAGA, make America great again. Not like a typical Maharashtrian, you and me will say, doubtful hai, मोदी अजून गादीवर आहे. Then he brought another of his cronies to look after the health of America, who brought out another slogan, Make America Healthy Again. And in the bargain took some mad and horrendous decisions. He said, don't take vaccines. For ages we have been looking at the US and the West and we have been aping them. So for a moment we got all upset. But then friends, let's not worry, because our vaccine experts and Indian companies like Bharat Biotech say, मैं हूं ना. So don't worry. We have very good Indian vaccines, very good Indian experts, and we'll be able to take care of everything. So to begin with, Bharat Biotech is looking at many vaccines which we are using day in and day out. So they have a wide product portfolio of more than 19 vaccines and even biological products. They have also many important vaccines in the pipeline like cholera, chikungunya and so on and so forth. But today our topic of discussion is typhoid fever. So as we all know, typhoid is caused by Salmonella typhi. Fever is the main complaint and then there can be various other complaints. This is important to know that typhoid is not just a disease of young children. So of course it's high in young children, but even adults suffer across ages, so much so that even 85-year-olds can suffer from typhoid, and we will see that this vaccine is now allowed for adults up to 85 years. Now, when we did microbiology in second MBBS, after second MBBS we said, chalo jaan chuti. But no, jaan didn't chuti. So we still have to remember the basics. So O antigen, H antigen, we know all this. We've been using it in Vidal test, we'll talk more about it. And the VI antigen, which is important for all the vaccines that are being manufactured for typhoid. So let's talk a little about how do we suspect and diagnose typhoid. Obviously, it comes as high fever. In children, we see a very typical trend of rising trend, which means on day 1 the fever is 102, and then day 2, day 3 it becomes 103, 104, what is known as the step ladder pattern. Adults, this pattern may or may not be seen. Typically, chills come a little later. So malaria will start with chills from day 1, but in typhoid you start getting chills on day 3 or day 4 as the disease progresses. There are no other localizing symptoms. So obviously when you start with high fever, there could be hundreds of possibilities. But I think what we have to pick up is that there is no cough, no cold or very minimal, or there are mild GI symptoms like some 1 or 2 loose motions, not like a full-blown GI infection or some abdominal discomfort. So that is what we have to pick up. And the most important, no downward trend by day 3, day 4. So most viral infections get better by day 3, day 4, but the typhoid fever will continue. So friends, one big message I want to re-emphasize today is not all longish fever. So in outpatient practice, even a 3-4 day fever is very long because you expect it to get better by your treatment or without it. But any fever which lasts for 4 or 5 days is not necessarily typhoid. Today viral fevers last longer. Today there could be other infections like a sinus infection which is camouflaged. So therefore please pick up typhoid only when you have no other symptoms and a lot of fever. Look at that kind of a situation. And then of course if we examine, we find a tumid abdomen. What's a tumid abdomen? The patient has not eaten, but we feel he has eaten. That's the kind of abdomen that we feel. And if we can make out a liver and spleen that is enlarged. Coming to CBC. CBC in typhoid is important on day 3, not on day 1. Day 1 will not give you clues to typhoid. Now on day 3, day 4, a low normal count is what is most important. Friends, typhoid, the count will be 4,000 something. If the count is 3,000 or 2,500, very high chances this is viral and not typhoid. So low normal, not lower than normal. low eosinophils. Of course, we don't know the previous eosinophil count of that patient, but if it is 2 or 1 or 0, it gives a clue. Monocytosis, so 8 to 10% monocytes, and low platelets are not seen in the first few days of the illness. Coming to Vidal, I think we've all been traditionally taught Vidal. We've been all practicing it for many years. Because we pediatricians deal with typhoid more often in children, we now know that Vidal is no longer justified. So in a lighter vein, I will say that we should ask for Vidal only if the lab is owned by my wife. Because of course I need to generate business. But otherwise Vidal is to be thrown in the dustbin. Stop wasting money on Vidal. There are baseline titers for every city and we don't know those baseline titers. For all you know, Raigad baseline titer may be 1 in 160 and therefore a 1 in 160 Vidal does not tell you this is typhoid. So let's give up Vidal and Typhidot to diagnose typhoid. Similarly, we all look for SGPT. Now again, while in typhoid, yes, there will be a mild raise in SGPT, but there are many viral infections which can cause a mild raise in SGPT. So again, that is not specific and we should not use that as our clue. So ultimately, the only test for typhoid is a blood culture. Our traditional arguments have been, no, itna bada test kaun karega? No, it's not a big test. It can be easily done. It can be easily grown. If we start asking for blood cultures, our pathologists will start giving blood culture reports nicely and it will always work. And believe me, even in a patient who has received antibiotics but has not responded, your blood culture is likely to be positive. So let us stop spending money on Vidal and Typhidot. Instead, use that money and add a little more and ask for a blood culture. Treatment, of course, cefixime, only point to remember is that it's 20 mg per kg and therefore adult ceiling dose is not just that 200 mg tablet which is available in the market. It has to be, it can be as high as 600 BD. So 400 BD or 600 BD depending on how heavy your patient is. And in adults, azithromycin also works well. Again, the dose is a little higher, 10 to 20 mg per kg and 1000 mg is the dose, maximum dose. Here, I would again request that many times we see non-specific fevers. Just because we haven't found anything, just because it's been day 4, we call it typhoid. Based on some Vidal positivity, we admit this patient, we start on some broad spectrum antibiotics and we believe that we have treated typhoid. This is not right and this is only going to add to antimicrobial resistance. Talking about antimicrobial resistance, I can see a lot of seniors here. So you all know that when 30 years back or whatever, the typhoid treatment started with chloramphenicol, then soon it became resistant. We all went through this ciprofloxacin era where we used a lot of ciprofloxacin. Now even that is 90% resistant. Now admitted patients is ceftriaxone, outpatients is cefixime or azithromycin, but there are even some ceftriaxone resistant patients that are coming in. So we really need to be very, very careful. And this resistant typhoid is not restricted to India. It is all over the world in so many other countries. And therefore, we now have a typhoid vaccine called Type Bar TCV, which has been marketed or produced and marketed by Bharat Biotech. So now why is the vaccine important? Once again, a lighter moment. You know, nowadays builders have a new stunt. What is the new stunt? They give you lakhs of rupees discount to book a flat in their new apartment. You know what is the catch? They've stopped making kitchens there. They are only giving a free subscription of Zomato and Swiggy, right? Now with this kind of a situation, the incidence of typhoid is still high. It is continuing to be high. And of course, the most important point is that even if we were to treat typhoid, some people are left behind with a carrier state. They are themselves at risk, plus they can pass on the infection. And again, most important, even after suffering from typhoid, there is no permanent immunity. So therefore, we definitely need the vaccine. So what will a typhoid vaccine essentially do? How will it help us? It will decrease the disease incidence, it will decrease the severity of the infection, because mind you, the vaccine is not 100% protective, almost no vaccine is. But even if the person gets typhoid in spite of the vaccine, the severity will be less. There will be decrease in transmission of the disease. Therefore, because of not suffering from typhoid, indirectly it will help in antimicrobial resistance. It will prevent a carrier state and complement the immunity that the patient has got from the infection. So what is this conjugate vaccine? What is conjugation? So conjugation is a process by which we make a vaccine much better. So what it does is the antibodies they develop more affinity. There is induction of memory cells so that the response lasts longer, long-lived antibody production, and improved immune response in younger age group, because polysaccharide vaccines don't work in less than 2-year children, and these conjugate vaccines do work. Now, type bar TCV, produced by Bharat Biotech and marketed by them, is the world's first WHO pre-qualified vaccine. What do we mean by WHO pre-qualified? WHO actually looks at all the manufacturing processes, the content of the vaccine, quality control, etc., and gives its kind of stamp of approval. So this is the world's first pre-qualified vaccine. Now, they've done a multiple studies. Interestingly, they first started with a study with University of Oxford in UK, where they actually gave volunteers a typhoid germ solution to drink, and then they saw how many of them developed typhoid and whether the vaccine prevented them from developing, and they found an astounding 87% efficacy in prevention of typhoid. This of course was followed by multiple trials in India. You can see so many of them on a wide age range, including adults, right up to 45 years and now even 65 years. And all these studies have shown safety, immunogenicity of the vaccine. The biggest trial, which has continued for a 7-year follow-up, has shown that it is safe, immunogenic. In this trial, in a subsection of the patients, they followed them up for 7 years, and in a subsection, they gave a booster at 2 years to see what is the effect. And they found that as many as 60% remained seroconverted even 7 years after the first dose. And on the other hand, 80% remained seroconverted if they got a booster. What is more important is that the booster dose resulted in superior avidity maturation. That means the quality of antibodies was better. So there is another study done at Malawi which also showed that at 4 years roughly the titers may start falling. So the WHO position on boosters is still, they say we don't need a booster. That is because they are of a public health perspective. They feel give 1 dose to everyone, at least give minimal protection, then hopefully every time we eat in such conferences or at Jew Beach, we will get some more dose of typhoid and it will boost our immunity. But on an individual basis, if you think you want to be safe, you can give a booster at roughly 4 years from the previous vaccine. After efficacy, we do effectiveness studies. That means we actually use it in the public to see whether it's actually effective in the field. And these are effectiveness studies all over the world, and they have shown that this vaccine is extremely effective with efficacy varying from lowest 75% to highest 95% in Pakistan. In fact, in Pakistan, there was an outbreak of XDR typhoid, which was resistant to multiple drugs, and therefore they used it to give the vaccine to a big part of the population, and they found that it prevented them from acquiring that XDR typhoid. So it's effective against XDR also. Of course, in India, there have been multiple studies. This is a huge program in Navi Mumbai, where more than 1 lakh children were vaccinated with typhoid by the Navi Mumbai Corporation, and they again found that this was very effective and it reduced the risk of typhoid by 56% even in the community. So that's a big reduction. This is a American journal which talks about the field effectiveness of this vaccine in the Navi Mumbai study, and it said that the adjusted odds ratio was 0.16. That means the vaccine was 84% effective. So these statistical calculations differ upon depending on what you are really looking at, but in general the vaccine is very effective. It has a robust safety data. We've been using it for years in pediatrics, and it only causes a minimal pain and fever, if at all, that too in 1 out of 10. So it's extremely safe. And in fact, the company has continued with his post-marketing surveillance and phase 4 studies to continue looking at the safety and immunogenicity of the vaccine. Now, there are many other companies also making typhoid vaccine. So why type bar TCV? Because they have really looked at the conjugation process. They have in fact patented their conjugation process, which results in a very high immunogenic, high avidity antibodies and lasting immunity. So what is the edge of type bar TCV over others? It is the first typhoid conjugate vaccine with WHO pre-qualification. It is the only typhoid conjugate vaccine with so much long-term data. It is the only typhoid vaccine which is used as a comparator. So if any new vaccine is produced in the market, they use this in the control limb and see whether the antibodies of the new vaccine are equal to those generated by this vaccine. Then it is proven efficacy, it has proven booster dose effect, it can be administered with other vaccines, and last but not the least, it is effective in all age groups including the elderly. So this is the most recent data about use in elderly at extremes of age, and the conclusion is that it can be used from 6 months to 85 years of age. So friends, I would seriously request all physicians present here to first take typhoid vaccine yourself if you have not taken it, because we are going to keep eating in conferences and outside. Second, actively recommend it to your patients, because this is one additional step in combating this disease. So finally, to kind of sum up on what is the vaccine, it's active immunization, purified polysaccharide which is conjugated to tetanus toxoid. It is available as a ready-to-use liquid, 0.5 ml syringe which you just have to directly use. This is 65, but it can be used till 85. It's available as single dose and multi-dose vials, and it is fairly heat stable, though of course we have to store it at 2 to 8 degrees centigrade. So this vaccine has been used all over the world, and therefore let's not take typhoid lightly. Let's use this vaccine to prevent typhoid. Friends, before I end, this is a quote by James Boyce, who says that medicine is the only profession that labors incessantly to destroy the reason for its own existence. So we say, if we remove so many diseases by using vaccines, then what will we do? How will we work? But friends, don't worry. There is always a solution. See, nowadays you will agree, every patient, before they come to you and me, they consult Google Da. Correct? And Google Da has this peculiar habit of speaking on both sides. So Google will say, aisa bhi, and then vaisa bhi. So ultimately, the patient gets confused. So in other words, friends, जब तक मिलेगा गूगल से ज्ञान, पेशेंट्स आते रहेंगे मेरी जान. So please use vaccines and prevent diseases. Thank you.
Any question?
If there are any simple questions, I am ready to answer. Complicated questions, I am eager to answer.
Rajesh, IAP recommends 1 dose at 6 months.
Yes, sir. Single dose, 6 months onwards,
but booster,
at any age.
Booster?
So booster, as I said, officially WHO says no. IAP has not yet said yes. But on a personal basis, I would like to give a booster 3-4 years after the first dose.
Yes.
Any other questions or on any other adult vaccine?
Hemant, any question? Thank you very much.
Thank you. Thank you so much. Thank you.
What about the Vidal difference between tube test and the slide test? Should we prefer the tube test, whether the report comes after 48 hours after the actual
Correct.
test?
So, like I said, slide test is absolutely useless, and even without seeing the report, you can throw it in the dustbin. Tube test is more reliable than the slide test, but it's not the issue about report coming after 48 hours. The issue is, like I said, we don't know pre-existing baseline titers. So if you get a report of 1 in 80 or 1 in 160, you don't know how much of it was already there before this illness. So you cannot call it an increase in titer, and therefore it's not reliable. Actual increase in titer fourfold will take many days. You can't wait for that period. That is why it is our sincere request, stop relying on Vidal. Look at those subtle clues in the CBC. Before that, look at absence of other symptoms except fever and ask for a blood culture. Save your money on other tests and ask for a blood culture. Thank you.
What an insightful session. Thank you, sir. Now I request Chairperson Dr. P.B. Jain, sir, and Dr. Sampath Deshmukh, sir, to please felicitate our guest speaker, Dr. Rajesh Chokhani, sir. Thank you. Now I request our chairperson, guest speaker to please felicitate our chairpersons, Dr. Sampath Deshmukh and Dr. P.B. Jain, sir. Before we proceed to our next session, we'll take a Okay, then we'll proceed to our next session. I request Dr. Kamini to take over the mic.
Thank you, Dr. Sajid sir, for seamless handover. Thank you, sir, for the clear and informative talk on typhoid vaccine. Moving to our next session, I would like to request Chairperson Dr. Manohar Sabne sir and Dr. Aniruddha Joshi sir to please accompany our guest speaker, Dr. Rahul Gupta sir, to the dais. Thank you, sir. I request Chairperson Dr. Sabne sir and Dr. Joshi sir to please welcome our speaker by offering bouquet on behalf of Raicon 2526. Lucky draw घ्यायचा आहे. साजिद लकी ड्रॉ घ्यायचा आहे ना Okay. I would like to introduce our guest speaker. Before that, today is our guest speaker, Dr. Rahul Gupta sir's birthday. So, on behalf of Raicon, we all wish you happy birthday, sir. It's our pleasure to celebrate your special day with us. After the lecture, we will have a brief cake cutting. Dr. Rahul Gupta sir is an interventional cardiologist, Navi Mumbai, DM cardiology topper from KM Hospital, MD medicine topper from BYL Nair Hospital. Currently, sir is practicing as a HOD and director of cardiology and structural heart intervention at Gleneagles Hospital, Parel, Mumbai. Sir is a founder of Cardium Advanced Heart Care Clinic, Vashi. His expertise in complex angioplasty and pacemaker procedures, TAVI, mitra clips. Sir will be speaking on topic game changer technologies in cardiology, boon to high risk patient. Sir, please start the lecture.
Thank you everyone for the wishes and the kind introduction. So can we have the slides? So we all know that cardiac disease are number one killer. Of course, oncology has picked up and in terms of number of cases, but we need to be aware about what is available for our cardiac patients whenever they are in a difficult situation. So we have entered an era where patient once considered as no options can now be treated safely, and there are advances mostly related to in CKD, bleeding risk, refractory hypertension, complex blockages, atrial fibrillation and structural heart disease. So I'll go through certain case scenarios. I will tell you that these are the patients who come to us, they pose a difficult challenge and how do we deal with them. So let's discuss a real life case scenario. CKD stage 4, creatinine 4.2, patient walks into your clinic with typical symptoms of angina. What is your biggest worry? Can anybody say? Somebody with high creatinine is getting angina. What is the biggest worry of the doctor who is referring and biggest worry of the patient about this patient? See, finally we'll have to do an angiography for this patient. Do you agree? But what is the risk? What do you think?
Dye reaction.
Dye related progression, and people fear dialysis more than anything else. I think we would agree. So we hesitate because we worry about contrast nephropathy. Do you think CT angio is better? Do you think CT angio, how much CT angio must be utilizing the dye in doing an angiography? CT scan. You want to find out the blockages. Any idea?
CT is it is a misguided, I will say, in practice. Interventional cardiology or the direct angiography is far better, because if you got any doubt in the CT angio, again you have to perform the same dye is used.
I agree. So 60 to 80 ml dye is utilized in doing a CT angio. And conventional angio will take about 20 to 25 ml. Okay? A typical angioplasty takes about 100 ml, 150 ml, 200 ml. But when you have a patient whose creatinine is high, you want to utilize as low dye as possible, and we have developed a technique called as low contrast angiography, where I can actually do angiography in about 4 to 6 ml dye, just 4 to 6 ml dye, and angioplasty in 0 ml dye. So if you have a patient who's got creatinine which is high, and if you are worried about the creatinine going high and developing contrast induced nephropathy, this is the technology. So there is a biplane cath lab, like in clinicals we have a biplane cath lab where in just one injection you get 2 views. So 3 injections to 2 ml, you get the entire coronary, you get 6 views, which otherwise would have consumed about 20-25 ml dye. So this was a patient, diabetic, CKD, multiple creatinine 2.1, and this was a critical blockage. If you look at the picture on the left side, there is a critical blockage in this area. So his angioplasty was done using IVUS. This is IVUS images. No dye was given throughout the angioplasty. Only all the pictures and everything was being done by using the angioplasty and the camera, internal camera, and this is entire stent. Everything is studied, whether the stent is opened well or not, and this final 2 ml dye. So entire angioplasty of this kind of angioplasty, which takes about 150 to 200 ml dye, could be completed in just 2 ml to 4 ml dye. So these are the advances which we should know. So if you have a patient who has got CKD, who is worried about getting a contrast induced nephropathy, this is what we can do for these patients: biplane cath lab and ultra low contrast angiography and angioplasty. Now let's discuss another case scenario. 50-year-old male planned for renal transplant. Now where I work is a very high transplant volume center where kidney and liver transplant happens very frequently, and these patients are referred for fitness. So this was a 50-year-old male who was turned out to be triple vessel disease, a 70-year-old male, critical 95% lesion for liver transplant. Now if you put a stent, you will have to defer the surgery for about 3 months, because what can happen if you stop blood thinners in these patients? Stent thrombosis, which is life threatening. So what do we do in these kind of patients? Any idea? Somebody who's got critical blockages, needs a kidney transplant or a liver transplant, but we need it very early. So what do we do? Any idea? Anybody? Any thoughts? Have you heard about metal-less angioplasty? So we treated these patients by metal-less angioplasty. That means no stent, everything with drug-coated balloon, which is equivalent to a stent or better than the stent because there is nothing left behind. So you treat the blockages and there are no stents at all. So the blockages, so no stent thrombosis. You can stop the blood thinners very early. Within 1 month you can stop the blood thinner, and good for younger patients. Like this one 29-year-old male who came. So we do amongst the highest number of metal-less angioplasty in the city of Mumbai, Navi Mumbai, Thane including. Because these are the patients who will benefit. So it needs a different kind of mindset and technical skills. And this is how the balloon gets, all the drug gets into the artery. The blocks are removed and this drug is distributed, which prevents repeat blockages in these patients. So this is another technology. If there is a patient who is young, there's a patient who needs a surgery immediately but has got critical blockages, not eligible for bypass, we can do angioplasty with drug-coated balloon, and these patients are free. You can stop blood thinners. They can undergo the surgery which they want to do. Because with blood thinners on, you can't do the surgery. You have to stop the blood thinners. It becomes a very messy situation. So this is one thing we all should know, that if there is a patient who needs something before the surgery, cannot wait for long because it's cancer, it's liver transplant patient is deteriorating, we can solve it like this. Now, have you ever seen a patient in your practice where patient is having angina? He walks for a little bit, he or she gets discomfort in the chest, and you do an angiography, angiography is normal. Have you seen that? Referred for angiography, angiography done, TMT was positive. When you do an angiography, it is normal. So what are these patients? What are these patients? These are syndrome X, or these are microvessel angina. Previously, there was no test which was available to diagnose microvessel angina. So normal angiogram doesn't mean normal coronary or normal coronary health. Okay, it can be microvessel angina. And what do you do? Like I will tell you, the first case of the entire country which we did for this latest technology which has come to diagnose these microvessel angina was a doctor's mother. Even walking for 10 meters, she would get angina. Typical discomfort in the chest, she has to wait. And we thought there would be something very critical. So we did an angiography, and angiography showed that the blockages are only 50 to 70%, not more than that. Why is she getting so much angina? So we did, I said you wait for 10 days. There is a CoroFlow test which is getting launched in the country. Maybe you will be the first patient to undergo this. And they waited, and then this doctor was from London, and he was expert. So we called him, and then we did the first CoroFlow test of the country. So this was the blockage. So we see that there is a blockage, but this was not explaining the significant symptom of this patient. So we did a CoroFlow test. In CoroFlow, you can find out whether it is epicardial coronary arteries. That means the blockages which we are seeing are causing the trouble, or it is the microvessel which is causing the trouble. In the microvessel also, based on these values, FFR, CFR, IMR and RRR, based on these values, you can find out whether this is fixed structural microvessel angina or functional microvessel angina or a mixed microvessel angina, and then you can give appropriate therapy. So even in therapy for patients with microvessel angina, you need to know which kind of medications are going to help these patients, and this CoroFlow test can give us the diagnosis. So if you have a patient who gets angina, every time they get admitted, you do an angiography is coming out to be normal, and we need an answer why this patient is getting admitted with angina, with MI, tropa is elevated, you do an angiography, it is normal, you can refer them for CoroFlow test. So it is now available in India. It was launched about a month back, and we were lucky enough, it's just about the luck that the patient was there who needed this, and we were lucky enough to do the first case of the country. So these are all these cases where we solved. Angiography did not show much, patient very symptomatic. We did a CoroFlow test, found out what is the problem, and then treated accordingly with medical management, and they are doing well. So we must know. Now let's discuss a rhythm scenario. Now what is the biggest risk for a atrial fibrillation patient? Suppose somebody has got atrial fibrillation. What is the biggest risk we are thinking about these patients? Stroke. How do we prevent stroke in these atrial fibrillation patient? we have to give anticoagulation. Now, if you, there is some scenario, you are giving anticoagulation, but the patient is bleeding. So, you want to prevent the stroke, but when you give the blood thinners, the patient is bleeding. What can we do for these patients? So, they are at high risk of stroke, high risk of bleeding. What do we do for these patients? What do you think? Is there any technology which is available? So, we had these patients, it is called as catch-22 situation, where you want to give the blood thinners for preventing stroke, but when you give the blood thinner, patient is developing a bleeding. You can do a LA appendage closure. Anybody has heard about LA appendage closure? So all. Acha, he has already shown? Okay. So LA appendage closure, I will just tell you where the LA appendage closure is there. So this is the LA appendage. And maximum clots are formed in this, and if you close it with the device, you will have prevention of any kind of clot which will go to the brain. So you already know. And what happens is when there is a atrial fibrillation, the heart is just fibrillating and the blood gets stagnated into the LA. So this is the blood which is getting stagnated in the LA appendage. Now this is a vestigial. So this is the clot which is coming out. This clot goes into the brain and it causes the stroke. So now there is a stroke. So if you close this by percutaneous intervention, you can go inside and you can close this. You can go inside and just put a device, just like we do a ASD device, and these patients do well. So if it's a catch-22 situation, our patients will be significantly benefited with this game changer technology. So where do we have the indication? Patient is at high bleeding risk. There can be old patients, or the patient cannot tolerate, has high risk of stroke, and we are in catch-22 situation, then you close this and the patient will do well. Now, this was a patient, live case. I will not go again. This I did a few days back. This patient is doing a very good, now we don't give any blood thinner and she's prevented from stroke. So this is another indication. Now let's discuss about the silent killer. So do you know the classification, do you know the definition of resistant hypertension? What does resistant hypertension mean? When you are giving 3 or more drugs, including one of the diuretics, and still the BP is more than 130/80, it's not within the target limit, it's called as resistant hypertension. And we should all understand our duty as a physician that high blood pressure is attributable cause for strokes, kidney failure, heart failure, and therefore controlling the blood pressure even if the patient is not symptomatic is of utmost important. We don't want our patients to land up into complications. So, and if you need 4 drugs to get the BP less than 130/80, again it is resistant hypertension. So 4 or more drugs are being used, or 3 or more drugs including a diuretic which are needed to control the BP, these are resistant hypertension patient. And suppose still the patient is not under control, what is the treatment line which is available? Have you heard about RDN, renal denervation therapy? So suppose somebody's blood pressure is very high and you are not able to control, you can actually insert radiofrequency ablation catheter. These are the kidney arteries. So this is the kidney. These are the nerves which are surrounding the kidney arteries, and they are hyperactive in some people, so the BP doesn't come down. You can go from the groin just like an angiography, angioplasty. You can apply the catheter and these nerves get numbed permanently. So the blood pressure comes down permanently. Lot of these patients, BP will be controlled, their drugs will be reduced or sometimes even stopped. So this we should know. Resistant hypertension not getting controlled with adequate number of BP medications, or patient not tolerating, consider the RDN therapy for these patients. Okay, so this is another game changer technology. Now let's discuss about the valves. So we see a lot of older people now with severe MR, severe AS, and these are the patients who are not fit for surgery. Now what do we do for these patients? Do we have any options? Yes. So the mitral valve can be repaired, mitral valve can be replaced, aortic valve can be replaced, tricuspid valve can be repaired, tricuspid valve can be replaced, pulmonary valve can be replaced. So we have 4 valves in the heart. All 4 valves can be treated with transcatheter therapies if there is a need. So this is, for example, the mitra clip, and this is the instrument which allows us to do the mitra clip. And so we go into the heart, and this is how the clip comes. I will show you. This is the clip, and you can apply the clip. So this is the leaking valve. So this is the mitral valve which is leaking. You go inside and you apply the clip. And this can do wonders for a patient. Now I have two patients who are posted. One of them is 81-year-old. They are going to come from Satna, MP. The other one stays in Ulhasnagar, and they are planning next week for mitra clip. These are all in their 80s where surgery is high risk, and we want to give them symptomatic relief, otherwise well preserved. So we have this technology which is available. So this is a clip. You can clip the valve and see that this was a leakage, and after the clipping the leakage has stopped. Now this was a case which I did some time back, severe MR, and so this is real life cases. This is how the clip looks like on the catheter, and this patient did well. Now let's discuss a tricky scenario. What could be the diagnosis and symptoms of pedal edema? Suppose somebody comes with swelling over the feet and swelling over the abdomen. What are the thought process which comes to your mind? What are the things? Right heart failure, or it could be even liver disease. So this patient which I am discussing was being treated like a liver case, cirrhosis of liver, pedal edema, ascites, and then she was referred for evaluation, and we found that she has got severe TR. She is again a mother of a physician, and she was 35 kg, very fragile, so we replaced the valve. So what you do is, you put one SVC valve. So our IVC and SVC, they drain into the RA. RA drains to RV through the tricuspid valve. So this was leaking. So I put two valves, one in the SVC, one in the IVC. I will show you how the real life looks like. And this stops the impact of the severe TR in this patient. So this was a 73-year-old female. This is the leakage, massive leakage. This all the blue color is a massive leakage across the tricuspid valve. This is the SVC valve. This is the real life case scenario. Again, this was the first case of Navi Mumbai Thane area which we did, or maybe second case of the entire Mumbai Maharashtra which we did. And this patient has done well. Now this is TAVI. If there is an aortic valve which is narrowed, you put a this valve and you can open it up. So those who have never seen TAVI, this is how the valve gets opened or valves get inflated. This is how we do it. Tomorrow I am going to do one case in Thane where the patient is admitted with cardiogenic shock, and she was found to have severe aortic stenosis. So, and she's not able to come out of the ventilator and all. So tomorrow we will do a balloon, and she will start doing well, because these patients are very high risk for surgery, but they can do very well with this kind of patients. Now we have some more time, so let's discuss about dangerous blockages. These days, I think all the complexity of the disease has increased. So we get patients who have got critical triple vessel disease. We get calcified vessels which are highly calcific, and it becomes very difficult to treat them. We get patients whose ejection fraction is just 15 to 20%. Day before yesterday, I did a young patient who came in cardiogenic shock, cardiac arrest in the office, CPR given, revived, and then this patient was very, very sick. EF just 10 to 15%, critical blockages. I did a procedure called as Impella. Have you heard about Impella? So Impella is the smallest heart pump in the world. And this is the size of the device. This is the motor. It goes into the heart, and then it starts giving blood supply to the entire heart. And this is a patient, I will just show you a real life case scenario. Calcified vessel, highly calcified left main, rejected for surgery, very high risk for angioplasty. I did this Impella, this is the Impella. And this takes care of the heart. Then you can do all the complex work. You can visualize the artery, you can break the calcium, you can cut the calcium. Do you know, are you aware about the calcium drilling technology, where we can drill the calcium? So there are many calciums. When the calcium is there, the angioplasty becomes very difficult. And we have technology called as orbital atherectomy. Rota was there. It is a diamond burr. It can actually burr. It can make the calcium into powder, and then you can do the angioplasty. So before that, I will tell you a case which is very interesting. Have you heard about near infrared spectroscopy? So this was a patient. You can actually study the plaque burden. So whenever we have got blockages in the heart, what is the composition of the blockage decides how the patient is going to behave. So this technology has come up which can actually study the composition of the plaque. I will show you. This patient came to us in a cardiogenic shock. I will show you. See, this is RCA, tight block, and this is the left main. Can you see? This is left main, completely occluded. The moment the patient's angiography was, patient was very bad, we were ready for intubation, breathless, severe chest pain, his left main is completely occluded. And this is the next step. Now what is happening? Can anybody tell what is happening to this patient? This is CPR. See, you can see the hands. Somebody is pressing the hand. Somebody is compressing the chest. And I am doing the angioplasty with the ongoing compression of this patient. Did the angioplasty. This patient is still, he's a ex-income tax of this thing, retired, and this life was saved. We did a balloon, metal-less angioplasty in this patient. We did the nurse. It was high lipid burden. And once we removed the lipid and we did this, he is without stent, but he is doing absolutely well. So these technologies have become game changer and very useful. I was talking about this calcium, the rock of calcium. They are very difficult to treat. So these are the calcium in the coronary arteries. How do we break them? It's very difficult. And they makes the angioplasty very difficult. So this is orbital atherectomy. See how it is shaving off the calcium. This is how what happens when we are shaving the calcium. See, it is shaving the calcium. And there are a lot of patients, we shave the calcium. After that, we don't even put the stent. So they do well. So I think these are the latest technologies which are there. This is the last case which we did. If somebody has got aortic aneurysm, you can actually do it with the stent graft. And these patients did very well. You must be aware about the leadless pacemaker, where you can put a small lead and they can do well. So intervention saves life when medicine fails. And I think there is now no option patients are not there anymore because the advanced technologies are there. And if you have a patient who has been said that nothing can be done, I think there is still a hope, because there are a lot of patients who come to us that this option was never discussed. So I feel that everybody should know about the newer technology, because the patient have they always come back to us, they always come back to you, and they want to ask what is there for us, can our father be treated? Just last week I treated a 93-year-old female with severe aortic stenosis at Breach Candy Hospital, and the relatives were saying, can we really do it? And we did a TAVR. This patient is now doing well, discharged. So we have a ray of hope for all kind of patients with these advanced technologies. So thank you very much. I have put my number.
There is one question from my side. Let's wait. Suppose the patient had chest pain, normal angio, coronary angiography normal, but the patient had chest pain. Now you have shown that that is a microvascular angiopathy or a microvascular angina. So what is the basic treatment for that?
Yes.
Right, first thing. Second thing, if this patient is responded to the treadmill test, there should be T inversion or it should be positive. Is it positive? Or what drugs you use? We should use.
Yeah. So when TMT can be positive in these patients, stress thallium can be positive in these patients, and when you do an angiography, it is normal, microvessel angina. Typical angina, angiography normal is microvessel angina. Now you want to find out whether it is, there are various kinds of microvessel anginas or normal coronary arteries with, so one is Prince metal angina, where we can do acetylcholine test. Here in Prince metal angina, if there is spasm, ST elevation and angiography comes out to be okay, then these patients do very well with nitrates, they do very well, beta blocker should not be given, they do very well with calcium channel blocker like diltiazem and verapamil. So this is one group. Then we go into the microvessels, and in the microvessels, it could be structural microvessel disease, it could be functional microvessel disease, or it could be mix of both. So the drugs which are useful and which you can rotate and see which patients benefit best is nicorandil, ranolazine, trimetazidine, flavidone MR and all those things, beta blockers, and the nitrates do not work in these kind of patients.
The point. Because what commonly GP they are using nitrates.
So nitrates will not work. Nitrates will not
That's
work.
why I'm totally. Thank you, sir.
Thank you. Thank you very much.
Thank you, sir, for such an engaging session, especially for sharing game-changing cardiology technologies for high-risk patient. Key home message is, if angiogram normal means patient should refer to coro flow test. Thank you, sir. I request our chairperson, Dr. Sabne sir and Dr. Aniruddha Joshi sir, to please felicitate our guest speaker on behalf of Raicon 2526. I request our guest speaker to please felicitate our chairperson, Dr. Sabne sir and Dr. Joshi sir. Thank you. Thank you, Global Hospital, for sponsoring this lecture. We will now proceed with birthday cake cutting. I would like to invite RMA President Dr. Ashutosh Kulkarni sir, RMA Treasurer Dr. Kumar Oswal sir, and RMA Secretary Dr. Prashant Gangal sir.
Happy birthday to you. Happy birthday to you.
Thank you everyone. Thank you RMA President, Treasurer and Secretary. Thank you Dr. Rahul Gupta sir. Once again happy birthday sir. Have a good day. I'll hand over next session to Dr. Sheetal.
We now begin the next session. It will address a critical issue that threatens the very core of our noble profession, violence against doctors. Today's lectures aim to go beyond root causes and exploring actionable solutions to foster a culture of respect and security. To shed light on this multifaceted challenge, we have Dr. Rajesh Dere sir as our guest speaker. The session is sponsored by Miracle Hospital. I request chairpersons Dr. Hemant Gangolia sir and Dr. Mukesh Oswal sir to kindly accompany our guest speaker to the dais. Welcome, sir. I request our chairpersons to kindly welcome Dr. Rajesh Dere sir on behalf of RMA's Raicon 2026 by offering a bouquet. I now request Dr. Rajesh Dere sir to kindly take out the lucky draw sponsored by Mumbai Oncology Center. Dr. Santosh Aglave. Yes, he is there. Come on, sir. Congratulations. Congratulations. It is my privilege to introduce Dr. Dere sir. Sir is Professor and Head of Forensic Medicine Department, Lokmanya Tilak Municipal Medical College, Sion. He is Secretary of Indian Academy of Forensic Medicine, Secretary of Medical Legal Association of Maharashtra, Chairman of Junior Doctors Network, IMA. He is known as Jumbo Man of COVID pandemic. He is Dean of India's first and largest hospital, BKC Jumbo facility, and is featured in World Record Book for developing more than 2,500 COVID beds with more than 120 beds of ICU and dialysis in just 17 days. He is director of all jumbos of BMC. Late Bharat Ratna Nightingale of India, Lata Mangeshkar ji has appreciated Sir's work with her own handwriting along with multiple government, state and national awards. He is awarded in House of Commons, London for his exceptional work during COVID pandemic. Dr. Rajesh Dere sir is Senate member of MUHS and has delivered hundreds of medical legal lectures across India and abroad. He has been appreciated by national and international agencies for providing forensic expertise in Tash terror strike, Mahim bomb blast, and has been expert for Government of Maharashtra for Agent Kasab's case in court of law. Sir, please.
So thank you very much. How much time is allotted? किती वेळ आहे काय? कारण आता 20 minutes we can take, right? कुठे? Okay. So we should start also then. So thank you very much. And thank you for RMA, the governing body of RMA, Dr. Kulkarni, Dr. Oswal and his team, for providing me an opportunity to interact with you on this, burning topic or current topic. And when I delivered this lecture, I am chief advisor to, there is a All India Government Medical Officers Union also, just like IMA. And chief advisor to them also, and I have delivered this when they required in Sofitel 2 years back. See, this topic what we are discussing is a never-ending topic for me. Because unless and until we the fraternity, that is the medical fraternity, I'm not talking of any allopathy, medical and all this, is a medical fraternity. Unless we are not aware for ourselves, no government, no police, no one will save you. See, this is the dictum. Sir is here, we have delivered many medical legal lectures along with him also. See, whatever laws are made, always keep in mind this is democracy. Our constitution is a democratic nation, and the first line of democracy is always to the people, for the people and for the people. So if it is for the people, so laws will always be for the majority of the people, not for the minority of the medical fraternity, and that too we are dissociated medical fraternity. Now, I am Senate member for MAHS and I am being voted across the pathies in, MAHS is not only for MBBS, it's for BMS, BHMS, UNANI, DMLT, CMLT, whatever medical related courses are there. So that is where I feel this we should be aware, and see this, no physician, however conscious or careful, can tell what day or hour he may not be the object of some undeserved attack, malicious accusation, blackmail or suit of damage. याचं सांगण्याचं काय आहे की आपण किती चांगलं वागलं ॲज अ मेडिकल प्रॅक्टिसमध्ये, यू आर 110% इथिकल, then also you can be blackmailed, then also you can be targeted, then also you can suffer from violence from the mob or so-called social workers. भरपूर उगम आहे प्रत्येक पार्टीमध्ये. And so-called few advocates who liaison with this social worker for the best interest of their own economy. So that is the major concern in now, or in society. It is not the major concern of, the aggrieved party legal has been complaining against the practice doctor. See, I have done more than 75,000 PM till now in my 28 years of career. But hardly 10% of the allegation against the doctor are suo moto, voluntarily made by the patient's legal heir. Legal heir म्हणजे त्यांचा नातेवाईक, मुलगा वगैरे. Or 80% are instigated by police or other agencies. It's a simple funda. Now, it is not only physical, I think, we all suffer from verbal and psychological aggression. Also, even in your OPD, I will tell, there is always an aggression. Aggression is more in government hospital or public hospitals like us, but still there is aggression in your private OPDs also. I will give one example, which I was member for Consumer Forum for 5 years. Injection on deltoid given technically. Nowadays there are no, आम्ही तर PHCला गरम करून टोचत होतो तरी काय होत नव्हतं, gentamicin. But now there is no such feasibility. Now everyone is using disposable. It may be of any quality, any brand. After giving injection, there was just reddening of that, deltoid area, and he suffered some pain and मी कामाला नाही जाऊ शकलो नेन. Then he filed a compensation for 10 lakhs, 15 lakhs, and the pure doctor has to appoint a lawyer. Then he has to spend lakhs of money, and त्या टेन्शनमध्ये ते म्हणतो मराठीत टांगती तलवार, काय होईल काय होईल. यू मे बी वॉट एव्हर नीडर, यू मे बी वॉट एव्हर यू मे बी रिच, यू मे बी इन्फ्लुएन्शियल, तुमचे घरातले मंत्री काय असं ना तिकडं, बॅक ऑफ द माइंड इट विल गो फॉर यू. प्लीज टेक इन दिस माइंड. कधी कधी काय होतं की वी फील की नाही नाही माझे एकदम आय एम रिच, माझा भाऊ लॉयर आहे, माझा कोणतरी जज आहे, माझा कोणतरी मिनिस्टर आमदार आहे, पण काही नाही. your human psychology for that case remains for you. They will only give you ancillary support from the society की जास्त मोर्चे नका काढू, जास्त शिव्या नका देऊ, मारहाण नका करू, याच्यातच उपयोग आहे. आणि लॉयर कोणीही असू द्या, we have to pay fees. आणि no lawyer in this world will guarantee you acquittal. And I have also done LLM and I guide many senior counsels. He may be Ram Jetmalani, he may be Manohar also, he may be Mundargi also. You may give him 5 lakhs per standing, 10 lakhs per standing. No counsel will guarantee you acquittal. If any counsel म्हणजे advocate, if he guarantees you the acquittal, he is the foolish practicing advocate in these courts. हे मी नाही म्हणत, हे बारवाले बोलतात. Right? So it is not only your physical way. See, there are these few major factors, but it does not include everything. Please keep in this mind. Emotional stress. Now in government sector, workload is our emotional stress, right? Now in private sector, earning more is the emotional stress. To earn more, we have seen many consultants running across 5 to 6 hospitals. In Mumbai, traveling is such a headache. In cities, what to do to maximize the profit? So he may practice in Apollo, he may practice in 30-bed nursing home, he may practice in 100-bed specialty or multi-specialty hospital. Still the emotional stress will evolve around you always. Then long wait times and frustration, mainly for government hospitals and public dispensaries. Disagreement over the treatment. No, last 5 years now, since COVID, when everything is online, COVID has given good things like online reporting of CT and MR. आता रेडिओलॉजिस्टला पैसे जास्त हॉस्पिटलच्या मालकांनी खर्च करायची गरज नाही पडत. Still they are in high demand for ultrasonography. But now online reporting, because of COVID, is legalized. तर तुम्ही इथे तुमच्याकडे जर CT असेल, तुम्ही वर्ल्डचा बेस्ट जो रेडिओलॉजिस्ट आहे, यू कॅन टेक हिज ओपिनियन नाव and with least finances. So disagreement has increased because now Google and AI, पहिला Google होता, एकच बाप होता सर्वांचा, आता मल्टीफॅक्टोरल बाप आलेले आहेत. चॅट GPT, काय परप्लेक्सिटी. Now in next 2 years everything would be AI based. There are robots now started surgery, neurology and this. 18-20 लाखाचा robot which can be controlled from the computer. Just like I made robots, first world's robot in BKC to serve food, to take BP and pulse, because manpower was deficient. So this is where disagreement will increase. म्हणून बऱ्याचशा मी कन्सल्टंट जे टेक्निकली चांगले आहेत ते बाहेर बोर्डच लावतात की गुगल पेशंट असेल तर यू आर नॉट अलाउड टू टेक माय कन्सल्टिंग. इफ यू आर ए गुगल पेशंट प्लीज डोंट अटेंड माय OPD. कारण तुम्ही कितीही चांगली ट्रीटमेंट द्या, ही विल सर्च इन फ्रंट ऑफ यू. अरे डॉक्टर, इथं तर डॉक्सिसायक्लिन लिहिलं आहे, तुम्ही ॲमॉक्सिलिन कसं काय देऊ शकता? सो दिस इज वेअर दिस लॅक ऑफ कम्युनिकेशन अगेन. This is the chapter I know I always discuss. The best of the best surgeon like Dr. Panda has suffered because of lack of communication. याच्यापेक्षा मोठे तर डॉक्टर मुंबईत आता फार कमी आहेत. की ऑलवेज मेक अन हॅबिट. मी सांगतो, यू मे बी बेस्ट डॉक्टर आणि तुमच्याकडे रोजची 200ची OPD आहे आणि तुम्ही फार बिझी आहे आणि एकदम 2-2 मॅनेजर ठेवले आहेत, सगळं ठेवलं आहे, तरी लॉ मॅन्डेट्स इफ यू आर टेकिंग चार्जेस फ्रॉम युअर पेशंट, you may be any senior consultant, junior consultant, it is your pertinent duty to talk with him and to explain and advise him at least for 1 minute. So media influences, आता मीडिया जर प्राईम मिनिस्टर बनवू शकते तर डॉक्टरांची डिग्री पण काढू शकते. Like media influences or WhatsApp University. You know, there are agencies in Mumbai, across India, they take fee for creating a perception. म्हणजे मी किती चांगला डॉक्टर आहे, जर माझं नाव खराब करायचं ठरवलं आणि चांगली मीडिया टीम लावली, कारण आज नो मीडिया इज इंटॅक्ट, नो प्रिंट मीडिया इज न्यूट्रल, एव्हरीथिंग इज इन्फ्लुएन्स्ड इन दिस वर्ल्ड बाय मीडिया. सो कल्चरल अँड लँग्वेज बॅरियर, रिसोर्स लिमिटेशन फॉर गव्हर्मेंट हॉस्पिटल, mental health issue, lack of security measure. This is, security team. In last term IMA I have discussed with Dr. Utture and all this. We should have own security team for doctors also. See, तुम्ही किती पोलीस स्टेशनला, आता मी इन अँड आउट 28 years पोलिसांबरोबर आहे. यू जस्ट इमॅजिन की तुम्ही किती कॉल करा स्टेशन हाऊसला, डू यू एक्सपेक्ट ते तुम्हाला मार खास्तोपर्यंत येणार आहे तिथे? एक भगवतीला 8 वर्षापूर्वी एक केस झाली, कोलॅप्स आणि PM माझाच बॅचमेट करत होता. पोलीस सिनियर PI बाजूला उभे, त्याच्या पुढे तिथला सिटिंग आमदार आता तेव्हा पण होते, येऊन त्याला कानाखाली मारून गेला आणि पोलीस बघतो. सो सेक्युरिटी हॅज टू बी टेकन कन्सर्न. थोडं 100 रुपये जर मी कमवतोय ना, दिस माय ओन पर्सनल व्ह्यू, की 10 रुपये सेक्युरिटीला घालवा तुम्ही. कारण तुम्ही ते 10 रुपये वाचवण्यासाठी, इफ यू वॉन्ट टू सेव्ह युअर 10 rupees, you will spend your 100% of money if you are assaulted by your patient or the relative. That psychological trauma and stress will not leave you to sleep for minimum 5 years. And these are few relatives of the assault doctors and all this. Now see this, the way we are assaulted. These are few example. You can see how much blood, vandalism in the hospital. Now see, these are various cases of brutal treatment. What is more alarming for me is, you see this data. See, over 75% of the doctors across the country are reported to have faced at least some form of violence. This is not my data, it is compiled by Times of India. And it's actual data. Now, escort of the patient committed 68% of the violence. म्हणजे जे पेशंट बरोबर येतात त्यांचं, डॉक्टर्स हॅव बीन डिमांडिंग ए सेंट्रल लॉ, अजून आलेला नाही आहे. 2दा पार्लमेंटमध्ये आला, डॉक्टर कोल्हेंनी मागे विषय घेतला, पण नो वन ॲग्रीड टू हॅव ए सेंट्रल स्ट्रिंजंट लॉ which will create a barrier for all such activity. Around 18 states already have laws in place, but they are toothless. आपल्या इथं पण आहे मेसमा. Clear cut आहे, first it is a non-bailable offense. Show me one assaulter against hospital or doctor who has been booked under non-bailable offense. कारण आपल्याला वाचवायला जास्त पुढारी नाही येणार, पण त्यांना वाचवायला 10 नगरसेवक उभे राहते. So why doctors waste? Who is to be blamed? See, this is all nurses receiving aid, high emotions. These are all authentic data, and it's just, I wanted to show you because that's where, that's where the seriousness, even now 50% are standing in the porch. They are also not serious of this. See this. These are a few videos. The way we are vandalized, assaulted, they brutally, assault the doctors. It's not कि एक झापड़ मार ली. You can just have a look. Now all this, MAD and all this will go on strike. 2 दिवस government CM meeting होतात, and then see this article, I think you have read from Mumbai Mirror. Is given by one of the senior consultant of Mumbai. Don't want children to enter in medical profession. काय हालत झाली आहे बघा आपली. की now the senior consultant are feeling that I will not put my kids or offspring to any of the medical college for being a doctor because of all this. See this? The handwritten notes, doctors in subjected. Now what is more important is prevention, which we are not spending time, and I am sorry to say at least आम्ही गव्हर्नमेंटमध्ये आम्हाला कंपल्शन आहे कम्युनिकेशन स्किल. PGला पण आम्हाला पीडोलॉजी PG स्टुडंटला 7 मार्काची फॉर कम्युनिकेशन स्किल, बट फॉर प्रायव्हेट प्रॅक्टिशनर्स यू आर नॉट स्पेंडिंग इवन 2 minutes फॉर टू गो थ्रू दी प्रोसेस हाऊ टू प्रिव्हेंट. सी आपण सगळ्यांनी मेडिकल केलेलं आहे, मे बी डिफरंट स्ट्रीम. PSM मध्ये एक ब्रीद वाक्य आहे, कार्डिनल सेंटेन्स, प्रिव्हेन्शन इज बेटर दॅन क्युअर. इज अ डिक्टम. आपण प्रिव्हेन्शनसाठी काहीच करत नाही, पण इश्यू झाल्यावर त्यानंतर सुटण्यासाठी लाखो रुपये खर्च करतो आपण. मग बऱ्याच जणांच्या हातापाया पडतो, पुढारी झाले, इन्फ्लुएन्शियल पर्सन्स ऑफ द सोसायटी झाले, पण वी डोंट गिव्ह अ सिंगल मिनिट ऑफ आवर प्रॅक्टिस to prevent ourselves from all this. What is this? Training program for doctors. आम्ही घेतो. Now there is compulsory 30 MMC we have done, everything we have done, everything is right in place. पण किती लोक अटेंड खरंच करतात? You can see from this. I think we have 600 registration. बरोबर आहे? Now hardly 50-70 doctors are attending. I am not against anyone, it is their liberty. But I want to show the seriousness of the मेडिकल फ्रॅटर्निटी की वी आर इन मेडिकल कॉलेजेस एव्हरी मंथ 2-3 CME असतात. कोणती तरी डिपार्टमेंट घेतं. वी जस्ट गो अँड साईन आणि पॉईंट जमा करतो. सी फॉर मेडिकल टीचर्स वी गेट इझिली बिंग इन दॅट प्रोफेशन, बट बाकी येतात नाव टाका आमचं, सही करून आम्ही निघून जातो. सो दॅट इज नॉट टू सॉल्व दॅट पर्पज अँड ऑब्जेक्टिव्ह ऑफ दिस. डॉक्टर पेशंट रिलेशनशिप, आर वी डुईंग एनिथिंग? नो, वी आर नॉट डुईंग एनिथिंग. किती प्रायव्हेट प्रॅक्टिशनर्स आहे किंवा गव्हर्नमेंट आहे की तुम्ही सोसायटीत जाऊन आर यू गोइंग टू सोसायटी फॉर एनी सोशल प्रोग्राम अँड ट्राय टू कन्व्हिन्स दम की व्हॉट गुड वी आर डुईंग फॉर यू अँड दिस सोसायटी? हार्डली 1-2 बोटावर बाबा आमटे सारखे दिसतील. देन कोलॅबरेटिव्ह एफर्ट बिटवीन हेल्थकेअर इन्स्टिट्यूशन, गव्हर्नमेंट बॉडीज अँड लॉ एन्फोर्समेंट एजन्सीज. हे हार्डली CMEला यू मे कॉल VIP to SP, DYSP, सिनियर PI, DHO, ADHO, MS, आणि 10 मिनिटांनी चहा पाणी झालं का युअर इंटरॅक्शन इज ओव्हर. ते त्यांच्या घरी, आपण आपल्या घरी. इज नॉट द राईट वे ऑफ इज नॉट कॉल्ड एज अन कोलॅबरेटिव्ह एफर्ट. एंगेजिंग हे पण नाही. फास्ट ट्रॅक कोर्ट. इफ गव्हर्नमेंट काय नाही फास्ट ट्रॅक कोर्ट फॉर वॉक्सो, फॉर फिमेल ऑफेन्सेस, फॉर ताडा, फॉर MCOC, why can't they have fast track courts for medical professionals? What is wrong in that? एक जजेस तर नेमायचं आहे. काय म्हणजे काय, व्हॉट इज द ग्रेव कन्सर्न की पैसा कोणता आहे गव्हर्नमेंट चालवणारे लोक आपल्या खिशातनं भरतात? इट इज द पब्लिक टॅक्स ओनली. दे आर पेईंग टू द गव्हर्नमेंट सर्वंट. त्यात मी पण आहे. सो वाय कांट, इफ 10 years we require now, I think 15 days before Ganguly sir, एक verdict आलं पॉझिटिव्ह आफ्टर 11 years. आणि ते पण इतकं मायनर पनिशमेंट, काय भीती बसणार आहे. ही असॉल्टेड, त्यांनी मेजर इंजुरीज केल्या, डॉक्टर ग्रीवियस इंजुरीमध्ये इन्फ्लिक्ट झाला आणि 2 ते 6 महिने शिक्षण, त्याच्यावरही बेलेबल हे पैसे भरून मोकळा झाला. देन अवेअरनेस कॅम्पेन, security of sensitive hospital, private hospitals are taking CCTV installation now, everyone is doing. Central, see, this is what if IMA can do. Now I am chairman of JDN, Junior Doctors Network. We have a meeting, we are trying for this. Ki jasa we have a control room for police, why can't every district IMA have a control room, for all these activities? Ki if any incidents happen, just like we call Chamber number, we can have hotline number. Any doctor in trouble, irrespective of the stream, he can call that control room at district, and the district committee should take utmost efforts to mobilize whatever is required to save our fraternity. So this is, I think we should think better. Infra expertise filling a entry restriction. See, this everyone is doing in hospital. Hope general practitioner will do. Give me only 5 minutes, I will not take more than this. Rape and murder, see this. Now they are gone beyond this. Even the female doctors are raped and murdered also. So what is the safety now? Nothing is the safety. स्वतः जागे व्हा, स्वतःसाठी स्वतः लढा. Does the law is enough? See, this is our so-called law in Maharashtra Medical Care Service. 5 minutes, not more than that. Service and Medical Care Institutional covers a registered practitioner, nursing, paramedical, punishment, non-bail, everything is good on paper, but is not implemented in true spirit. So what is the use of this law then? जर law तुम्हाला वाचवतच नाही आहे, तो law काढून कशाला फायदा? Just to give pacification to doctor community, किंवा आम्ही तुमच्यासाठी लॉ काढला, आम्हाला मतदान करा, आम्ही तुमच्यासाठी फार चांगले आहोत, एवढंच आहे त्याचा वीस. 10 years we are trying for central law. There is no uniformity in 26 states. Worst part, what is in the parliament, majority of the state has opposed this. तुम्हाला ही फॅक्ट आहे, तुम्ही पार्लमेंटची यूट्यूब बघा, त्याचे प्रोसिडिंग्स पण वेबसाईटवर अवेलेबल आहेत, की मोर दॅन 16 states आर अपोज दिस. आय डोंट नो व्हॉट इज हार्म विथ द पॉलिटिशियन, की आर वी नॉट ट्रीटिंग पॉलिटिशियन? वी आर ट्रीटिंग them also, na? They are policy makers. We are treating bureaucrats also. They are also policy makers. See, deterring attacks on a non-bailable as per our act, but is not implemented. Does the law, this is the Law Commission of India. Only under this act, damage of the public property, if that healthcare institution is a public institution. Under this, private institutions are not covered. So we can only protest. 2 दिवस काळ्या फिती बांधू आपण, 2 मेणबत्त्या घेऊ, अर्धा तास आपण चालू, मॉर्निंग वॉक, इव्हनिंग वॉक होऊन जातं. 2-4 प्रेस रिपोर्टर माझ्या तुमच्या ओळखीचे गोळा करायचे, आणि चांगली बाईट द्यायची, अँड देन आय विल मेक माय बाईट व्हायरल. बघा मी कशी बाईट चांगली देतो. संपलं. आफ्टर 3rd day हिस्ट्री रिपीट्स इट सेल्फ. सेम होणार. आणि व्हॉट इज worst part of our fraternity, say I started medical teacher association in BMC. I was the municipal medical teacher association. मेडिकल फ्रॅटर्निटीला वाटतं माझ्यावर नाही आहे ना, मरू द्या, पडू द्या. आणि सगळ्यात सेल्फिश मेडिकल टीचर्स आहेत, म्हणजे आम्ही. नो वन इज बॉदर्ड फॉर दी कलिग. दे फील की माझ्यावर जोपर्यंत येत नाही, आणि जर माझ्यावर आलं तर आय एक्सपेक्ट सगळ्यांनी मदत केली पाहिजे आम्हाला. तुम्ही बघा काय, तुम्ही कशाचे डॉक्टर आहात. पण जेव्हा दुसऱ्यावर येतं, अँड वेन ही इज अप्रोचिंग यू टू सपोर्ट, ॲटलिस्ट यू मे नॉट डू एनिथिंग ॲक्टिव्ह फॉर हिम, just give a support, be with him at least. That will, engrave his grief 50% minimum. ते तरी करतो का आपण? No. वी ऑलवेज फील जाऊ दे 10 पेशंट वेटिंगला आहे, त्याला अजून मारलं नाही ना, मारल्यावर मी जातो पोलीस स्टेशनला. आणि वर्स्ट पार्ट सर, मी याच्यात घेतलं नाही, एक मी टॉपिक शिकवलं सुरू केला आहे 2 वर्षापासून, ऑनेस्टी अँड इंटिग्रिटी इन हेल्थकेअर प्रोफेशनल्स. हां, इथेही बोललो होतो पण दे वॉन्टेड धिस आता प्रॅक्टिशनर लेवलला. वन ऑफ द मेजर फॅक्टर ऑफ दिस इज प्रोफेशनल JLSC ऑल्सो. ज्या दिवशी ते यूट्यूब आय विल शेअर ऑन द ग्रुप, मी नॅशनल बॉडीला घेतलं आहे. वर्स्ट इज माझ्या बाजूला कॉम्पिटिटर आहे आणि कसं मी काड्या करतो आणि माझी नाव कसं होईल आणि दुसऱ्यांचं कमी कसं होईल, हे सगळ्यांना लागू होत नाही. देर आर फ्यू ओनली, बट आहेत. आय हॅव नेम्स, आमच्याकडे केसेस आलेले.
प्रोफेशनल जॉस्टिंग.
येस, ते वर्ड आहे. सो थँक्यू व्हेरी मच. जागे व्हा, आपल्या लोकांसाठी थोडा वेळ द्या. तुम्ही तुमच्या लोकांसाठी, इफ यू फाईट फॉर युअर पीपल, दे विल फाईट फॉर यू. Nobody is there to take care of medical practitioners or medical fraternity. And you know, public says की डॉक्टरांनीच कमी पैशात करायचं. लॉयर पर स्टँडिंग 20 लाख VR मनोहर घेऊ शकतं. जेठमलानी 21 लाखाची लिगल फी घेतो पर स्टँडिंग. त्याच्यावर कोणी ऑब्जेक्शन घेतलं आहे का? पण एक डॉक्टरनी, जसे सुधांशू भटे टॉपचे पांडा सर आहेत, इफ दे चार्ज फॉर वन सर्जरी मोर दॅन वॉट द अदर कलिग्स आर चार्जिंग, लगेच सोशली येतं. बघा, डॉक्टरांना सामाजिक बांधिलकी काही राहिलेली नाही आहे, राईट. आणि बघा, यांना माणुसकीच नाही राहिली. म्हणजे सगळी माणुसकी काय डॉक्टरांनीच पाळायची आहे का? आपण बोलतो का कधी दुसऱ्या फ्रॅटर्निटीला? वाय पीपल आर नॉट थिंकिंग की अदर्स आर ऑल्सो चार्जिंग. तुम्ही एक मशीन, आता वी आर टेकिंग सो इक्विपमेंट, मी तर किती खरेदी केलेत कोविडला, मीच एक्सपर्ट झालो आहे मशीनमधला कॅलिब्रेशनचं. हां, एक तुम्ही बायोमेडिकल इंजिनियर त्याला बोलवा, त्याचे व्हिजिटिंग चार्जेस 1,500-2,000 घेतो तो. हात पण नाही लावत तो. आर वी क्वेश्चनिंग हिम? आर दी सोसायटी क्वेश्चनिंग दम की वाय दे आर चार्जिंग एक्सेसिवली? बट एव्हरीवन in this society is ready to question medical profession. Only reason is we are the soft target of the society. And why we are soft target? Because we are dissociated. And we are the most selfish profession available in this country. Sorry to say, कोणाला माझ्यावर डिफेमेशन करायचं बिंदास करा. I am ready to face. But this is a fact. ते मलाही लागू होतं. असं काही नाही की मी फार याच्या बाहेर आहे. So thank you very much for your patience hearing. And thank you Raigad Medical Association, Dr. Kulkarni, Dr. Oswal, Gangwal sir and all his team. सगळ्यांची नावं माहीत नाही. साबणे सर आहेत सिनियर खूप, यांचं नाव ऐकलंय मी आता होते. Thank you very much. And if anything is there, I am always ready to reply for that. Thank you.
Sir, they try to do capping of fees, but they should do capping of compensation also.
Right. They are not capping ना. तुम्हाला तर माहिती आहे, आता जे आपलं रिफॉर्मिंग झालं कोविडच्या अगोदर, दे हॅव इन्क्रीज लिमिट ऑफ स्टेट कन्झ्युमर फॉर टू लिमिटलेस. म्हणजे मला जर एखाद्या इंजेक्शनला ॲब्सेस झाला आणि टेक तुमचं बॅड लक आहे, मी एक नाव घेऊन एक्झाम्पल देऊ शकतो, इट इज इन पब्लिक डोमेन. एक हिरोईनला जर तुम्ही केलं, समजा तिच्या चेहऱ्यावर पश्चू लिहिलं, विच इज अ नोन आउटकम, यू मे गिव्ह ऑगमेंटिन, नाही पाहिजे थोडं महागडं, यू मे इन्फ्यूज हर, आणि तिथे जर 15 दिवसाचं शूटिंग गेलं, शी विल सी यू फॉर crores of rupees. यू ऑलवेज कीप दिस इन माइंड. एक स्किल्ड हँड आहे, समजा तो कोण होता माधुरी दीक्षितचा तो काढणारा टॉपचा आर्टिस्ट, काय नाव, हां, समजा त्याच्या हुसेनच्या हाताला काही झालं आणि यू टेक अ स्टिच आणि तो 1 महिनाभर त्याची ती पोर्ट्रेट काढू नाही शकला, ही विल से की 1 महिन्यात मागच्या 3 वर्षात वर्क कंपेन्सेशन ॲक्ट खाली मी 10 पोर्ट्रेट बनवले आणि 1 पोर्ट्रेट माझी 1 कोटीला जाती, आणि तेवढा लॉस आहे डॉक्टरच्या ट्रीटमेंटमुळे झाला आहे. अँड आय शुड बी कम्पेन्सेटेड. इन ॲडिशन टू दिस, जेवढा डिले होईल त्याला 9% पर ॲनम व्याज लागतो. हे पण ध्यानात ठेवा, नुसती मुद्दल द्यायची नसती. पण आपल्या इथं बरेचसे, आता माझी बायको GP करते, आमचे 30% पेशंट चाळीतले वगैरे 3-3 वर्ष उधारीच देत नाही, तरी आम्ही नाही म्हणत नाही कोणाला औषधं द्यायला. सो थँक्यू. वाय वी आर एक्सप्लेनिंग ऑल दिस इन व्हेरियस फॉरम इज टू जस्ट टू every fraternity सोडून द्या, मी BMS आहे, MBBS आहे, BHMS आहे, आयुष आहे, सोडून द्या ते आता. ते टेक्निकल लेवलवर वी विल फाईट अमॉंग आवर सेल्फ. दॅट इज नॉट आवर इश्यू ॲट ऑल. बट दिस इज द सिरियस इश्यू. आणि हे जर तुम्ही नाही केलं तर एक दिवस असा येईल ना की तुम्हाला, आता काही लोक जसे देतात ना पाकिटं महिन्याला, तसं लोकल यांना द्यावं लागेल. तर नाव नाही घेणार पण द्यावं लागेल, ही वेळ येणार आहे. प्रोटेक्शन मनी लक्षात घ्या. थँक्यू व्हेरी मच.
Thank you, sir, for this highly informative and insightful session. Yes, sir. I now request our chairpersons to kindly felicitate Dr. Rajesh Dere, sir, on behalf of Raicon 2026. Thank you, sir. I now request our guest speaker, Dr. Rajesh Dere, sir, to kindly felicitate Dr. Hemant Gangolia and Dr. Mukesh Oswal. Thank you, sir. Dr. Mukesh Oswal, sir. I request Dr. Kunal to take over the mic. Sir, तुमचं हे.
Good afternoon, everyone. Our next session is on interpretation of thyroid function test, and for that I request our chairperson, Dr. Gajanan Chavan sir and Dr. Jayashree Deshmukh, to please escort our speaker, Dr. Prashant Gaikwad. Yes, sir. आहेत. I request our chairperson to welcome our guest speaker with a bouquet. Just a minute. There is one more lucky draw sponsored by Policy Era. I request our guest speaker to please do the honor. हे आहे. हां. हात जाईल. दोन. डॉक्टर M.N. दीक्षित पनवेल. Second one, sir, one more is there. Dr. Shalaka Patil, Alibag. Dr. Shalaka Patil. Dr. Pratik Kambli. Dr. Pratik Kambli.
रजिस्ट्रेशन डेस्क वरती
आहे.
Congratulations, Dr. Pratik. You are waiting since long time.
Congratulations to all winners.
पॉलिसी एरा रायगड मेडिकल असोसिएशन आमचं कोलॅबोरेशन आहे आणि आपण सर्वांनी या पॉलिसी एरामध्ये आपल्या इंडेमिटी इन्शुरन्स असेल किंवा कुठल्या इन्शुरन्सबद्दल तुम्हाला जर काही आवश्यकता असेल तर नक्की पॉलिसी एराच्या आपल्या प्रतिनिधींना कॉन्टॅक्ट करा. 2 मिनटं ते बोल.
So first of all, thank you all the dignitaries and especially requested Dr. Kulkarni sir, Dr. Kumar Oswal sir, Dr. Gangal sir for giving us an opportunity so that we can explore our policy areas, indemnity insurance exclusively for the RMA members. We also have the entire scheme, customized plan for professional as well as hospital indemnity. So do call us. We will understand your policy, the schemes, and then you the best options available. Thank you for that. You can contact me directly also. My name is Milind Chilate. So number is 70450 21897. I will also circulate my numbers within Dr. Kulkarni sir so that he can also connect within the group sir. So once again, thank you all for the support from RMA, and we'll explore for the next coming years as well. Thank you.
Yes, thank you.
Thanks.
I am privileged to give introduction of our next speaker, Dr. Prashant Gaikwad. He has done his MBBS, MD, General Medicine, DM, Endocrinology. Expertise in diabetes, thyroid disorders, PCOS, osteoporosis. Manages complex hormonal and metabolic disorders in adults and children. Known for evidence-based patient-centric care. Affiliated with White Lotus International Hospital, and today's topic is interpretation of thyroid function test. I request Dr. Prashant sir to do the rest.
Slideshow. This slideshow. So this will be regarding the thyroid function test, and I am thankful to the RMA for the opportunity, especially Dr. Kulkarni and the Oswal sir. So it will be the case-based approach mainly. It is practical cases. It is compilation of all my old patients' records, and who are interested in the cricket should be knowing this, what is regular off-break and what is dusra. Okay, that is going out. One is the dusra and that is coming in is the regular off-break. So we have to pick up the dusra of the thyroid function test to take care of our patients. So some of the interesting cases. So we'll start with the case scenarios. The first case here. So 28-year-old female having the headache, palpitation, nausea, vomiting for past 1 month, history of irregular menses and now amenorrheic, and family history of hypothyroidism is there. On vitals, we can see the BP is 110 by T and the TSH was 0.1, free T4 was on higher side and the prolactin is increased to 110. So I expect the answer from delegates. Anyone want to answer? So I will give the clue for the diagnosis. Anyone? Pregnancy, good. But it is physiological hyperthyroidism of the pregnancy. So how the pregnancy causes hyperthyroid-like state? So in the pregnancy, there is an increase in the estrogen level that leads to increased thyroid binding globulin. So if you do the total T4, it will be on the higher side.
Along with that, there will be increase in the SCG level. So SCG and the TSH, alpha subunit is same. So SCG will act on the TSH receptor. So in the pregnancy, we will get the low TSH level. So that is the hyperthyroid-like picture. Other than that, in the pregnancy, what happens? There will be the increase EGFR or the glomerular filtration rate, though. So that leads to the increased iodine loss in the urine and increased requirement of the iodine. So these are the some of the changes in the pregnancy, as we can see here. So in the first pregnancy trimester, there will be a surge of the SCG. The increased SCG level leads to low TSH because the same alpha unit. And as I talked earlier, the increased estrogen lead to increased TBG and the increased total T4 levels. So that is the physiological hyperthyroidism of the pregnancy. So in such cases, we should not start with the propylthiouracil or the neomercazole. Okay. So how to differentiate between the Graves' disease in the pregnancy and the normal pregnancy? So for the Graves' disease, there will be the stigmata of the Graves, that is the thyroid swelling, orbitopathy may be there, or clubbing may be there, or pretibial myxedema could be there. And for differentiation, we can do the TSH receptor antibody, that is specific for the Graves' disease. That will differentiate between the Graves' disease or hyperthyroidism of the pregnancy, that is physiological. So these are the some of the reference ranges for the TSH level and the T4 levels. So any time you are interpreting the reports of the pregnant lady, we should use these reference ranges. We can see here the reference range for the non-pregnant and the pregnant is different. So maximum suppression of the TSH is seen at the first trimester, that is due to the SCG surge. So these are the changes whatever I have discussed earlier. So this is the summary. So second case, we'll move. 11-year-old female with a history of failure to gain height. Her height was minus 4.2 standard deviation, indicating severe short stature. She had the history of recurrent hypoglycemia. Headache was there and the blurring of the vision was there. And we have done some of the investigation that has shown that the serum cortisol was on the lower side, free T4 was on the lower side, TSH normal, IGF-11, that is surrogate marker of the growth hormone, that was also on the lower side. So patient has the insufficiency of the cortisol, then the thyroid insufficiency and the growth hormone deficiency also. So this is the picture of the patient. And further, for the diagnosis of panhypopituitarism, we have to rule out the pituitary cause. We have done the MRI. So that is the coronal section. We can that is the sagittal section showing the cellular and supracellular mass, and that is likely craniopharyngioma of the pituitary gland, and that is causing the compression of the normal pituitary gland, leading to panhypopituitarism. So this is the axial section and this is the craniopharyngioma. For this patient, we have suggested the transpenoidal resection of the pituitary gland, and after that the patient has been rendered panhypo, and we have started with the supplementation, that is growth hormone has been started, cortisol supplementation has been started, and the thyroid supplementation has been started. So from here we can take a point that the TSH may be normal, and in such central hypothyroidism, free T4 is always on the low side. So any patient who is coming with the low T4, normal TSH, we have to suspect the central hypothyroidism. The cause is at the pituitary level. So in central hypothyroidism, TSH may be low, normal, or it may be high. So what are the causes of the central hypothyroidism? As in this case, it could be cellular or supracellular mass or paracellular mass, head injury or pituitary apoplexy, that could be secondary to diabetes or sickle cell, thalassemia, or it could be a surgery of the pituitary gland itself, or it could be an infection or the inflammation of the pituitary gland. So what clue you get for the central hypothyroidism? So this patient have the raised intracranial pressure, and that can lead to the headache or blurring of the vision due to the optic chiasmal compression. So bitemporal hemianopia is a common. So many of these patients with bitemporal hemianopia were referred to the ophthalmologist, then they advised the MRI, and they have found it is pituitary lesion that is causing the bitemporal hemianopia. So panhypopituitarism is nothing but the two or more hormone deficiency that is secreted from the pituitary gland, that is panhypopituitarism. If you get such patient, we have to go for the MRI pituitary. And isolated TSH deficiency is very low. So For the central hypothyroidism, TSH is not useful. We have to go for the free T4 or total T4 level. And patient with the cortisol insufficiency, having the concomitant cortisol insufficiency and thyroid deficiency, we have to start with the cortisol supplementation first, and then we have to go with the levothyroxine. So reason for this is if you start directly with the thyroid supplementation and patient is having underlying cortisol insufficiency, patient may land up with the adrenal crisis. Okay. To prevent the adrenal crisis, we have to start with the cortisol supplementation, and then we can start with the levothyroxine supplementations. So this is the case 3, 60-year-old male admitted in the ICU with pneumonia. He is on the mechanical ventilation and managed with the IV antibiotics and supportive care. Patient is improved and extubated. On clinical examination, it was almost normal and TSH was found to be 0.05. So what is the next? Anyone from the audience want to answer? So what investigation will you advise next? So next investigation will be the free T4 and the total T3. So we can look at this, the free T4 that is on the lower side and total T3 is not low. So from this we can make out what is the diagnosis. Patient is having critical illness and recovered from the critical illness now. So it is non-thyroidal illness that is related to critical illness. So what happened with the critical illness? So any patient who is having the critical illness, we should not advise the thyroid function test until we are suspecting myxedema coma or thyroid storm. So what is the mechanism that leads to the low TSH level and the low T4 and the T3? So it is decreased activity of deiodinase 1 and deiodinase 2 that leads to decrease in the T4 and T3 levels, and augmented D3 activity leads to the low T3, increase reverse T3 levels. So this is the mechanism or the activity of the deiodinase that leads to the low TSH that increases subsequently with the recovery, and low T3 and the T4 levels. So some of the drugs that has been used for the critical illness, such as the dopamine or the glucocorticoid, this suppresses the TSH levels. Even the heparin or furosemide, what is used in the critical illness, can replace the T4 from the TBG and can lead to the elevated T4 levels. So in the critical patient, we have to think before sending the thyroid function test. So this is the case 4. 20-year-old primary hypothyroidism for 8 years on levothyroxine 75, recently started college. He says his compliance is good with the therapy. He came for the routine checkup. We have found that the TSH is 10.8 and free T4 above normal range, that is 1.9. So what is your diagnosis? Anyone? So what is the diagnosis? It is non-compliance. So most of the patient who come with such report, we suspect the non-compliance because the TSH is on the higher side and T4 is normal. So most of the patient do one thing, they are non-compliant with the therapy, and before taking the giving the sample for the thyroid function test, they take the levothyroxine supplementation. So if they take the supplementation 1-2 days prior to the testing, the free T4 will be on the normal side and the TSH will be elevated. So it is non-compliance. So 41-year-old diagnosed with the hypothyroidism since 15 years, and he is following with the local practitioner, and the levothyroxine dosage we can see here started with the 100, then decreased to 75 and further increased to 225 and 250. So TSH is fluctuating throughout the course. She is having the TSH more than 100 also. So in such cases, how to approach? So it is uncontrolled hypothyroidism. In such cases, we should first ask the history, the compliance with the medication, or patient is taking it in the fasting and then taking the breakfast after half an hour or 1 hour. And other than this, patient is taking concomitant other drugs also. So iron, calcium may inhibit the absorption of the levothyroxines. Other than this, we have to rule out the malabsorption, that is due to the H. pylori infection or the celiac disease or gastritis. So this is the normal pathophysiology. The maximum absorption of levothyroxine occurs at the upper jejunum, and bioavailability is 62 to 82%, and after 3 hours of the taking levothyroxine, there will be the peak levels of the levothyroxine. So these are the some of the drugs that interfere with the absorption of the levothyroxine. That is proton pump inhibitor, calcium supplementation, aluminum hydroxide in the liquid form, or it could be tricyclic antidepressant or phosphate binders. So these drugs may interfere with the absorption of the levothyroxine. Other than this, the pathological condition, as I discussed earlier, H. pylori infection or gastritis, short bowel syndrome, or patient has underwent the bariatric surgery, or patient has the steatorrhea secondary to pancreatitis, chronic pancreatitis. So we have to rule out it is pseudo malabsorption. Pseudo malabsorption is nothing but the non-compliance with the therapy. So how to check that patient is non-compliant with the therapies? For this, one test is there, levothyroxine absorption test. We have to load the patient or give the 1000 microgram of levothyroxine early morning, and we have to take the sample 1 hourly. So first basal sample you have to take for the free T4, and 1 hourly we have to collect the sample. So any value that is going above twofold of the basal, it indicates that patient is non-compliant with the therapy. So here the basal value is 0.8 and it has increased to maximum 2.11. That is more than twofold rise was there. So it indicates that patient is non-compliant with the therapy. So case 6, 43-year-old male, history of upper respiratory tract infection, having the palpitation, heat intolerance and the tremors. On examination, tachycardia was present, goiter was absent, and these are the some of the thyroid function tests. We can make out the TSH on the lower side, elevated T4 and the T3 level. So what is your diagnosis? Anyone? So history of upper respiratory tract infection is there. So it is more likely subacute thyroiditis and not the Graves' disease. So for that I have advised the technetium scan, and here you can see the uptake on the thyroid is 0.2%. That is the decreased uptake in the thyroid gland with the technetium, indicating subacute thyroiditis. So in such patient we should not start with the neomercazole or carbimazole therapy, otherwise patient will be rendered hypothyroid. So it is subacute thyroiditis. The course of subacute thyroiditis is initial hyperthyroid phase followed by hypothyroidism, and there will be euthyroidism. So initial hyperthyroidism is due to the inflammation leading to release of the preform thyroid hormone from the thyroid gland, that leads to hyperthyroidism, and then there will be depletion of the thyroid stores that leads to hypothyroidism, and once the function of the thyroid gland is recovered, it will be euthyroidism. So in the Graves' disease there will be the persistent hyperthyroidism throughout the disease course. For the subacute thyroiditis, the typical features may last for the 2 months, and technetium 99 per technet scan is useful to differentiate between the subacute thyroiditis and the Graves' disease. So this is the technetium 99 scan. This is the normal uptake, that is 0.5 to 5%. This is the Graves' disease, that is increased uptake in the technetium scan, and this is the reduced uptake in the thyroiditis, that is less than 5%. For the multinodular goiter, we will get the patchy infiltration or the patchy uptake in the technetium scan. For the autonomous nodule or toxic adenoma, we will get the single adenoma with decreased uptake in the rest of the thyroid gland. So this is the utility of the technetium per technet scan for the diagnosis of the hyperthyroidism. So this is the case 7, 11-month-old baby presented with the history of neonatal jaundice, difficulty in breastfeeding, hoarse cry, macroglossia, that is large tongue was there, congenital hypothyroidism was there, TSH was 30, free T4 was 1, thyroid scan we have done, that was suggestive of the hypoplastic thyroid gland, that is suggestive of the hypoplasia of the thyroid gland. So this is the picture. We can make out that the baby has the large tongue, macroglossia, then the hypertaylorism was there and low set ears were there, and the mental retardation was present for the baby, and the limb, if you consider, it is short as compared to the trunk, that is suggestive of the congenital hypothyroidism. So mental retardation is the grave complication of the congenital hypothyroidism, so we have to treat the baby as earliest as possible. So this is a 22-year-old female with a severe short stature and the headache, blurring of the vision. On examination, bradycardia was present, dry skin was present, hoarse voice and the macroglossia was present, and no goiter. So what is diagnosis? It is likely congenital hypothyroidism that is undiagnosed. So what may be the cause of the headache and the blurring? So it is mainly the feedback adenoma that is seen. And for this patient, his TSH was more than 100, free T4 was very low, and the prolactin was elevated. So what may be the cause of increased prolactin? It is the compression of the pituitary stalk or the pituitary gland by the feedback adenoma. For this patient, we have done the MRI that was suggestive of the tumor in the cellular region. So it is nothing but the feedback adenoma. What happens with the hypothyroidism? There will be increased TRH level, and TRH will increase the TSH level, and that can lead to the thyrotrope adenoma in the pituitary gland, and this adenoma may cause the compression of the pituitary stalk and lead to the hyperprolactinemia in such patient, and we have to rule out the panhypopituitarism in such cases. So that is the importance. So this is the case 9, 56-year-old male. He was presented with the stroke, that is the cerebral bleed, and referred in view of hyponatremia and the unconsciousness, and this was the report of the CT brain that is suggestive of the cerebellar bleed. So patient was intubated in view of CO2 retention. So I got the call, patient was having the CO2 retention and the hyponatremia. So what will you suspect in such patient? So for this, we have advised the thyroid function test as the evaluation of the hyponatremia, and we have found that the T4 was 0.22 as compared to the low normal level of 0.93, that is suggestive of severe hypothyroidism, and TSH was almost 53. So for this patient, we have make the diagnosis. These are my notes, that myxedema coma is more likely. We can see here the sodium was 114. So I have loaded this patient with the 100 microgram 5 tablets of levothyroxine, that is 500 microgram of levothyroxine has been given to the patient on day 1. On second day, I have given 300 microgram of levothyroxine, and for the myxedema coma, we have to give the cortisol supplementation also. So patient has been treated as a myxedema coma, and after 2 days, the report we can see here, the T4 has been elevated to 0.74. And patient was extubated, he was off ventilation, and patient has been discharged, and he is following in the OPD. So that is the importance of diagnosing the myxedema coma. So with the myxedema coma treatment, we can have a low mortality rate. Otherwise the mortality rate in the myxedema coma is almost 30 to 50%. So this is the last case, 41-year-old male presented with the palpitation, excessive sweating, breathlessness, increased stool frequency, and the agitation. On examination, pulse rate was 160, suggestive of tachycardia, but the pulse was regular, not suggestive of the atrial fibrillation. And the goiter was present on examination. Thyroid associated orbitopathy was present, and patient had a bilateral basal crepitation indicating congestive cardiac failure. So what is the diagnosis? Anyone want to comment? So for this patient, we have done the ECG that was suggestive of the sinus tachycardia. Pulse rate almost 150 to 160, and these are the thyroid function tests. We can look at this. The TSH was suppressed, T4 elevated almost 3 times, and the free T3 has been elevated almost 7 times. So from this, we can make out that patient is having the thyroid storm. So for this, we have the Burch-Vostovsky score. We have to calculate the score to diagnose the thyroid storm. For our patient, we have calculated the score, and it was 50. If the score is more than 45, it suggests the thyroid storm. For this patient, I have started with the propylthiouracil. We have given the corticosteroid and the beta blockers, and Lasix has been given for the heart failure, and patient was saved and discharged. So that is the importance of the diagnosing the cases like myxedema coma or the patient having the thyroid storm, because the mortality rate is more in such cases if we don't get the diagnosis of these conditions. So from this take home message, whenever you advise thyroid function test, advise T4, T3 along with the TSH, and don't rely on the TSH only. And look at the pregnancy specific reference ranges. So we have to compare in the pregnant lady with the pregnancy specific ranges only, not with the normal individual. If the patient is requiring levothyroxine more than 1.9 microgram per kg, rule out the malabsorption or pseudo malabsorption, that is nothing but the non-compliance. And they rule out the thyroiditis before initiating a carbimazole in the Graves' disease. And the early diagnosis and treatment of the congenital hypothyroidism is important to prevent the mental retardation. And immediate treatment of the myxedema coma or the thyroid storm is important to reduce the mortality. So always remember that we are treating the patient and not the numbers. Thank you.
Thank you, Dr. Gaikwad, for this informative lecture and presenting so many cases. I request our chairperson to please felicitate our speaker, Dr. Prashant Gaikwad, with a memento on behalf of RMA Raicon 2026. I request our guest speaker to felicitate our chairpersons, Dr. Gajanan Chavan, Dr. Jayashree Deshmukh and Dr. Gajanan Chavan. दोन मिनिट थांबा सर. एक बाहेर एक इनोवा आहे, नंबर आहे 4142, डबल पार्किंग झालेलं आहे. प्लीज ती जरा काढायची आहे. तर अच्छा सरांचीच आहे का? ठीक आहे. आय रिक्वेस्ट आवर गेस्ट स्पीकर टू डू द ऑनर फॉर नेक्स्ट लकी ड्रॉ स्पॉन्सर्ड बाय H&H Pharma. डॉक्टर किसन मोहिते, किसन मोहिते. कॉन्ग्रॅच्युलेशन्स डॉक्टर किसन मोहिते. झालं संपलं. एकच आहे ना. I request Dr. Sajid sir to take the next lecture.
Thank you, sir. Thank you everyone. Now it's time for our last lecture of this Raicon 2026. The session is going to be delivered by our guest speaker, Dr. Vivek Sukumar. I request Dr. Sachin Pawar sir and Dr. Amit Oswal to please accompany our guest speaker to the dais. And the topic is pushing limits of surgical oncology. Now I request Dr. Sachin Pawar sir to please welcome our guest speaker, Dr. Sukumar sir. Dr. Vivek Sukumar sir is a highly skilled surgical oncologist, specialization in gynecological and gastrointestinal cancers with deep expertise in extended pelvic resections, cytoreductive surgeries and minimally invasive oncology. He has participated in major international trials such as Torpedo and Presin NT, and recently presented his innovative extraperitoneal cytoreduction technique at PSOGI 2025. With over 500 cytoreductive surgeries and 30 plus publications, he continues to advance evidence-based care. Dr. Sukumar currently leads surgical oncology service at SSO Cancer Hospital in Navi Mumbai and Mumbai, where he has managed complex oncologic cases, drives multidisciplinary care pathways, and contributes to surgical innovation and clinical research. He is also actively exploring AI-driven decision support to improve precision, safety, and outcome in cancer surgery. I request sir to continue his lecture.
Yeah. Yeah, thank you, Raigad Medical Association for inviting me to Raicon. So today the presentation is going to be what's new in surgical oncology, how we are pushing the limits, and how we are using technology to push our surgical outcomes of our patients. So we're going to discuss three main points: what's new, what can we offer in our setting, and the innovation, application, and impact we are having with what we have developed in India and technology we have developed in India. So what's new in our setting? I'll be discussing three main topics. First, the role of fluorescence. We use special fluorescence for our surgeries right now. We use AI to reconstruct liver models to do surgery, and also we have developed technology which can add life or years to the life of patients who have unresectable tumors. So we'll start with that. We'll start from the palliative setting where we think surgery does not have a role. But you see, the problem is in India, 20% of malignancies are in stage 4. So the most significant drop in quality of life happens when there is peritoneal metastasis, when the disease goes into the peritoneum or abdominal cavity. And the treatment options are limited. So only option is either you continue chemo, which patient may not be able to continue more than 2 or 3 cycles because it's extensive disease. So we had this technology which was developed in Germany, but it used to cost 3 lakhs per session, and one patient requires one session at least every 2 to 3 weeks initially before you can start treatment. So when we asked this to the company, they said we didn't design the equipment for India. So we decided to develop our own technology, and we have developed our own technology to bring equity. Same cost of 3 lakhs per session, now we are giving it at around 20,000. And this is the technology I'm talking about, PIPEC, where we give the particulated chemotherapy inside the abdomen so that the ascites and the peritoneal deposits come down, and we help the medical oncologists give chemotherapy. Sometimes the patient is in such a bad state that they are not able to take chemotherapy at all. So this helps in initiating, and also in palliative setting. Having a large abdomen with 3 to 4 liters of malignant fluid is very difficult. Quality of life comes down drastically, and this helps improve it. So it's a small video. This equipment has been solely developed by us with our engineers. It's produced in our factory in Rabale, and we have done more than 270 cases, and so many medical oncologists send patients upfront so that we can help them out. So like I said, quality of life is very poor once you have metastasis which is there. And I'll just go quickly through the video. Yeah, so this is the equipment. We have a wand, which is an equipment which delivers the nano aerosol chemotherapy, and we have a nano system which converts the fluid into nanoparticles so that penetration is very high inside the abdomen. So we did all experiments from zero. We collaborated with AIIMS Delhi to use the transfocal and microscopy to evaluate particle size. We worked with Indian Institute of Science for confocal microscopy and multiple other scientific organizations to ensure that the equipment is working well. And these are some pictures of those experiments that we have done. So the whole idea is we have disease which is very aggressive, and it's very extensive. You can see the patient has already undergone surgery. So the first port is generally put on the lateral aspect so that we don't have any injury. Then we go under vision, after which the other ports are put in, and then we do a staging laparoscopy.
So in this particular case, you can see how bad the disease is inside. Now this is not an operable case, most likely will never be operable, but this patient never went for chemotherapy, and chemotherapy could not be started because the ascites was so bad that the medical oncologist was not able to start chemotherapy. So in these patients, PIPEC definitely has a role, because we suck out all the ascites, we give a good wash, we see the amount of disease and we score it by a scoring called as PCI. And once the scoring is done, we try to remove all the jelly like material which is there using our suction. And once that is done, we prepare the nano wand. So this technology, what it does is, this machine, it converts the liquid chemotherapy into nanoparticles, and as the fluid goes through the wand, the nanoparticles disperse all along the abdominal cavity. So once I go in, the chemo drug is start, the aerosolization process starts, and I'll just show you a little later on how it works. Yeah, so this is, you can see, this is how it works. So the chemotherapy gets sprayed locally. Now why do we need to do this in peritoneal metastasis? Because the availability of chemotherapy when we give IV is less than 1% when it reaches the peritoneum, because vascularity is very poor. So when we do this special kind of chemo into the abdomen, the amount of ascites comes down drastically, and patient's quality of life improves, appetite improves, and the tolerance to chemotherapy improves. So we have done around 278 patients, of which around 40% were given upfront so that they can go in for chemotherapy, and there are about 10 to 15 patients who have gone from this stage to operable stage. And these patients required to be admitted only for 2 days, and the cost from 3 lakhs per session has come down to around 25 to 30,000 because of this innovation. So there are intraperitoneal chemotherapy, there are different ways in which we can give surgically. One is NIPEC. NIPEC is when we give chemotherapy through a port, but you have problems of infections and problems that the port is causing inside the abdomen. Then we have two, PIPEC, which I have just shown, and HIPEC. HIPEC is only done when we complete cytoreduction, when we can remove all the disease in the abdomen, and then we give hot chemotherapy for 90 minutes. This is an integral part of treatment of ovarian cancer, somewhat in colon cancer, gastric cancer, and primary peritoneal disease like mesothelioma and PMP. So this is the setup where you have an open abdomen and you have two pumps which go inside, which give chemotherapy for 90 minutes. We have done 1500 HIPECs, just completed the number last month, and we have one of the highest numbers in the world. So we are members of the World Peritoneal Surface Oncology Organization and also the Indian Peritoneal Surface Organization. These are two videos just showing the extent of disease and the extent of resection we might need to do. So this is a little more cleaner. This is a CA ovary responded well to chemo. You can see the diaphragms have been, the peritoneum is completely removed. The liver peritoneum is completely removed. There is no omentum, and other organs are okay. But this patient had a primary peritoneal carcinoma, which is a PMP. So the whole colon had to be removed, the rectum is removed, this is a small intestine, the stomach is there, and the Glisonian capsule of the liver is also removed along with the whole of the peritoneum. Now in these primary peritoneal disease, unless this surgery is done to what we call CC0, means the surgeon cannot see any disease, they will recur. So being aggressively, you have to do aggressive surgery and remove all the disease, and surgery goes on for about 8 to 10 hours, after which we give this intraoperative chemotherapy. So once this is done, then we give the HIPEC. So this is what we were talking about, that we got to present a new laparoscopic approach on how we can do this whole surgery laparoscopically. We presented it I presented it in Barcelona last year as one of the selected videos to present over there, along with my colleague Mufaddal and Dr. Sanket. And it's the same thing we do, but we do it completely laparoscopically. We go in the between the intraperitoneal and retroperitoneal plane, and the peritoneum should not be breached. So that is the whole game. We come to the extraperitoneal space like you do a totally extraperitoneal approach in hernia surgery. But the problem is, in this case, the peritoneum is diseased. So it becomes challenging to get that plane. So you could see what a big incision we had to do when we do open surgery. But when we do laparoscopic surgery in selected patients, we cannot do in patients who have a lot of disease. This is with a PCI score of less than 10. you can see that all the major structures can be defined. The ureters all are seen retroperitoneally, and we go to the opposite side. So once we complete this dissection, this is the gerota we are pushing down, and we are reaching the opposite side of the peritoneum. So the whole of the peritoneum, DG flexure, all of the peritoneum is resected laparoscopically. And once that is done, we do the diaphragm as well. The diaphragm also comes out, the diaphragmatic peritoneum also is completely excised, and we complete the dissection that we did as in open surgery via the laparoscopic approach. Now, this should only be done in an experienced center which does liver laparoscopically and also colon and the stomach surgeries laparoscopically, because there is a tendency to leave behind disease. If we leave behind disease, the whole procedure is futile, because even if you leave a tumor which is more than 1 centimeter or in the abdomen, it results in recurrence. So you can see the diaphragm is completely cleared of peritoneum, the spleen is bare, the omentum is out, we remove the omentum also, and then we put, these are the tubes through which hypec goes in laparoscopically. So chemotherapy, hot chemotherapy at 41 degrees will go into the abdomen for 90 minutes. Now, you could see a big incision that we used, and when we do it laparoscopically, we can do only this. So this is a trial which I am a part of. So we can also do it with an open method, where we open a little bit of the abdomen and put this retractor, the Thomson retractor, and then we put the tubes in. So that is about peritoneal disease. So what is the other technologies in other organs? If you have extensive metastasis in both lobes of the liver and chemotherapy options are exhausted, one of the things that we use is the Fujifilm Synapse 3D, with which we reconstruct the whole liver. We construct the biliary anatomy, the arterial anatomy, portal anatomy, as well as venous anatomy, and we overlay each of the liver parenchyma over these structures. So we are able to detect where the tumor is at what location. So when you have disease on both sides of the liver, we do something called as parenchymal sparing liver surgery, not conventional right and left. Because this is metastatic disease, we need to get all of this with a margin. The software gives us amount of liver that will be preserved after the surgery and whether the liver will survive, because the most important complication or dreaded complication after liver surgery is post hepatectomy failure. So this is how it is. You see extensive diseases there on the right lobe, some scattered disease on the left lobe. So can we do this surgically? So this is just a case presentation. I'll just quickly go through the video once again. We had a 51-year-old male, a top executive of an IT firm, sigmoid. He had a sigmoid colectomy done, but had multiple liver mets, 6 cycles of false Fox, 6 cycles of false Fury. Medical oncologist said we can't give anything more. So then he said, can you refer that, can we go ahead with this parenchymal sparing surgery? And what we do in parenchymal sparing surgery is we first take a good CT scan. And we see the triphasic CT, you can see there's extensive disease involving all lobes of the liver, almost all segments. So we use our software and we make a plan. We mobilize the liver completely. Intraop ultrasound is done and we localize all lesions which are there on the ultrasound. And once that localization is done, we clamp the vessels so that there is no bleeding when we operate. And each of these tumors are removed with adequate margin. So the end result is you each time repeat the ultrasound, each time you remove each metastasis or the area which is maximally involved. So you can see here we removed segment 2 and now we will start with the segment 6, segment 7, segment 8, and we are going through the liver and ensuring that all disease is gone, is coming with the specimen out. So you can see individual segments we are identifying, clipping and cutting. So this, we require a lot of help from the anesthesiologist as well, because the BP tends to fluctuate when we clamp the liver and not. In between we pack the liver, we give some time for the liver to get reperfused, and then we check if our plane of dissection is correct. So we complete all the dissection. You can see that segment 7 is completely dissected, segment 8 is completely dissected, and finally we take a cut and we keep it on the pedicle, after which we just staple it out. So once we staple it, almost, see this is the last pedicle, the pedicle of segment 8, and it is completely excised. Now it's lying only on the right hepatic vein, and it's completely excised. So these patients would generally be palliative with no treatment option if we don't do this surgery. There are no other options that are left for this patient. Now this patient was done around 2 years ago, 2022, 3 years ago, and he's absolutely fine. The liver has regenerated. You can see that the liver has been preserved as per the preoperative planning, and almost all of this liver has regenerated over time. So this is what we do with the 3D Raicon. Now what we do with fluorescence. Now this is a very important tool that has come in hepatobiliary surgery. We give ICG dye which is metabolized in the plasma, liver, bile as well as feces. So what happens is, depending on the mode at which you capture the ICG, you can use it for visualizing the tumor in the liver, visualizing the biliary anatomy, also visualizing vascularity of organs. So when it is in the plasma, you can check for hepatic perfusion. So this is a robotic arm you can see. You can see that you have clamped the hepatic vessels. So this side does not have the perfusion and this side has. So your line of resection is going to be this, if it's in the liver. Next is cholangiography. Many Western countries it is compulsory. If you're doing a lap chole, you have to use ICG because it shows the bile duct anatomy really well, and most of the modern laparoscopic stacks come with this inbuilt in them. So that is when you use bile. And you can also use to localize the tumors pre-operatively, so you are ensuring that everything comes out during the surgery. So few videos I'll just show. This is what I use for positive staining. When you have only one tumor, you can see over here, there is a tumor, it is only in segment 6. I have put laparoscopic ultrasound. I can see the portal vein which is going into that particular area. I have introduced a needle and injected into that portal vein. So I can see exactly where segment 6 is. I don't need to remove all of the normal liver. So I have removed segment 6 and the patient is fine after 5 years also now. This is our robotic system that we have, which we use to do these complex procedures. This is a case of robotic esophagectomy we have done. I have created the conduit with the stomach. So we have made a new esophagus with the stomach. Now most dreaded complication is esophageal leak, which happens because of vascularity. I have injected the ICG. Now the ICG camera is showing that vascularity is good. But to the naked eye, the tip looks normal. But ICG is showing delayed perfusion. Means there is a risk of necrosis. So if I anastomose this with the neck esophagus, there is bound to be a leak or higher chance of leak. The fluorescence of this part is much more than the tip. So I have to revise the conduit. So this is what helps us. We can also see the proximal segment. The proximal segment will be over here. Yeah, this. So we can also see how the vascularity is in the proximal segment, so that anastomosis does not give us trouble. And we have done around 97 esophagectomies using this technique. There has been no leaks when we have used an ICG. So it is something that we use routinely in all our esophagectomies now. What about in laparoscopic right hemicolectomy? We do a 5 centimeter incision, after which the whole of the large intestine comes out with the big amount of disease and omentum. We ensure that the vascularity is good in both sides, because we take a lot of effort to make sure we do it minimally invasively and good way. Poor vascularity should not be a cause for re-exploration. So we ensure that the vascularity is good, and we do an anastomosis after we ensure the vascularity. Same thing for rectum. We check the rectal conduit, how the rectal conduit is and how healthy it is before we do an anastomosis, because vascularity is challenging in the lower end of the pelvis. So we once again inject ICG and we check for vascularity. This is only to ensure that we are not missing out on anything. And here you can see the cutoff. Beyond this, there is no blood supply, because we have taken the blood supply at the origin with all the lymph nodes, so that there is the least chance of recurrence. So even advanced reconstruction is the fifth topic I'm going to deal with. So we do advanced reconstruction for vessels also as well, because sometimes that remains the last option. We had a 24-year-old boy with an advanced retroperitoneal sarcoma,
completed multiple lines of chemotherapy. There was involvement of the inferior vena cava, there was involvement of the aorta, declined surgery at multiple places in major centers. So as a last option, they came to us, and we went ahead with aorta and IVC resection. And this boy who's 24 is now around 28, and he is doing fine. So the response to chemotherapy, when it's good and when we can do surgery, I think it is the most important thing that we should do, because what I believe is surgeon is one of the most important prognostic factors. Because one of the famous sayings that Dr. Paul Sugarbaker, who's a father of peritoneal surface, says is, what the surgeon does not see kills the patient. If the surgeon misses the disease, the patient is going to die because of that missed disease. So surgeon is one of the most important prognostic factors, and I have presented all this technology because it is available in our setups, and it can be provided at very affordable prices at around half or 40% of what major corporates are providing outside. So this is an initiative by doctors, all our surgical oncologists, around 14 of us, so that we are able to provide this quality care outside the setup, so it becomes more affordable to most of our population. Thank you.
Thank you, sir, for such an informative session. Now I request Chairperson Dr. Sachin Pawar, sir, and Dr. Amit Oswal to please felicitate our guest speaker, Dr. Sukumar, sir. Now I request our guest speaker to please felicitate our chairpersons, Dr. Sachin Pawar, sir, and Dr. Amit Oswal. Thank you, everyone. I thank each and everyone for your presence, patience to make this conference a grand success. We have come to an end of this Raicon 2026. Before we proceed for our valedictory function, we have a bumper prize that is sponsored by ICTC Hospital. So that bumper prize will be announced after the valedictory function. Yeah. So I hand over the valedictory function session to my colleague Dr. Anirudh Joshi.
अध्यक्ष असं करायचं का? चलो, thank you. Probably we had a good RMA session. मी एक दुरुस्ती सुचवतोय, RMA प्रेसिडेंट जर परवानगी देत असतील तर आपण व्हॅलिडेटरी फंक्शन न म्हणता, म्हणजे व्हॅलिडेटरी फंक्शन आहेच आहे, पण सिन्स RMA प्रेसिडेंट वॉन्ट्स टू ॲप्रिशिएट दोज हू हॅव कॉन्ट्रीब्युटेड डायरेक्टली, तर आपण त्या फंक्शनला रेव्हरन्स ऑफ व्हॅलिडेटरी सेक्शन असं नाव देऊया. तर डू यू परमिट मी टू डू दॅट? तर लेट अस स्टार्ट. रिस्पेक्टेड आदरपूर्वक सन्मान ह्या शेवटच्या निरोप समारंभाचा. रिस्पेक्टेड गेस्ट Dr. Sukumar sir, distinguished my senior colleagues, delegates, organizers and dear colleagues, a very good evening to one and all. As we come to the validation session of this RMA conference, Raicon, we stand at the conclusion of a truly enriching and meaningful academic journey. Over the course of this conference, we have witnessed insightful deliberations, knowledge sharing and thoughtful discussions that reflects the dedication and commitment of our medical fraternity towards excellence in healthcare. This conference has not only strengthened our professional skills, but has also reinforced the values of compassion, ethics and service that define the noble profession of medicine. It has provided a valuable platform for collaborations, innovations and reflection on the changes and opportunities in the today's healthcare system. The valedictory function, a reverence one, is a moment to acknowledge the collective efforts of the organizers, the speakers, the participants who made this conference a success, and to carry forward the ideas and the inspirations gained here into our daily practice for the benefit of the society. With the spirit of gratitude and fulfillment, let us now proceed with the permission of our President for the valediction. Thank you. I now call upon our President, Dr. Ashutosh Kulkarni, Secretary, Dr. Prashant Gangal, Treasurer, Dr. Kumar Oswal, to do the honors. President would like to name first our Chief Advisor, IMA President, Dr. Jain Sir. Jain Sir, please come forward. Sir, a profoundly honored dignitary of KMA, member of RMA, for his sagacious guidance and invaluable counsel, which has continually strengthened the association's vision and initiatives. His wisdom has been instrumental in nurturing growth and cohesion among members. Sir was the initiator and promised our President that he will look upon the management of this particular venue, and which he did at his best. So let us clap for that. Chief Advisor of RMA. Another Polaris, Dr. Hemant Gangulia sir. सब गेले? पण एकदा सरांचं रेफरन्स वाचूया. Scientific Committee Chairman, we gratefully recognize the Scientific Chairman of RMA for his strategic leadership in framing the scientific agenda and handling the MMC affairs. His scholarly guidance has ensured the program's rigor, relevance and seamless education. डॉक्टर राजेंद्र चांदोडकर. चांदोडकर सर आहेत? वाचू? स्किप करू डायरेक्ट. डॉक्टर आदित्य मामणकर, डॉक्टर राजेश सकपाळ, डॉक्टर आदित्य जंगम, जॉइंट सेक्रेटरी ऑफ RMA, we acknowledge the Joint Secretary's helpful nature, humble attitude and calm demeanor, which has been a source of strength and support to all the members. Dr. Sachin Pawar. Joint Secretary of RMA. We appreciate the Joint Secretary of RMA for his untiring efforts in resource mobilization. His dedication has significantly empowered the association's initiatives and strengthened its capacity. Dr. Ganesh Mengal. Joint Treasurer of RMA, we acknowledge his corroborative attitude and sincere service to the association, which has been valuable for the team and its activities. Dr. Lakshman Avte, Dr. Dilip Savde, Editor. Our editor has consistently demonstrated creativity and originality in all his endeavors. His work has added immense value for the association's outreach and documentation. डॉक्टर शीतल कराळे एक मॅडमचं आपण नंतर हे करूयात कारण त्यांच्याकडे ड्युअल रिस्पॉन्सिबिलिटी होती. शीतल कराळे जॉईंट एडिटर पण होत्या आणि शीतल कराळे MOCच्या कमिटीच्या मेंबर पण होत्या. पण त्यांचं जॉईंट एडिटर म्हणून थोडं विशेषण वाचूया. वी अॅक्नॉलेज द जॉईंट एडिटर्स व्हॅल्युएबल सपोर्ट अँड कोलॅबरेशन विथ द एडिटर. टुगेदर देअर एफर्ट्स हॅव स्ट्रेंथन द असोसिएशन्स communication and creative output. Thank you, madam. Dr. Ganesh Salunke. Chief Organizing Chairman of the RMA. He has shown remarkable zeal and his commitment in raising funds for the association. His dedication has been instrumental in achieving our goals. Dr. Shripal Jain, 2 minutes वाजू नका. Organizing Chairman of RMA, we acknowledge the Organizing Chairman's dynamic spirit and tireless efforts in mobilizing resources for the association, which has made a significant impact on the success of our activities. Dr. Gajanan Chavan, Organizing Chairman of RMA, we gratefully recognize Sir for his exemplary leadership and meticulous supervision of the food committee. His thoughtful planning has ensured the comfort and well-being of all the participants and thus enhancing the value of the event. Dr. Amit Oswal, Organizing Chairman of RMA. We acknowledge the Organizing Chairman of RMA for his role in coordinating the efforts, events and supporting the committee. Dr. Bhavesh Oswal, Chief Organizing Secretary of RMA. We respectfully commend the Chief Organizing Secretary who has helped the Secretary in organizing the events, ensuring association's initiative. Dr. Sangeeta Gangolia, Dr. Mahesh Shirshat, Organizing Secretary of RMA. We recognize for being part of the organizing team. His involvement has contributed to the overall spirit and smooth conduct of the program. Dr. Ashish Karve, KMA President. We respectfully honor the President of KMA for his distinguished leadership and support in advancing local medical initiative. And Ashish was instrumental at the registration counter along with Pratik. आशिषने हे पाहिलं की एकही फेक रजिस्ट्रेशन झालं नाही, कोणाला येऊन दिलं नाही आणि होऊन देणार नाही. डॉक्टर मिलिंद सोनावळे, डॉक्टर कुलदीप इंगोळे, कुलदीप इंगोळे नाही आहेत, ऑर्गनायझिंग ट्रेजरर ना, सेक्रेटरी. डॉक्टर निलेश म्हात्रे, Sports Secretary of RMA. We extend our sincere gratitude to Dr. Nilesh, whose dedication as Sports Secretary and meticulous organization ensured the smooth conduct of all the events, fostering teamwork and discipline. Dr. Sanjeev Patil, Joint Sports Secretary. We respectfully commend the Joint Sports Secretary of RMA for his vigorous efforts in organizing men's cricket and indoor games. His initiative and perseverance has greatly enriched the sports activity of RMA. Dr. Kisan Mohite, Sports Committee member. We sincerely acknowledge the Sports Committee member of RMA for his enthusiastic participation and diligent support in organizing the events. Dr. Vikas Gomare, Sports Committee member. We recommend him for his wholehearted participation and coordination with the committee members to run the sports activity smoothly. Dr. Jayashree Deshmukh, Women's Sports Secretary. We respectfully exalt the Women's Sports Secretary for a remarkable initiative and steadfast guidance in promoting women's cricket among the doctors. Her vision and perseverance has enriched the sporting culture and encouraged active engagement of the ladies team in the fraternity. Dr. Bhagwan Karale, Sports Committee member. We honor the Sports Committee member for his energetic engagement and consistent support in all the event organizations. Sir is NIMA's Vice President. Dr. Supriya Mahontkar, Cultural Secretary of RMA. RMA honors her for her dedicated planning, tireless work in bringing the RMA event what you saw yesterday. Her creativity, commitment have greatly enhanced the cultural vibrancy of the association. Dr. Varsha More. Actively helped in organizing the Mrs. RMA event which was conducted yesterday. Her efforts and coordination continued significantly to the smooth and successful execution of the program. Dr. Ritesh Jain and Dr. Rahul Patil, Food Committee member of RMA. We honor the Food Committee member of RMA for their effort and seamless coordination in handling all food-related arrangements. Their contribution has played a vital role in the success and enjoyment of the gathering. Dr. Sanjay Bhamere, Dr. Geetanjali Rao Hazare. Sports Activity Committee. We respectfully commend the Sports Activity Committee members for their social activities, for organizing impactful social and medical outreach programs. Their efforts have enriched the association's mission of community service and public health advocacy. Nagesh Chitte, a special appreciation. We gratefully commend Dr. Nagesh for his tireless involvement and willing support in every facet of the RMS program. His sincere commitment has enriched both the spirit and success of the association. नागेशचं महत्त्वाचं काय की त्याच्याकडे कुठला पोर्टफोलिओ नव्हता, पण पोर्टफोलिओ नाही म्हणून काम करायचं नाही या भावनेने तो कधीच राहिला नाही. त्यांनी स्वतःहून समर्पित भावाने काम केलं. Dr. Rahul Oswal, special appreciation. Dr. Nilesh Sawan and Dr. Abhijit Bhosle. We solemnly recognize Dr. Bhosle for his energetic engagement and remarkable support in the DPL of RMA. Dr. Prashant.
One of the most important committee, Master of Ceremony for the event. We gratefully recognize the Masters of the Ceremony here at the right hand. Masters of the Ceremony of Raigad Medical Association for their dedicated effort in managing the event with finesse. Their confident presentation, seamless transitions and engaging composure ensured the program was conducted with utmost grace. Their performance was greatly enriched the ceremonial and professional spirit of the gathering. Thank you. I will name Dr. Aniruddha Joshi sir, Dr. Sharwani Kulkarni madam, Dr. Sajid Adhikari sir, Dr. Manish Parmar sir, Dr. Kamini Masul Madam, Dr. Amruta Patil Ma'am, Dr. Kunal Rathod Ma'am, and Dr. Sheetal Ma'am.
Special appreciation, Dr. Pratik Kamri. हा एक असा स्वयंसेवक आहे जो स्वतःहून काल आशिष बरोबरती रजिस्ट्रेशन काउंटरला उभा होता, मारामारीची पण तयारी होती.
अजून एक स्पेशल अप्रिसिएशन आपण करूया, वुड बी डॉक्टर आर्यन जोशी. गेले तो 2 दिवस बॅकस्टेजची सगळी कामं करतोय.
नागेश आला, ये व्हेरी गुड, ये नागेश शित्ते, आरएमएचा खरा स्वयंसेवक. आणि इव्हेंटमधलं स्पेशल रेकग्निशन, स्पेशल ॲप्रिसिएशन जे इव्हेंट्समधलं शेवटचं आहे, डॉक्टर नितीन भोपतराव. त्यांच्या प्रेझेन्समुळे सगळे खेळाडू बरोबर खेळले. आरएमएची कॉन्फरन्स, आम्ही केएमएच्याही कॉन्फरन्स पाहिल्या, खर्च वाढत चाललेत. आता पसारा कसा सांभाळायचा? जैन सर पाठीशी आहेत, अनेक लोक पाठीशी होती, पण पसाऱ्याचं व्यवस्थापनाचे जे काम आहे, जे आपले ट्रेजरर आहेत डॉक्टर कुमार ओसवाल, वी रिस्पेक्टफुली रेकग्नाइज द डिस्ट्रिक्ट ट्रेजरर ऑफ आरएमए for his judicious planning and accountable oversight, which ensures the smooth execution of the association's endeavors. His transparency and financial diligence with prudent management has ensured the financial strength and stability of the association. A big clap to Dr. Kumar. कदाचित आपण आज जाऊन आपापल्या घरी झोपू, पण ट्रेझरर, सेक्रेटरी आणि अध्यक्षाला हिसाब किताब होत नाही तर झोप लागणार नाही. तर त्यासाठी एकदा जोरदार टाळ्या देऊया. लवकरात लवकर हिसाब किताब करा आणि चांगले श्रमपरिहारासाठी आमच्याकडे या. टीमचे बॅकबोन. सगळ्या घटना घडत असतात, घडून घ्याव्या लागतात. एक स्ट्रेंथ असते, एक फोर्स असतं. तो फोर्स कदाचित प्रशांत आहे, डॉक्टर प्रशांत गांगल. वी रिस्पेक्टफुली एक्नॉलेज आवर सेक्रेटरी फॉर हिज diligent coordination which forms the backbone of the association's functioning. His devoted services ensures continuity, coherence and integrity across all the initiatives.
जनरली प्रेसिडेंट, सेक्रेटरी, ट्रेजरर तिघंजणं खूप काम करतात. म्हणजे आम्ही केलं आहे असं म्हणून नाही, जनरली करतात. पण आमच्याकडे एक चौथा पिलर पण आहे ज्यांनी आमच्याबरोबर वर्षभर खूप काम केलं. तो इथे मागे बसलेला आहे, डॉक्टर दिलीप सावळे. प्लीज एक फोटोसाठी पुढे या.
दिस इज न्यूज NEWS. हे चौघजणं नॉर्थ ईस्ट वेस्ट साऊथ एकत्र आले आणि RMA कॉन्फरन्स खूप छान फील झाली. आता आम्ही RMAच्या प्रेसिडेंटचा सत्कार करतो. तर मी आपल्या स्टिअरिंग कमिटीचे मेंबर डॉक्टर डहाके सर, डॉक्टर काळे सर, डॉक्टर लाड सर यांना विनंती करतो की त्यांनी व्यासपीठावर यावं. President RMA, we bow in respect and acknowledge the esteemed District President of the RMA, whose visionary stewardship and noble service continue to uphold the highest deals. His leadership remains a guiding force for unity, learning and excellence.
एक छोटीशी गोष्ट सगळ्यांना सांगायची आहे आणि सगळ्यांनी माझ्याबरोबर बोलायची आहे. RMA आपण सगळे पहिलेपासून RMA करतो आहे आणि एकापेक्षा एक त्याच्यात एक छान आपल्याला काही ना काहीतरी मिळतं, एक आनंद घेऊन आपण घरी जातो. आज जी झालेली कार्यक्रम, मुख्य अध्यक्ष असतोच पण त्याच्याबरोबर जी सगळे लोक असतात ज्यांना आता आपण आज बघितलं, त्यांच्यासाठी एकच गोष्ट आपण सगळ्यांनी एकच बरायती. 3 cheers for हिप हिप हुर्रे, हिप हिप हुर्रे, हिप हिप हुर्रे. थँक्यू व्हेरी मच.
सर्वप्रथम मला एक सांगायचं की आपल्याला ज्यावेळेला आशुतोषची नियुक्ती व्हायची होती, डॉक्टर गांगुलिया यांनी चांगला जोर लावला आणि त्याच वेळेला आशुतोषने पण जिद्द केली, मी प्रेसिडेंट होणार आणि मी ते सक्सेस करून दाखवणार. पण ज्यावेळेला त्याने हे धनुष्य उचललं, शिवधनुष्य उचललं, थोडंसं असं वाटत होतं एवढा मोठं त्यानं आता हॉटेल बुक करणंपासून तर एवढं RMAचं काम करणं इतकी साधी गोष्ट नाही आहे. पण तो मनात त्यावेळेला खचत धरला होता. परंतु ह्या सर्व टीमने जी त्याला मदत केली, त्याला जे सहकार्य केलं, खरोखर कौतुकास्पद आहे. आणि मध्ये आपल्या स्पीकरने पण सांगितलं की आपण वर्गामध्ये सुद्धा कुठल्या लेक्चरला लक्ष देऊन ऐकलं नसेल, पण आज सर्व जे आपले डेलिगेट्स आहेत सातत्याने ते लेक्चर्स सगळे आणि A to Z लेक्चर्स ऐकले. जेवणाची तमा केली नाही, जेवणाची सुट्टी घेतली नाही, पण मध्ये कुठेतरी जाऊन जेवून आले आणि परत इथं येऊन बसले. म्हणून सर्व डेलिगेट्सचं मी कौतुक करतो. सगळ्यात जास्त कौतुक करावं असं वाटतं प्रशांत मगाशीच बोलून गेला, MOC. जर MOC बरोबर नसेल तर आपलं हे कार्य सक्सेस होत नाही. पण त्याने अतिशय उत्कृष्टपणे कार्य केलं, म्हणून मी तुमच्या सगळ्यांचं खूप खूप अभिनंदन करतो. आणि आपल्या सर्वांनी आशुतोषला सहकार्य करून त्याने अतिशय उत्कृष्ट अशी ही आपली जे करून दाखवलं, त्याने आपलं कार्य करून दाखवलं. खरोखर मी मनापासून आशुतोष कुमार, प्रशांत गांगल आणि त्यांच्या सर्व टीमचं मी पुन्हा पुन्हा कौतुक करतो. आणि ही आपले आयुष्यभर आपण लक्षात ठेवू अशी ही कॉन्फरन्स झाली, म्हणून धन्यवाद. जय हिंद, जय भारत.
डॉक्टर जैन सर.
थँक यू व्हेरी मच फॉर युअर काइंड परमिशन्स. मित्रांनो, 30 वर्षापूर्वी KM एस्टॅब्लिश झाली, जन्म झाला, आज ती मॅच्युरिटी झाली पूर्ण त्याची. आणि मला खरोखर आनंद वाटतो, कारण मला प्रॉब्लेम कसा होता की जेव्हा आशुतोष म्हटला की सर मी प्रेसिडेंट होतोय, आणि ही वॉज ए नॉन ॲलोपॅथिक, इट वॉज अ व्हेरी डिफिकल्ट टास्क. कारण आशुतोष मला सर मी कुठलीच कंपनीला माझ्याकडे येत नाही, MR लोक मला विचारत नाही आहे. म्हटलं तू बरोबर काळजी करू नकोस, यू पुट माय नेम. मी याला म्हटलं यू पुट माय नेम, डोंट वरी. आणि मी प्रत्येक कंपनीला एकच ॲपील केली, व्हॅन्यू कंपनीला ॲपील केली, आय हॅव कम्प्लिटेड माय 70 years, 70 वर्ष झाले आता गेल्या महिन्यात मला. आणि म्हटलं पुढची कॉन्फरन्स मला माहीत नाही की बघेल का नाही बघेल, पण धिस कॉन्फरन्स इज युअर्स. आणि प्रत्येक कंपनी 80% कंपनीला मी पर्सनल टेलिफोन केले. भले तुम्ही कन्व्हिन्स केलं, पण त्याला शेवटला फोन मला करावा लागला की नाही यावेळेला तुम्हाला पैसे द्यावे लागतील कॉन्फरन्ससाठी, कारण फंड इज व्हेरी इम्पॉर्टंट. आदूषोना म्हटलं तू हे समजू नको की मी BMS आहे आणि मला हे लोक हेल्प करते का नाही. म्हटलं यू डोंट वरी म्हटलो. कारण काय माहिती आहे का, मला माहिती आहे कंपनीवाले थोडेसे वेगळे टाईपची वागतात कधी कधी. सर आम्हाला त्यांना भेटत नाही, ते काय आमचे प्रॉडक्ट लिहित नाही. मग ते लिहित नाही पण आम्ही लिहितो त्याचं काय म्हटलो. आणि अल्टिमेटली वी कन्व्हिन्स देम. असं झालं म्हणून तू बिंदास हो, तू बिंदास घे कॉन्फरन्स. म्हटलो विल मेक इट अप टू डेट. कारण मला माहिती आहे आय वॉन्टेड टू सी कॉन्फरन्स बिकॉज प्रोबेबली 70+ म्हटल्यानंतर आम्ही पुढचं काय माहीत नाही आम्हाला, पण ही कॉन्फरन्स मला चांगली बघायची होती. आणि मी 3 दिवसापूर्वी गुजरातला होता, म्हणून काळजी करू नकोस, मी गुजरातवरून येतोय, आय एम इमर्जन्सीमध्ये मी बाहेर आलेलो आहे, पण कंटिन्यू द वर्क. फंड म्हणा, स्पीकर्स म्हणा, कंपनीचे म्हणा, इवन स्पीकर काय सायंटिफिक कॉन्फरन्स यांनी जेव्हा मला दाखवलं की सर ही सायंटिफिक, म्हटलं गो हेड म्हटलं, तुम्ही किरकोळ कामं करत जा म्हटलो. फंड रेजिंग, सायंटिफिक कमिटी, व्हॅन्यू, डोंट वरी म्हटलो. कारण हे तुमचं जे काम आहे ते मला काय करायचं नव्हतं, बिकॉज यू आर ऑल एक्सपर्ट इन दॅट वे. मी नाही आहे त्याचे एक्सपर्ट काय, बरोबर आहे का नाही. तर आज मला खरोखर आनंद झाला आहे की ही कॉन्फरन्स खूप चांगली सक्सेस झाली. लेट मी टेल यू, RMAमध्ये पीपल विल रिमेंबर दिस इज वन ऑफ द व्हेरी गुड कॉन्फरन्स. मला लोकांनी रिमार्क केला की सर एवढं सुपर व्हॅन्यू आणि वेल ऑर्गनाईज होतं की मला चांदोरकर म्हटला स्वतः, म्हटलं सर मी अशी कॉन्फरन्स बघितलेली नाही RMAची आणि रिअली आय एम हॅपी. मला खूप आनंद वाटला की कर्जत मेडिकल एस्टॅब्लिशमेंट झाल्यानंतर अचीव टॉप माइलस्टोन्स, लेट बी टॉप माइलस्टोन्स. पुढे येणारं तुम्हाला फुल ब्लेसिंग्स आहे. You will go ahead and hopefully Shipal we are prepared for that actually. So he is there with you, all other members are there with you. Thank you very much. असंच काम करत राहा. कर्जत मेडिकलचं नाव वरती घेत जा. नॅशनल कॉन्फरन्स यांनी तयारी ठेवा भविष्यामध्ये. विल कीप अ नॅशनल कॉन्फरन्स ऑल्सो, डोंट वरी. ओके, थँक्यू व्हेरी मच. हां,
डॉक्टर काळे मॅडम.
सर्वांना माझा नमस्कार. कर्जत मेडिकल असोसिएशनचे आपले एक धुरंधर व्यक्तिमत्व डॉक्टर आशुतोष कुलकर्णी यांनी 2026चा RMAचा पदभार स्वीकारला. त्यानंतर त्यांची जी कमिटी फॉर्म झाली त्या कमिटीने पदभार स्वीकारल्यापासून योगा डे म्हणा, डॉक्टर्स डे, रक्तदान शिबिर आणि जे काही बरेच कार्यक्रम आयोजित केले ते खूपच छान होते. आणि आजची ही RMA कॉन्फरन्स ही तर 2 दिवस म्हणजे लेक्चर ऐकून खूप छान वाटलं. त्यात नाश्ता, जेवण, सगळ्याच गोष्टी चांगल्या होत्या. सुप्रिया मॅडमनी अरेंज केलेला RMA सुंदरीचा कार्यक्रम पण खूप छान झाला. आणखीन एक आवर्जून गोष्ट सांगायची आहे की आशुतोषनी जी कॉर्डेला क्रूजची टूर अरेंज केली त्याच्यामध्ये आम्ही सहभागी झालो 2 जण आणि ती टूर अतिशय छानपणे आम्ही आनंदाने मजेत घालवली. खूप आनंद मिळाला त्या टूरमध्ये. हे एक मुख्य वैशिष्ट्य आहे आणि अशीच टूर त्याने पुन्हा कुठेतरी आयोजित करावी. त्याने कबूल केलं होतं की MA तर्फे आपण आणखीन कुठेतरी जाऊ. जसं अमित ओसवालनी बाली टूर केली होती ती आमची पहिली इंटरनॅशनल टूर होती. अशाच आणखीन टूर अरेंज कराव्यात आणि KMA बरोबर RMA सुद्धा वृद्धिंगत व्हावी ही ईश्वरचरणी धन्वंतरी चरणी प्रार्थना. आजची ही कॉन्फरन्स खूप छान झाली. सगळ्या सगळ्या माझ्या महिला सहकारी MOC करणाऱ्या सगळ्यांनी खूप मेहनत घेतलेली आहे ह्याच्यामध्ये. मी यावेळेला काहीही मेहनत घेतलेली नाही आहे RMAसाठी. याचं मला थोडंफार दुःख होत आहे कारण मी याच्यामध्ये जास्त सहभागी नव्हते घरगुती कारणामुळे. पण कॉर्डेला क्रूजची टूर अतिशय खूप आवडली, आनंदाने साजरी झाली. मला खूप आनंद आहे त्याच्यात. आणि त्याच्यामध्ये आशुतोषची आईसुद्धा आली होती. त्यांनी जी कॉर्डेलावरती कविता केली आहे ती आपल्या RMAच्या बुलेटिनमध्ये पण आहे. अतिशय सुंदर कविता म्हणजे पूर्ण टूरचं सगळं वर्णन त्याच्यामध्ये त्यांनी केलेलं आहे. आशुतोषच्या आईसाठी आईला माझा पूर्ण नमस्कार, साष्टांग.
सगळ्यात महत्त्वाचा भाग आशुतोष, प्रशांत, कुमार आणि मगाशी प्रशांतने सांगितल्याप्रमाणे दिलीप हे काय वाऱ्यावरती सोडलेली लोक नाही आहेत. तर मला असं वाटतं एकदा ज्योती, नम्रता आणि रीनासाठी जोरदार टाळ्या होऊन दे. आणि पायल, सॉरी. तर हा जर विश्वास नसता घरच्यांचा तर आज हे नसतं असं मला वाटतं. तर त्या स्पिरिटसाठी एकदा जोरदार टाळ्या देऊया. आणि बंपर ड्रॉ काढायचं आहे ना का आम्ही घेऊन जायचं? तर मी अध्यक्षांना विनंती करतो की त्यांनी बंपर ड्रॉ काढावा. कदाचित साजिदला लागेल असं वाटतंय. नाही रे, त्याला मिळू दे. एक महिना वापरणार होता आम्ही. डॉक्टर निलेश गायकवाड. निलेश गायकवाड 1, निलेश गायकवाड 2, निलेश गायकवाड 3 बाद. डॉक्टर हेमंत शेवाळे 1, 2, 3 बाद. जस्ट एक मिनटं, जाऊ नका. लेट अस राईज फॉर द नॅशनल अँथम.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा. विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा. तव शुभ नामे जागे तव शुभ आशीष मागे. गाहे तव जय गाथा. जन गण मंगलदायक जय हे भारत भाग्य विधाता. जय हे जय हे जय हे जय 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 हे.
भारत माता की.
Raicon organizing team, photo. Ganesh, Mahesh. Photo. रायकॉनची पूर्ण टीम प्लीज जाऊ नका कोणी. आपल्याला ग्रुप फोटो घ्यायचे आहेत.
बोल ना.